Let's try to stay as interactive as we can. I'm going to put the chat right in front of me, the screen that I have here. And let's stay as interactive as we can. If you guys don't know the answer, of course, I'll definitely fill in and I'll explain. But nevertheless, let's start exploring. Let's start looking at these subjects. So, okay, we're recording now. Let's start it off. I was explaining how the hypothalamic pituitary gonadal axis basically stimulates. It will stimulate from the hypothalamus to the pituitary to the gonads in order for you to then release certain types of hormones, right? Sex hormones. So, something very important that we want to acknowledge is that these sex hormones, they operate on a basis of intracellular type of receptors, right? You have intracellular types of receptors. So normally what it would end up happening, if we look at the idea of, let's say, testosterone, for example, let's use testosterone. Testosterone itself will have permeability to the membrane. Why? Because testosterone, just like estrogen, just like these other types of hormones, are derivative of cholesterol. They derive from cholesterol. So, yes, you will have, just because they're derivative of cholesterol, they share similar properties when it comes to their structure. They're able to have permeability and cross right through without any issue when we look at the actual membrane. Once they enter in the inside, their actual receptor, let's say, is being occupied. Yes, somebody's taking the space, somebody's sitting on their receptor that they want to bind. This receptor, we were mentioning it earlier actually, is called the heat shock. Well, actually, the actual molecule that's taking up the space is called heat shock protein. So you have to displace your heat shock protein in order to bind the intracellular receptor that testosterone needs to bind, right? In order to gain access into the nucleus. Inside the nucleus, you'll see that we have genomic, say we have our genome, and there's several types of genes that we should express if we want growth. So testosterone, estrogen, any kind of, let's say, anabolic type of steroid hormone. These type of things that want growth. They want to stimulate, let's say, either cell differentiation, cell growth. They're big on that sense, right? Remember that the estrogen is very important when it comes to building the endometrial wall. You need to have a proper amount of estrogen for that. So it makes sense what I'm saying here when it comes to the proliferation, right? They always want growth. And this is their intrinsic function, how they actually operate. Now, there's going to be one, let's say, there's these type of hormones that are kind of like peptide hormones, and they actually use intracellular receptors. This is the exception. So we have to know the exception of everything. If we're talking about one thing, we have to include all exceptions. So here, what is the exception? All hormones I just said that just permeate right through the wall use intracellular types of receptors. Specifically, I mentioned the displacement of HSP, heat shock protein. That displacement allows for binding of the intracellular receptor and then activity inside the nucleus in order to have anabolic growth. Now, all I'm telling you is this. Out of all the intracellular types of, let's say, hormones that we have, there's one that's a peptide. There is one that's a peptide. Who knows? A peptide hormone, I'm saying. Who knows which one that is? Who knows? Let's see. Let's see. This gets a little bit more tricky here, of course. Asking hard questions. I am conscious that I'm asking hard questions. So let's see. Where is the chat? TSH, insulin. Good guess. I'll tell you right now that that's a really good guess for that sense. But I'm going to put a list of intracellular receptors right here on the screen, and I'll tell you which one exactly. So it could all make sense. Intracellular, and this is a little mnemonic. I know it's a stupid, corny kind of mnemonic, but hey, it works. I can remember this. Yeah. Yeah. Pet the cat. How do you know that, Sophia? Sophia, how do you know that? I thought, yeah. Oh, first aid. Oh, okay. Oh, wow. I'm here thinking I have this mnemonic laid out in my mind. But okay, this is first aid mnemonic. That's cool. Pet D cat. Do they have the D in the middle? Pet the cat. Okay, so yeah, pet the cat. That is true. That is an intracellular type of process. All these have their intracellular type of protein that they need to bind, right? That makes perfect sense. So the only one here that we can see that actually comes from a derivative of tyrosine, remember, T3, T4. T3, T4. Remember that during the process of uh, thyroid hormone synthesis, remember, during this process, you have tyrosine. And tyrosine, you can find it on the TG, on the thyroid globulin. You'll find a group of tyrosine. And it's a very important process where you're actually getting to add iodine, iodine onto this tyrosine, right? You're adding it on. This is very important. This is a very important step that has to happen. But nevertheless, this T3, T4, T3, T4 that will be made towards the end. Remember, you have the process of organification. We have the whole idea of iodination. This is we have we have oxidation, iodination, and coupling, also known as organification. These processes right here, in order to make your T3, T4. Just a reminder. So, let's say tyrosine has to undergo this process. This is done via tyrosine peroxidase. So just recognize one thing. T3, T4 are coming from protein. Potassium iodide impairs the separation of thyroid globulin. So you'll notice that, yes, you could actually stop this process from happening. There's other things as well. I can just tell you this. How about this? Giving a whole bunch of iodine will stop this process through the Wolff-Chaikoff reaction. Remember, if you give too much iodine, then the increase will cause basically a regulation where you turn it off. You turn off the incentive to make more T3, T4. But nevertheless, to answer my question, T3, T4 is a peptide type of hormone, right? Because it comes from the amino acid tyrosine. This is the exception in this whole entire list. One thing that I'll tell you, always remember the exceptions, because a test writer can try to use the exceptions to try to ask you questions and try to see if you know your stuff. Amiodarone. Amiodarone is a drug that has iodine in it. So it can cause a Wolff-Chaikoff reaction. But if you have a patient who basically, let's say the Wolff-Chaikoff reaction isn't working with amiodarone, for example, you can have a Jod-Basedow reaction. So what's the difference between the two? Jod-Basedow reaction and Wolff-Chaikoff reaction. Wolff is protective. Wolff is protective. It's a phenomenon where you end up having a lot of iodide. So the increase in iodide tells the cell, hey, tells the follicular cell, hey, let's not make more T3, T4. We have way too much iodide. And if we just go with how much iodide we have, we'll start to cause an overload, too much T3, T4. So they stop, they turn it off. They turn off the system. So a large amount of iodine, we can definitely say, turns off the incentive to make more T3, T4. But in a Jod-Basedow reaction, this Wolff-Chaikoff is not functioning. In a Jod-Basedow reaction, the more iodine you have, the more T3, T4 you have. That's the difference there. My spelling is terrible. If you guys know me, if you guys take my class before, you guys already know. Spelling is not the best, but that doesn't matter. The multiple choice test, it makes sense. Jod-Basedow. Jod-Basedow is overreaction. So you'll have more T3, T4 whenever you introduce more iodide, right? And then here with Wolff-Chaikoff, it's protective. You have less T3, T4. Right. So the point of what I was saying basically is that intracellular receptors, you're seeing these kind of hormones. Notice the pattern here: progesterone, estrogen, testosterone, 125 dihydroxycholecalciferol. Calciferol is like a cholesterol. It all goes with this idea. All of them are derivative of cholesterol. You can definitely see that they all have to do with lipids, except for T3, T4. This has its own transporter. For that reason, T3 and T4 will have transporters in the surface of the cell that allow T3, T4 to enter in the first place. And then, yes, T3, T4 goes in and binds their receptor, and they. So what's the actual action of T3, T4? That's another question, actually. All from supraadrenal. Well, not aldosterone. Aldosterone, supraadrenal, all that, except for, I would say, vitamin D. Vitamin D is the only weird one. Yeah, they're all from supraadrenal, definitely. So it says, uh, yeah, vitamin D is like vitamin D and the thyroid. Yes, good, Pablo. That is true. That is true. That is the that is the exception there. So, what is the actual function? If they ask you a specific type of function of T3, T4, just to make sure we understand, it'll increase a lot of different effects all over your body. You have a hyperstimulus of everything. Definitely, definitely. Like if we get into it, we'll start talking about the entire body, everything in the world. But one thing we do need to understand is that to get a basic answer, let's say, it's going to increase, it's going to amplify, basically, you're going to have more increase of sodium, potassium, ATPase. ATPase. We could all narrow it down to the common denominator of this: your sodium, potassium, ATPase, which will potentiate your idea of depolarization, repolarization, right? It will cause effects everywhere. It has cardiogenic type of effect, of course. Remember, the heart is made up of pacemaker and non-pacemaker cells. So you will have the pacemaker cells are going to increase the chronotropic effect. So your heart rate is going through the roof. You also have dromotropic effect, which is like the actual effect of the conduction system. The conduction system coming from the SA node to the AV node, and then the Purkinje fibers. All this will be increased to the next level. So if you have, for example, the effect where you are increasing this conductive activity, patients can have an AFib. AFib can be seen, atrial fibrillation, irregular on the EKG. So the QRS, those R's are not falling in consistent areas. You'll see that one R is falling like this, the next R is all the way down here, making no sense. And you can't even find a P wave. If that's the scenario, if that's the case, you can definitely say AFib. Now, what should we do if we ever find a patient who has AFib? If we're diagnosing AFib, we went down the proper channels. We saw that the patient had a narrow QRS. We also saw that the patient had no P waves, irregular. Okay, we have enough to give the diagnosis. What's next? What should be done? Find out how much time he has had it. That's a good question. Yeah, that's a good assessment there. You find out how much time he has had it. Let's say he says, "Well, I don't know. I just live my life drinking Red Bull and this new drink here, Celsius, drinking these drinks all the time. I don't know. And you say, okay, well, we don't know how long he has had it. So therefore, we have to do an echo. We have to check to see if he has a huge thrombus, a huge piece of clotting material sitting in the ventricles. Because if he does, and you are not addressing it, that can be dangerous, right? You want to make sure he doesn't have this. And then after you make sure he doesn't have this with an echo, so I would say echo definitely, then you want to see what the cause can be related to. You want to be able to do a TSH type of test where you're testing your thyroid panel, where you're testing T3, T4, TSH. Why? Because this can just be some kind of reversible effect. This can be an actual thyroid storm. Too much T3, T4 can cause these type of atrial fibrillation. So this patient might actually just be having a thyroid storm. You have Graves' disease, let's say, for example. You have Graves' disease. And this Graves' disease is manifesting itself with these cardiogenic type of properties, cardiogenic problems like an AFib. Okay. Sinus tachycardia is what you could also see in these kind of cases as well. There can be so many different kinds of problems, but always good to relate this with AFib. Okay. Okay. So let's say, for example, we do this radioactive uptake scan on the patient. We're trying to see how it looks based out or the reaction. Yeah. Okay. So they're switching up the jod with the Graves. Definitely, I'll tell you one thing. If the patient has some kind of pathological situation, scenario in the thyroid, usually the Wolff-Chaikoff reaction will not be functioning. So if he is exposed to higher amounts of iodide, usually if he already has some kind of existing thyroid issue, if you, for example, come into the scenario where you're having increase in iodide in a patient who has Graves, you will exacerbate. You will definitely have a larger amount. It will cause like a job-based style reaction where you're having more and more release of T3, T4. So I'll tell you what exactly as well. If that's the case, let's say, if the patient has an increase in uptake, you'll see that the increase will demonstrate itself diffuse. Like if we look at these scans, you'll notice there'll be a very dark color everywhere. It'll be very diffuse all over. It's going to demonstrate the idea of reuptake. It's taking, not reuptake, uptake. It's taking up the iodine, making more and more T3, T4, right? That's what we should expect to see in this sense. Let's say we think it's Graves and we do a uptake, a radioactive reuptake type of test, and we end up seeing that it comes off like this, let's say, with this pattern. It comes off dark, but in one area, just one area. One area. What do we call that? What is the diagnosis here? Toxic adenoma is correct. Yes, yes. This is a toxic adenoma. This is just one type of irregularity going on, hogging up all the iodine in the system, pulling it into itself, making sure, hey, I am the one who's going to take this iodine. I am the one who's going to release TSH. I'm sorry, T3, T4. Basically doing this in that sense. Does that make sense, everyone? That's a toxic adenoma. Yes. Yes, perfect, perfect. That is the case. That is the case. Yes, it is. Definitely. So typically, though, you'll see that one thing that I can tell you is that the clinical vignette tends to start differently with the two different patients. For example, a patient who has these kind of problems on top, the Graves problems, they are complaining of palpitations. They're complaining of not getting any rest, losing weight. They're complaining of all these type of things. In the bottom here, the nodule is concerning. A lot of patients will come in asking about a new nodule that they have at the level of the neck. Yeah, bone pain, definitely. All these different types of problems. So this is understood. Here we can understand all this type of the problem, right? Now, if the patient is experiencing a thyroid storm, you want to mitigate this as much as you can. What type of drug can we give? Who remembers? Who knows this? So we start off a little easy. We get a little harder. We'll jump into more topics, but beta blockers, propanolol, to be exact. Yeah, beta propanolol, definitely. Propanolol inhibits what at the periphery system? Who can tell me? At the periphery system. Joey says 4Ps, 5-iodinase, peripheral transformation from T3, T4. Perfect. Perfect. Yeah. Definitely, that is true. And it also has a protective action upon beta 1 as well. Right? So you're seeing that this is going to happen in that sense. That's perfect. That makes perfect sense. So we are concerned many times because of the electrical activity, but let's also take this into consideration. So let's draw this out real quick. Look at this chart right here. In cardiac loops, for example, when you're looking at something like this, you're seeing that there is going to be basically, let's say the volume is volume. The volume always represents, and then y-axis represents pressure. Pressure. So for example, let's say, for example, we have the heart at this point where it's getting filled. You have that rapid filling. It's basically getting more and more volume. The point is this. At this point right here, the very end of this process, right before you have systole, right before you have ventricular systole, right before you have isovolumetric contraction, which happens here. Let's be very clear in this sense. Isovolumetric contraction happens here. Isovolumetric contraction. That is systole. That is QRS. That is QRS. That's the ventricles contracting. That happens at this point in the cardiac loop. Here, for example, if the patient is experiencing a hyperstimulus like we have on T3, T4, like we have in thyroid storms, like we have in an adrenaline rush, like we have in pheochromocytoma, there's many different things. All I'm going to tell you is that if you have an increase in inotropic effect here, there's drugs as well that can cause increase in inotropic effect increasing here, like digoxin, for example. Increase in inotropic here at this point, I'm going to tell you that the pressure is going to be very high. But what I am also going to tell you is that you will be consuming more oxygen. So let's be keen on this. More oxygen will be getting consumed at this point. more oxygen. So your oxygen demand at this specific area will increase. If you limit, if you have limited perfusion of let's say limited perfusion due to atherosclerosis, let's say there's some kind of clotting here that's going on. No, not clotting. Let's just say arteromas are limiting the amount of perfusion that you have, and your demand is very high. This can cause angina. This is the idea of causing angina because of an increase in demand, right? When you increase your demand, you are increasing the oxygen that will get consumed in the isovolumetric contraction. So while this happens, if this is going to cause an ischemic problem, it will reflect on the QRS. The QRS will reflect this problem. This is when patients, let's say, and it's going to be on a spectrum. Let's say patients have a complete occlusion, a problem where they cannot access their oxygen. Notice how this will cause a STEMI, right? ST elevation problems. Just want to see it in this sense. So definitely remember this idea. Remember this, that in this point, you are having oxygen consumption going on during isovolumetric contraction in order to create enough pressure in that ventricle to overcome the threshold. So yeah, we went all cardio here really quick, just letting you guys know how everything connects. So in thyroid, let's say you're having an increase in all this type of activity. Your oxygen demand is very high. So beta blockers make sense because beta blockers decrease the oxygen demand. Beta blockers decrease your demand of oxygen during isovolumetric contraction, therefore decreasing inotropic effect, helping you out in this manner. Does that make sense? Does that make sense, everyone? Are we flowing? Are we flowing? Good, 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 good. Awesome, awesome, awesome. Perfect. Okay. So remember that. Remember that idea of QRS and oxygen demand. Definitely super important. That's what we see when we come to think about thyroid. Now, something else about thyroid. Let me also include this. If certain tissues undergo some type of inflammation, let's just talk about the generalized idea of inflammation. When there's an inflammatory response going on to any type of system that we have, what will end up happening is that we have swelling. So when swelling occurs, the membrane starts to get more permeable. You have higher levels of permeability on the membrane. That's what we recognize. Now, if this were to happen, for example, let's say to the liver, you'll have leakage of liver enzymes, right? And then we'll be able to use that as a marker for reversible type of damage. You'll see that the liver is getting damaged. Now, for the thyroid, it's very specific. It's kind of weird. But remember, we have these follicles, these thyroid follicle cells, and you have a lumen of the follicle. Remember that things need to be transported inside in order for it to basically for thyroid globulin to actually build up and make your T3, T4. Yeah, to join the tyrosine, definitely, awesome. So here, what we see is that the swelling, when the swelling occurs, whenever you have a thyroiditis, an inflammatory response of the thyroid, you will start to leak out your T3 and your T4. It starts to leak T3 and T4. It starts to leak off. And not only does your T3, T4 leak, but a very important point here that I'll make, especially for anybody who's thinking about taking step 2, this is something that also we need to acknowledge when it comes to the clinical labs. Remember that we have TG. We have TG located in these areas as well. So TG would also leak off. It will leak out. You have TG, T3, T4. Okay, perfect. So we can see a patient who has manifestations of hyperthyroidism just because he has inflammation of the thyroid. Okay, you guys understand that inflammation of the thyroid in this scenario is leading to a hyperthyroidism. But we don't have a perpetual, let's say, reaction where it just continues happening. Why? Because T3, T4 is limited. There comes a time where it's going to decrease. There comes a time where all the stored T3, T4 that you have in here, it's not basically going to stay there like a perpetual activation. This is what we see in Hashimoto's. Remember, in Hashimoto's, you have that initial phase where it's hyperthyroidism. And as your thyroid keeps on leaking T3, T4, it gets to a point where there's no more. And now you have Hashimoto's. That's how the reaction happens. The very early phase, hyper. Later on, hypo. That should make sense for everybody. Now, something I'm going to tell you as well to distinguish, because it gets very difficult to think about the differential diagnosis. I'll tell you a scenario. Think about this. Imagine somebody has read an article, and you see, oh wow, if you take thyroid T3, T4, you're going to lose weight. So a lot of people start jumping up and just taking thyroid medication, thinking, oh, this is great. I'll just take this thyroid medication consistently, and I should be able to lose weight. I should be able to stay up all night and be able to study more and do all these crazy stuff. But what ends up happening? You end up having a lot of basically problems, tachycardia, all the problems we mentioned. But let's say there's a patient in front of you and you want to find out, is this a thyroiditis or is this an exogenous use of thyroid? The one factor that we can use here to distinguish the two, to differentiate the two, will be the thyroid globulin. Keep that in mind. Thyroid globulin. This can be used to differentiate those two things. Because exogenous, you're giving levothyroxine, let's say. Let's say you're just giving T3, T4, let's say. You are not also giving thyroid globulin. Thyroid globulin is not really even supposed to be outside of the thyroid. So if it is a thyroiditis, you can check. If you want to confirm to see if it's a thyroiditis, you can check the levels of thyroid globulin. Does that make sense, everyone? I'll tell you the exact levels right here. I had it on the algorithm that I was making early. Well, a while back, I mean. Let me show you guys this. That makes sense, right? I mean, you're leaking it. It's leaving that area. And it's like, well, if you're taking it from the outside world, if you're just self-medicating, for example, you shouldn't have thyroid globulin at a higher range. So take a look at that. The range is 1.40 to 29.2. It's not something you should memorize. It's not a big deal. It's just used for the thyroid globulin doesn't increase in exogenous. Nope. Thyroid globulin is a protein that shouldn't really even leave the thyroid. It stays in there. It stays in there. And in exogenous usage, you're just straight up giving T3, T4 to the patient, right? Exogenous usage. So thyroid globulin shouldn't be leaking off in that sense. In euthyroid diagnosis, no, not really, because the euthyroid diagnosis, for example, yeah, it wouldn't be useful in that sense. Here, you're only differentiating it from one thing, from the idea of someone taking it from the outside world. So, yeah, T3, the others should be normal. Yeah, and this is seen in the comorbidities as well. You see that patients with comorbidities are going to demonstrate like that in scenarios like sepsis, scenarios where, yeah, definitely you will see these type of issues. So remember that, guys. Remember that. Yeah, definitely. Yeah, thank you. That is perfect. All right. So what else? So yeah, getting into that, definitely remember that. That makes sense. Let's see. So okay, we talked about the exogenous use. Let's go back into the endocrine world, the world of endocrine right here. So wherever we lose our, let's say, mold, we get back here. So hypothalamic pituitary gonadal axis, we spoke about that. That made sense. The whole idea of the steroid hormones, how they work intrinsically. Then we talked about thyroid. Let's see. So yeah, there's so many. Let's look at the kidney really fast. Let's jump to the kidney. So the kidney itself, wow, there's so much endocrinological, let's say, procedures that can go on here at the level of the kidney. So first off, name some kind of hormones. If anybody can name a couple. Let's see some kind of hormones that are related to the activation of the endocrine system at the level of the kidneys. Let's see. There's so many of them. PTH. Let's say PTH. PTH does work on the kidney. Yes, it does actually has function on the kidney. It does. ACTH. Okay, so yeah, if we want to go to the supraadrenal, yeah, I want to go to supraadrenal. Let's go that route. Renin. Yeah, we have renin activity. That's a really good one. Vitamin D. Yes, vitamin D activation, right? Vitamin D activation. EPO. Yeah, there you go. That's key. EPO, definitely. Definitely EPO. Those are the parenchymal cells of the kidney. The kidney itself has a system that can activate EPO. I think we talked about this a while back. The idea of something called HIF, hypoxia-inducing factor. Hypoxia-inducing factor has the process of well, there's something called VHL. VHL, yeah, we spoke about the idea of VHL. VHL keeps this HIF shut down. It shuts it down. It's like a tumor suppressor type of protein. It's shutting it down, and this is through the process of ubiquination. So let's remember. Now, this is awesome because in medicine, if you learn your concepts pretty well, you don't have to consistently study them over and over. It's just if you know the idea of ubiquination, the idea of tagging a protein in order for that protein to undergo degradation, then you can just apply that concept here. The idea that whenever we have old proteins that accumulate, yes, chromosome 3, von Hippel-Lindau, that chromosome 3 has the expression of this VHL protein. The VHL protein, what is it? It's a ubiquination protein. It has ubiquination properties. Yes, the ubiquination properties. So what is that? What in the world am I even talking about? Well, let's explain it properly. If you have proteins that are very old inside a cell, proteins that have to go, they have to go. Their time is already expired. It's like, hey, what are you doing? You're just accumulating yourself here. You guys are just causing problems because you've been here for so long. So let's get you out of the way. So what do? They have to tag it first. You have to identify it and say, hey, you are no good. We need you in the trash. So in order to tag it, you have the process of ubiquination. This is an ATP process, so it does require energy. But in this process, you'll tag the protein, and then you have something called protease. Protease will be able to grab that protein and break it into fragment pieces. Break it down into fragment pieces. That's what we have here functioning at that sense. This proteasome is super important for this digestive process, right? You break it down. That's perfect. That's why our cells maintain themselves very clean, very nice surface. You can't have a messy cell on the inside. You can't have a messy cell. Your cell has to be clean. If it gets really messy, then you start to accumulate something. You start to trigger something called P53. P53 is a pro-apoptotic type of protein. It actually stimulates apoptosis. It goes to the mitochondria, right? And it activates these type of proteins that are not so nice. These proteins can start to attack the mitochondrial membrane. They're called BAX and BAC. So it stimulates this. So this can attack the mitochondrial membrane in order to then release something called cytochrome C. Cytochrome C. And remember, cytochrome C triggers caspases. This is the intrinsic process of apoptosis. But also, P53 has to inhibit something called BCL2, right? This is a very important type of protein. This is a protein that's protective. It protects the mitochondria. So you have to inhibit the protector as well in order to have this process happen. So, okay, that's just in case. That's just in case the protein starts to accumulate, just in case the proteasome activity is not functioning, right? This is what we can do in that sense. So just to let you know, induces back and back. Yes, it does. Definitely. It has to. It has to induce back and back and inhibits BCL2. Definitely. So that's the system that you have here. And what triggers P53? So many different things. It's like if you're not maintaining cleanliness inside that cytoplasm, P53 will activate. So what do I mean with cleanliness? I mean, if you're having all these proteins that are accumulating there, causing this problem where they're just there in that cell. Now the cell has the idea, hey, our time has gone. We can't clean up these proteins. We can't wait till they accumulate. Let's just cause apoptosis. If you have toxins that are accumulating, if you have, let's say, free radicals that are accumulating, if anything that's going wrong in this cell, the cell always has the option to induce apoptosis in order for a clean dissipation, right? You don't want to have all this storage of protein here. So you're able to do this with the triggering of P53. Okay? Remember that. P53. Okay, so also, let me just include one last thing. I want to overwhelm you with information, but I'll include one last thing as well. P53 as well, when it chooses to do apoptosis, it also has to choose to make this cell, specifically the cell that's going to go apoptosis, it has to make sure that this cell cannot replicate because it thinks to itself, I can't have this cell that's just in the borderline of undergoing apoptosis. The last thing we want to do is have this cell replicate, right? This cell is about to go. This cell is about to get eliminated from our body. Why would I want to induce a replication cycle to this cell? That's not going to happen. So it stimulates something called P21. And P21 basically is an inhibitor. So you're activating an inhibitor, not allowing the P21 to basically, well, you activate an inhibitor. So it inhibits the process that will trigger transcription. So down the line, yes, transcription. I'm not going to go too deep into it, but it has to do with the RB gene. It has to do RB protein and something called E2F, not elongation factor, guys. It's called E2F. RB has to get phosphorylated in order for E2F to be left alone. If E2F is left alone, now we have transcription. I think I just confused everyone. That's the reason why I didn't want to go too deep. So I'm just going to leave it here and just tell you guys this one thing. RB for retinoblastoma. Yes. Yes. So RB protein is a protein that is a gatekeeper. It's gatekeeping E2F. If E2F is by itself, then we have replication. If E2F, so let me just be very clear here. If E2F is ever by itself, it's like it has mitogenic activity, meaning that when it activates, it will induce replication. So the cell cycle continues. You go into S phase. You get into S phase if you stimulate, if you allow this to go in there. If it stays by itself, it stimulates the S phase. So we make sure this doesn't happen by having RB attached to it. RB makes sure that, hey, don't even look at that. Basically, you're not going to undergo replication. So whenever we actually phosphorylate RB, we then have isolation. Isolation will occur. RB will be by itself and E2F will be by itself. That's the problem. Whenever E2F is by itself, activation. So just letting you know, P53 makes sure that RB stays attached. It makes sure that RB does not get liberated from this E2F. RB gets liberated by something called cyclin and CDK. Cyclin and CDK have to come together in order to phosphorylate this. So P21 has to do with making them come together. So what you're doing here is that, well, P21 stops them from coming together. So P53 is stimulating P21. Okay, I successfully confused everyone. I think this is why I don't like to go too deep into all these information, but all I'm telling you is this. P53. So what is the job of P53? Really quick. The job of P53. It causes apoptosis and it makes sure that you cannot replicate that cell that's going to undergo apoptosis. It has to make sure it's protective. It says, hey, you do not want, induces back in order to promote intrinsic apoptosis. Because if you induce back, you increase the permeability of the mitochondrial membrane. Increase of permeability will allow for cytochrome C to leak off. If cytochrome C leaves that cell, then caspases will get activated. Caspase start all that blebbing of the nucleus and all that process of apoptosis, which will occur. Okay, understand that. That makes perfect sense. That's good. Now, why in the world did I mention P53? Let me just tell you one thing. Since we were talking about thyroid, let's include everything. Let's be very inclusive with everything we talk about. P53, this is associated with many different types of cancers. I mean, think about it. If you don't not have the power to cause, Lynch is a bit different. Coming straight out of, hold on. No, I think you might be right. Lynch, so go on, let's be very clear. There's something called MSH. MSH has to do with DNA repair. MSH and also another one, which has to do with the breast cancer one, trastuzumab. Which one is the breast cancer? BRCA. Both of these have to do with repair. And if these are damaged, then you can't repair the DNA. Therefore, you start to make DNA that looks really weird. And this weird looking type of DNA structure gets, so this is the vetting system. So yeah, let me just be clear. I don't want to confuse anybody. All I'm telling you is that in the process of replication, you have to vet the genetic material that will be made. So you're looking at the genetic material. If there's any kind of, let's say, error, you can repair this error. But we have several types of proteins that are responsible for repair. There's different types of repairs that you have, homologous, non-homologous. Um, yeah, I think it was Lee Freimanni. Yeah, Lee Freimanni. But okay, yeah, Lee Freimanni. Yeah, Lynch was something else. Um, but for the MSH, so okay, going back. Yeah, going back. In the DNA repair process, if you fail this process, let's say you try to repair your DNA and it comes out weird, this DNA you're replicating now your faulty type of DNA, which will cause mutations and cancers. That's related to this kind of problem here, the DNA repair. So these are cancers coming from DNA repair problems. But then you have also cancers that come from the lack of lack of apoptosis. If you do not have apoptosis to cells that need that apoptosis because they're undergoing some kind of change, they're undergoing some kind of irregularity, you need those cells to undergo apoptosis. If they do not undergo apoptosis, then yes, then you can have these type of cancers. Lee Freimanni, yes, is associated with, let's say, P53. What else though? I could also say P53, anaplastic type of thyroid cancer. Yes, AMNA. Yes, yes. So let's be clear. Thyroid kind of cancers. The mnemonic is PFAM. PFAM. Papillary. Follicular. Anaplastic. Anaplastic has the worst type of prognosis. Why is it the worst prognosis? Well, it has no shape. It's anaplastic. It's causing this problem where it follows no rules. You see what I mean, Pablo? It follows no rules. If you follow no rules, then you can do anything. You're at a point where the more mature you get, the more rules you follow. Notice that life is like this as well. In our life, as we get more mature, we have to follow more rules. It's the same idea with anaplastic. In these cells, if you do not mature, you have no rules. So you can differentiate. You can start perpetually just replicating and more responsibilities. Yes. And more stress, right? So that's what typically happens in this sense. Anaplastic cells, they're immature type of cells that undergo a mutation. Therefore, they don't really follow many rules or they're not regulated under any type of systems. So yeah, they lack P53 regulation. So therefore, they have very bad prognosis. This typically happens to older patients. Older patients, if we're looking at thyroid problems, all these type of cancers can be related to radiation, definitely. But here we're seeing, for example, medullary is the M, medullary. Remember medullary? This is basically medullary cells. Yes, so part of MEN2. If it's part of MEN2, we understand what type of gene is related here. What type of gene is related to medullary? Who can tell me? RET gene. RET gene. Yes. Good. Wow. Everybody's good. You guys are sharp so far. You guys are getting everything. Everything is making sense. Right? Okay. Now, if I ask you about papillary, what two type of genes are related here? Yeah. Why it's better to take out the gland when it's detected? BRAF. Good. So for papillary, we have not RET. For papillary, you'll see it's RAS and BRAF. Yes. Let's look at this. For example, if I try to see for follicular, what is the problem with follicular? So we said this one was P53. What is the problem with follicular? Yeah, KRAS. Good. Well, follicular, remember that follicular cells are the cells that are responsible for making your T3, T4. Remember that the follicle cells. The follicle cells are the ones that will basically slide in that iodine, slide it in there, and then you have your tyrosine peroxidase, which in the lumen of the follicles. That's where you're going to then have that whole pairing process, that iodination, where tyrosine is getting filled up with iodine. That's happening at the level of the follicles. For, yeah, parafollicular cells have to do with calcitonin. If we're looking at that and we're saying parafollicular C cells have to do with calcitonin, that's medullary. Yes. 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 So hold on. Blarina, let me confirm that because let's see. In that sense, we're saying that parafollicular. Yeah, let me name them these properly. Second messenger. One thing that we will say. Let me see. So yeah, okay. Really quick. When we're talking about these type of genes, I can tell you that. Oh yes, yes, you are right. You are right. So let's correct that. Yeah, let's correct that. Let's correct that. Definitely, definitely. Blarina, you are right. You are right. So okay, PFAM. Let's get this right. PFAM. Okay. P will be RET. That is true. It is associated with MENS, right? So RET and BRAF. Now, F is associated with RAS. This one is associated with RAS. So yes, you were right. You were right. You were right. Follicular also has RAS activity. RAS. BCL2. Yeah, let's see, because there's several types of issues that you can have with these. So let's see, but with anaplastic, for sure, anaplastic will have the manifestation of P53. That's the main problem that you have there, anaphylaxis with anaplastic P53. And medullary, we said, was RET as well because it is associated with MENS. So one thing I will tell you that follicular lymphoma. Okay, I see where you're going. Snow. Okay, sorry. I call you Snow. Sounda. Is that your name? Soundaria. Sorry. Okay. Yes. Good. Good. All right. I see where you're going. When we talk about follicular lymphoma, yes, we're talking about the 1418 translocation. Yes, there I will tell you that is associated with the idea of BCL2 gene. Yes, right? We're talking about follicular cancer of the thyroid. At the level of the thyroid, this is associated with RAS protein, Okay, this makes sense. RAS protein is associated with that kind of reaction. Perfect. So 1418, this was BCL2 in follicular lymphoma. Yes. Perfect. Lymphoma. Perfect, guys. Nice. So yes, that is going to be overexpressed in these kind of patients that have this problem. So think about it. I told you guys one thing. I said, hey, if mitochondria, it can be attacked by backs and back. I said backs and back can attack this, but I said it's being protected by BCL2. So think about this. If you have perpetual protection, this bodyguard is there, not allowing this cell to undergo apoptosis. We call that anti-apoptotic effect. So if this here is not allowing anything to happen to that mitochondria, therefore cytochrome C will never leak out of it, this cell has now become immortal, right? This cell has now found a way to never die, to inhibit apoptosis. Because here the intrinsic apoptosis is turned off completely because the overexpression of BCL2 will lead to the characteristics of immortality in this sense. You guys understand that? Yes, the price in exchange is very high. So there's a couple of things that you have to remember when it comes to cancer. I'll tell you guys. Cancers find a way to tap into your telomeres. They make sure that they can perpetually proliferate over and over and over again. That's one thing. The second thing is that they find a way to inhibit apoptosis. That's another thing. The third thing is that they increase vessels. They increase the irrigation towards them, making sure that they have a good access to our nutrients, our oxygen, our ATP. That's why a lot of people are tired. Those people have cancers. Those type of, they call them constitutional-like symptoms where they're basically losing so much weight. That's why, because cancers like this will create a highway with vessels where they can then hijack all our nutrients without any type of regulatory system. They broke the rules. And then the fourth one is the access of uh, metastasis, the access to spread, right? They start to now express less proteins that had to do with regulation, that had to do with the idea of it not moving around. Some cancers, like follicular, for example, follicular thyroid cancer, some of those can spread hematogenously. Cachexia is basically, a lot of cachexia you'll see has to do with tumor necrosis factor alpha. Definitely, that can induce this. But let's remember one thing: there's some kind of hematogenous spread that you can see with lung bone, specifically for follicular renal cell carcinoma. Nice. Yes, renal cell carcinoma can also do this. So hematogenous spread, we have to keep in mind. Yes, hepatocell, definitely. This right here spreads hematogenously. Remember that. So it can go F for far away. It can go far away. That's how I remember. F can go far away. Females follicular cell. Fine needle aspiration does not work with the follicular cells, right? That type of diagnosis here will not work in that sense. Remember that. Remember that. And for papillary, I do remember P for popular is the most popular one. Also remember that P for psammoma body. So I would ask you guys, what are the type of cancers that will demonstrate psammoma bodies? Which ones? Which ones are the ones that have psammoma bodies available? Do you guys remember? Do you guys know? Yes, here we go. Meningioma, mesothelioma, serous cystadenoma of the ovaries. Yes, good, good. Meningioma, all that, all that. Awesome, awesome, awesome. Yes, you see how we're just tapping into so many different parts, remembering everything, tapping into everything. Make sure that you can remember all these craziness. There's so many things, right? There's so many things, but we have to make sure that we can visit them. If not, we tend to forget them. Yes, perfect. We don't want to forget any of that. You want to have that in your mind, ready to just shoot it out. So yes, definitely. So I want to show you guys a little bit of images of some kind of psammoma bodies, and we can take a look at them just to remember how they are. And I'll tell you the actual, let's say, it's a game of semantics when they're describing it, because they might not show you images, they might just describe it. So these are the words that are being used to describe it. Spindle cells arranged in a whorl pattern. They have laminated calcifications. And this is how it looks like. To me, it just looks like roses. If you take a look at it, it looks like a blimp view of roses. That's how it looks like to me. I mean, let's juxtapose these images and let's look at them. I mean, we can, yeah, recently, thanks. This pic you keep showing us. Yes. Yeah. Awesome. Uh, Definitely, definitely. That's what I'm saying. Keep doing questions while you guys are in the drills and in the classes, because everything that I'm getting is basically a lot of it just from questions, from MBMEs, from Free 120, from the Amboss, putting it all together, making compilations and connecting it all. So that way it can connect in your brain as well. So here we're seeing images of like roses from a blimp view. You guys see that? How it basically looks? That's the way I identify them pretty easily. Yeah, it looks like it. If you look at it from above here. Now I even said, hey, yeah, it looks like it, right? Like a histological view for it. It looks like a really nicely drawn rose as well. I thought to myself, hey, what if we change the color? Because some of the images sometimes show you different color, different kind of weirdness. So take a look at this. White rose. There you go. Look at that. So yes, keep that in mind. Onion layers. Oh man, yeah. For me, I guess I'm not that much into the kitchen. All I do is I meal prep a little bit, so I'm not that, kitchen is not my specialty, let's say. So yeah, I just see roses. That's basically it. But yeah, onion roses could work too. So keep that in mind. For onion, I usually see when you see like a hyalination when they're showing you the arterial vessels, and they say, "Hey, there's hyalination of this vessel." That looks like an onion to me. All right, good, good, good. That makes sense. That's awesome. That's awesome. Good. Now let's keep flowing. Let's keep flowing. So we were talking about follicular. We mentioned the idea of follicular and how it works. Let's talk about this then, because men is a crazy topic to get into, the men one, men two, and all that. So if we start to mention men two, we already mentioned different things that can happen here. What happens with men one? What are the types of issues that you can see with men one disease? What do we see with men one? Men one is menin, definitely. Menin. So, what conditions are present in MEN1 disease? Who can bring it up? Who can tell me? Who can tell me? MEN1, pancreas, pituitary, parathyroid. Perfect, perfect, perfect. The three P's, right? The three P's. Definitely, definitely. That's perfect. That's how you definitely remember that. That's perfect. Okay, so that makes sense for men's. So then I would ask you, okay, well, pancreas. There's so many different types of cancers of the pancreas. So before even jumping into that, let me just ask you, well, pituitary. What is the most common pituitary type of adenoma that a patient can have? Who knows? What is the most common type of prolactinoma? Prolactinoma, yes. Prolactinoma can grow and it can start to push the optic chiasm. What does it cause when it pushes the optic chiasm? Who remembers? What type of issues are we having here if you push the optic chiasm forward? Bitemporal hymenopsia. Yes, yes, yes. So the patient will have problems looking at the peripheries. Usually, a question I've seen questions they're talking about patients who are getting into like minor car accidents or things like this, basically. But yeah, that definitely is super important. You have to remember the increase of prolactin. So let's talk about a little bit of prolactin. Prolactin. So prolactin has a regulatory effect. So it causes inhibition of what? I'm going to ask you guys, what does it inhibit? What does this inhibit? GnRH. GnRH is correct. GnRH is correct. So if we're looking at GnRH, GnRH generally stimulates the anterior pituitary gland in order to release FSH and LH, right? FSH and LH. And we said that FSH stimulates Sertoli cells. Sertoli cells. Sertoli. Sertoli, my mnemonic is Miss Sertoli. These are the things that Sertoli cells can do. I have that into my head. Why do I have that into my head? Because there's many times where they would ask about Sertoli and there's like, I need to have that. Like, you don't want to have organic thoughts thinking of what in the world was this and that, because you can get confused when it comes to Sertoli. So just definitely Miss Sertoli. You'll look at it like this. Miss Sertoli has, for example, inhibin. You have spermatogenesis, and you have Mullerian inhibitory factor, right? This is something that we utilize at the point of embryology, right? Mullerian inhibiting factor. Because to be a man, you have to do two things in order to come out male and have the male type of genitalia. You have to proactively stimulate male genitalia, the Wolferian duct, but you also need to inhibit the female type of genitalia. So MIF is important for that. Remember, in order to have this in the first place, in order to have Sertoli cells release this, remember, you need to first differentiate the gonads. So you have to have gonadal differentiation. And this you can do because Y chromosome will have testes differentiating factor. Testes differentiating factor is allowed, what basically stimulates the differentiation of our gonads. SRI. So what ends up happening here is that when you differentiate your gonads, now you're having Sertoli and now you're having Leydig. So Sertoli cell itself, now that you have your Sertoli, you're able to now proactively inhibit the Mullerian duct, which is the female, right? This way, MIF will be doing this, MIF. That way you don't have the uterus, you don't have the, remember it was FUP, the fallopian tube, the uterus, and the proximal part of the vagina. You're able to inhibit this with MIF. But then again, of course, you have your Wolferian duct. And your Wolferian duct, you have to proactively stimulate this with testosterone. Testosterone gets released by your Leydig cells. Leydig. So I'm going to put it and make it very clear. Sertoli is what will release your MIF. MIF. Right? And then your Wolferian duct, you'll have seed. Seminal vesicles, epididymis, ejaculatory duct, and your vas deferens. Boom. So testosterone is what will stimulate this. Testosterone comes from the Leydig cell, and MIF is what inhibits Mullerian duct MIF comes from the Sertoli cells. Hard being a man. You got to do all these different types of activities. You have to proactively stimulate the male. You have to inhibit female. So we have that test. Females by default, you'll see that the embryogenesis is going to demonstrate a female type of, let's say, phenotypic type of representation will be more female by default. If there's lack of stimulation, you'll see that female type of uh, characteristics will be present. Okay. So put this into your mind. Think about this crazy idea. What if, yes, AIS, perfect. Yes, that's exactly what I was going to say. What if we lose sensitivity to our androgens? Then what ends up happening is that we're still sensitive to MIF. So let's be very clear. MIF is not an androgen. It is in no way an androgen. In no way. And it will inhibit, let's say, that female type of characteristic. So in AIS, you do make your Mullerian inhibiting factor, which will inhibit the Mullerian ducts. So yeah, they have the lack of uterus and cervix, right? Makes sense. But when you try to stimulate your actual activity of, you do have latex cells. Let's be very clear. They have testes. The testes are there. Testes differentiating factor worked perfectly. Everything is there. Testes are able to make testosterone without a problem. Testosterone is being made, but your sensitivity to testosterone is gone. So therefore, you couldn't differentiate those Wolferian ducts into seed. So you're having a problem here with these type of structures. Your seed structures are not going to be present. So yeah, wolf will not be stimulated. And then what ends up happening is that as you have now, I didn't even mention secondary sexual characteristics, but there are certain structures that are primitive. And these structures, they strive on estrogen or they strive on testosterone, or let's say dihydrotestosterone, I should say, in order for them to mature, in order for them to then have that phenotypic type of characteristic where either they resemble penis or resemble vagina, right? All that type of structure. Like the clitoris is the best example. Glans, penis for male, female, clitoris. It's the same structure. It's just that it had different types of maturation according to the hormones which it was surrounded with. So hopefully that makes sense. So that's secondary type of characteristics. So guess what? With androgen insensitivity, you don't have any type of male influence when it comes to the idea of secondary characteristics. So full blown, this person will look just like a female. This person will look like a female. This person will have female phenotypic abilities, and it's crazy. Oh yeah, they also remember. So let's remember one thing. Now that you mentioned the fact of hair, let's look at this. Well, it'll have to be like yeah, pubic type of hair, or like let's say hair in the axilla. Let's look at this. Androgens are not all the same. They're in a spectrum. They're in a spectrum. Some androgens are weaker than others. Other androgens are very strong. Like DHT is extremely strong. We're trying to compare it with testosterone. Testosterone, DHT, let's say. But then, of course, you have things like androstenedione, which is highly malleable. Highly malleable. It wants to become something else all the time. Dihydro gives us secondary characteristics of the male type of structure, the structures that we have. Yeah, testosterone, what you'll see here in this sense is that testosterone can also become estrogen as well. So let's also be very clear here. Estrogen, it can aromatize. So actually, I should draw this in the middle so to make more sense, because estrogen can be aromatized as well when it comes to androgen. Androstenedione. Androstenedione is highly malleable. Highly malleable. Estrogen, let's say. That's what you're seeing here. So dihydro basically is associated with male pattern baldness. Remember, there's an enzyme here that makes your testosterone into dihydrotestosterone. Who remembers what enzyme this is? Who can remember this? Who can remember? Finasteride. Yes, perfect. Finasteride is an actual enzyme. Well, it's the drug. Hold on. Yeah, it's the drug. 5 alpha reductase. Finasteride is the drug that inhibits it. Yes, yes, yes. It inhibits it. So let's be clear. Finasteride is what we find in these shampoos nowadays when they want to promote the idea of uh, decreasing male pattern baldness. They would put finasteride all in the shampoos and everything. And the actual enzyme that finasteride will inhibit is called 5 alpha reductase. Reductase. And when it comes to estrogen, testosterone becoming estrogen, we have something called aromatase. Aromatase. They actually call it the aromatization of hormones. Yes, definitely. Definitely. Yes, it's also used to treat BPH, definitely. Remember that we can use prazosin, like these type of alpha 1 blockers, in order to treat. That will definitely, and let's see exactly how. We'll get into that as well. We'll jump into that idea as well, which had to do second line. Yes, I'll tell you. I wouldn't say second line. I'll tell you how it is. For example, you use them together. You use them together, but it's just that one of them is actually like the alpha blocking type of drug, the alpha 1 blockage, like prazosin, terazosin. This will work immediately, right? Because it's addressing the actual vitals, it's expressing itself in that sense. When it comes to hormone type of therapy, it takes longer. It takes a lot longer for this to actually work. So remember that. Remember that in that sense. Um, prazosin, yeah, terazosin for BPH, hypertension, prazosin, BPH only. I'll tell you one problem that you can get with alpha 1 blockers, the orthostatic type of hypotension. This can occur on many patients. Why? Well, first off, what type of patients are having BPH problems? Elderly patients. Older people are having these problems. So the carotid sinus, it loses a lot of sensitivity on older people. So the lack of sensitivity of your carotid sinus will be amplified with a problem of dysregulation. For example, you're supposed to have these vessels responding, they respond to your, let's say, systole. For example, if you have a contraction, the blood that's reaching this level, if it caresses your carotid sinus, if it touches, if it vibrates on the carotid sinus, it'll start to stimulate. It'll stimulate. So let's be clear. Stimulation of cranial nerve 9 causes in the nucleus tractus solitarius in the medullary system, in the medulla of the brainstem, will stimulate a relay effect where you then activate cranial nerve 10. Activating cranial nerve 10 causes stimulus of acetylcholine to M2 receptors. This is how we naturally understand this. And this happens vice versa as well. What do I mean? Vice versa. Vice versa is opposite in the sense that if we don't have enough blood to caress the carotid sinus, it sends an inhibitory signal to cranial nerve 9. Cranial nerve 9 will then inhibit cranial nerve 10. If you inhibit an inhibitor, you end up activating. So this carotid response has both stimulatory and inhibitory effect. If it vibrates on the carotid sinus, yes, if it vibrates on the carotid sinus, then it will activate. When it vibrates, that means we have a lot of blood volume. So let's be very clear. If I am touching the carotid sinus, it's only because I have so much volume that's touching it. Therefore, this touching stimulates, makes the afferent, which is cranial nerve 9, stimulate cranial nerve 10 via the nucleus tractus solitarius on the medullary system. It will stimulate cranial nerve 10. If I stimulate an inhibitor, I am inhibiting. Remember this reaction because it's also vice versa. I'm going to repeat it one more time. Vice versa, it happens opposite. When you have less blood, you tend to not touch the carotid sinus. When you do not touch the carotid sinus, you inhibit cranial nerve 9. Cranial nerve 9 inhibition will relay this information to the nucleus tractus solitarius, which will then relay that inhibition to cranial nerve 10. So if you inhibit cranial nerve 10, you stimulate the heart. So what's the problem here? If I give alpha 1, then it's not responsive to this. I'm not going to say that it's going to be perpetually dilated and activating this problem. It's just not responsive. So what do I mean by responsive? Right now, this carotid response, what it's supposed to do when it comes to managing us properly, it's supposed to make sure that we don't pass out when we stand up. If I stand up right now, yeah, that's another question. You see, Joy, that is a hypersensitive problem. That's a different type. And yes, older patients can get this, but this is not physiological. What I'm mentioning here is more physiological. All of us, as we get older, this gets weaker. But there's a pathological situation that can happen to certain patients that this gets highly sensitive. And as they shave, they're going to have an increased sensitivity, and it'll send such a very powerful impulse to activate cranial nerve 10. Activation of cranial nerve 10 is a stimulus of M2. Remember, M2 second messenger system is GI. It is inhibitory. Yes, increasing the vagal tone. So going back to this idea, if I stand up right now really fast, there's going to be redistribution of blood to my lower extremities. If I stand up right now really fast, there'll be redistribution of blood to my lower extremities. So the carotid sinus will recognize this. It's supposed to. This is normal. This is what happens normally. It recognizes this, so it inhibits cranial nerve 10, let's say. Right? It happens to cranial nerve 9, of course, but cranial nerve 9 is the afferent, sends it to the medullary system. Then cranial nerve 10 gets an inhibitory response. If I inhibit an inhibitor, if I'm inhibiting M2, then beta 1 thrives. So right now, we get up really fast. You put your hand on your heart, you're going to notice your heart goes boom, boom. That's because our carotid sinus are functioning awesome, because we're young, and yeah, I mean, none of us are 80 years old, 70 years old yet. So we're good in that sense. Our carotid sinus is working nicely. So yes, forever young. The problem is, the older you get, the more sensitive your carotid sinus is getting. Yeah, that's what will happen. So with this being said, what else can I tell you? Definitely. So when you take a drug like an alpha 1 inhibitor and you stand up really fast, guess what does not regulate? Guess what will not regulate this whole system? So you can stand up really fast and then pass out, because alpha 1 is not, it's not listening to your ideas of redistribution of let's say of force when it comes to the cardiac output. Remember, cardiac output is heart rate times stroke volume. So here, for example, stroke volume is CAP, is contractility, afterload, and preload. If my preload decreases because there was redistribution of blood to the lower extremities, I need to somehow fix this problem. The compensatory mechanism is with an increase in contractility and an increase in heart rate. That's the mechanism of compensation. This mechanism of compensation is brought to you by beta 1, because beta 1 is competing with M2 when it comes to control of the cardiac dynamics. Does that make sense? So no, GQ second messenger by alpha 1. Hold on. So let's be clear. M2 will have GI second messenger, and beta 1 has GS second messenger. Alpha 1 is going to be GQ. So when we're talking about the actual regulation of the heart, remember, these two types of receptors are GS and GI. When we're looking at alpha 1, yes, alpha 1 second messenger system involves GQ. Keep that in mind. That is 100% true. For the regulatory regulation system of the idea of the vessels, let's take a look at that. The vessels, I call this concept the battle of the receptors, because there's two receptors that are fighting for control. Two receptors that are fighting for control. And you could actually manipulate this by either activating the agonist or activating the antagonist, or inhibiting the antagonist. You see what I'm trying to say? Or inhibiting the activation. This is where a lot of people get confused. I hope nobody gets confused with this, because we have enough time to think to ourselves. Sit down in a room, turn off all distractions, and think to yourself. If I activate an inhibitor, I am inhibiting. If I inhibit an inhibitor, I am activating. This is something that in medicine, it's found everywhere. If you're able to flip that vocabulary in your mind fluently, if you're able to say, activation of inhibitors or inhibiting an activator of an inhibitor. Like, what does that do? Does it inhibit or does it stimulate? If you're able to iron all this craziness out in your brain beforehand, it really helps you in an exam because you do not want to be an autopilot trying to distinguish this in a question, right? That you're being timed. Yes. Plus equals plus. Negative times negative equals positive. Yes, that's also true, Marianne. Yes. Like in DNA methylation. Oh my God. That is a hell of a question. They love throwing these type of questions. That's another type of vocabulary, another type of trick that likes to get used. What do we mean with DNA methylation? There's a vocabulary that gets used, guys, with methylation. Methylation, M equals muting. M equals muting. So listen to this, Paulo. This is kind of crazy, but M equals muting, acetylation equals activation. So what are they going to do in an exam? They're going to try to mess with you and say demethylation, right? Or activity or increased activity of deacetylation, or decreasing the enzyme responsible for deacetylation. That's where things start to get confusing now, because you're thinking to yourself, are they talking about activation or are they actually talking about inhibition? So let me show you guys a little list I made of these crazy kind of words to try to iron them out before. I made this a long time ago. Well, not a long time. It feels like a long time ago. But I do have this list. Let me pull it up. These are in my notes. This will definitely show you the difference. So here, let's say, yeah, share your goal. Definitely. We have to share. We have to basically get this information out there. Let's see. Where did I put this? Let's see. Oh, I know where I have it. I know where I have it actually, because I did send this off to a group. This was in a uh 1 second, guys. Let me pull this up. Give me 1 second. This was here. Um yes. Definitely. Let me show you guys. Oh. And where in the world is it? Hold on, give me 1 second. I have to find this now. Now I have to. So yeah. So much of this was made, so it has to be. Let me see. 1 second, guys. 1 quick second. Okay, yes. Oh wow, this is how I found it. I mean, yeah. Let me perfect it a little bit more. Yeah, let me show you guys. 1 second. Okay, I wrote all over it in this image. Okay, I can find it clean. Yeah, there it goes. Found the clean version. So I'm going to show you guys this. This is the vocabulary here that gets used. So we have to learn how to differentiate this vocabulary. Look, methylation equals mute. Methylation equals mute. So if I tell you that I have an increase in methylation of some kind of genetic material, increasing in inhibition, basically. So what do I mean, first of all? So yeah, let me present this the proper way. Let me present this topic properly. We have chromosomes. If we take a microscope and go deeper into this chromosome, like what it's made out of, all we see are squiggly lines. If we are able to pixelate this and make these squiggly lines finally look very clear, you'll notice you'll have nucleosomes. Nucleosomes. This is packaging the DNA material. If we're able to now zoom into this nucleosome and iron it out to look at all the type of genetic material that we can find here, we're going to see it like this: helical DNA structure. Helical DNA structure. So this is the same thing. When we look at these kind of chromosomes, it's the same idea of DNA. It's just the fact that this here is at a macroscopic level, and here you're getting smaller and smaller. That's just the idea. We were getting closer. We're zooming in. We're zooming in. Okay. So one thing that I'll tell you, though, is that the language that's being used here for activation or increased expression of genomic structure will be either acetylation or methylation. So let's look at that. If we're looking at something and saying that we're saying that there's a high level of activity, then I can tell you that there's a high level of acetylation towards this type of genomic material. Now, if I tell you that there is basically, let's say, acetylation, it's going to look very, for example, light. When there's methylation, you'll see it'll be very dark in that sense. So areas that are dark are going to be areas that are methylated. Areas that are light are areas that are going to be acetylated. Yeah, acetylation. So okay, let's get this very clear. So mute will suppress. So if they use the word suppression, they're talking about methylation. If you see them use the activity of DNA tightening, if the DNA is very tight, that means that it has not been opened. Remember, you need to open up your DNA structure in order for you to have any kind of binding or any kind of activity of promoters and enhancers or silencers. In order for you to intervene with this activity, you have to be able to have access to it. So it has to be relaxed. Relaxed DNA is the type of DNA that you can manipulate. If it's tight, then it's not going to be able to have any of this binding in the first place. Okay. Heterochromatin, this is also description here of things that are not available to you. Euchromatin are now going to be available for your usage. So this is a decrease in transcription for anything that is undergoing the process of methylation. Methylation. And then you have, for example, this is the opposite. So how would a question approach you with this? I'm telling you right now, you might think to yourself, hey, looks so simple. This looks so simple. But when you look at a question, they'll tell you about a protein that increases demethylation is unmute. Therefore, it's activation, right? Demethylation is activation. And then deacetylation is, what's deacetylation then? Inactivation. Good. Perfect. That makes sense. So what type of disease has this as its major pathophysiological effect? What disease are we looking at when we look at this and we say it's associated with a type of disease? What's the pathogen? Huntington's. Yes. This is basically the idea, the expression of these type of proteins have this problem, right? The deacetylation activity. It's a deacetylation protein that it has. CAG repetition, right? The trinucleotide type of repeat will impair this enzyme function. There's an enzyme there that functions in order to cause this deacetylation. So that's the type of problem that you have with Huntington's. Let's see if I can pull up that image. There's an image on UWorld for this. See if I can pull it up. Huntington. Yeah. It's pretty awesome there when you start to understand everything about it. It all starts to make sense. So Huntington's has that issue. But yeah. What else can I tell you here? Yeah, this is basically what you'll see in this sense. Yeah, that's the idea of activation versus inactivation. But going back, this was just semantics. We were just talking about the idea of activity of stimulus versus inhibition. Definitely. So, for example, I can give you a good example of this when it comes to the lungs. Repetition, water flow. Yeah, we ended up somewhere in biochem right now, molecular biology, when we were just talking about receptors. But nevertheless, definitely, that's what you see here when we're talking about this type of stimulation. Now, alpha 1 we said was GQ. Alpha 1 we said was GQ. So there are certain types of things that operate from the basics of GQ. So let me pull up this list so we can look at the GQ type of systems. GQ uses what type of protein kinase, everyone? Everyone should know this. At this point, this should be something that we all understand. C, right? Protein kinase C, phospholipase C. All this type of activity should be used with GQ. Now, GQ, I have this mnemonic here. I invented this mnemonic. I don't think anybody else threw this in there, but I'll show you this. DAG got 1/2. So what do I mean by that? What do I mean by that? Well, of course, if we're looking at the second messenger system, we're looking at a system of PIP, which splits into, PIP2 has to split into two different things. So I remember DAG has 1/2. DAG has 1/2. So it's half of the splitting is DAG. The other half is IP3. All right. So notice this. The IP3 is what will have the increase in calcium. Calcium release from the endoplasmic reticulum or the sarcoplasmic reticulum. That's happening because of IP3 in this sense. Calcium. So I remember the ones that are associated with number here are associated with calcium because calcium has a 2 on top of it. Now, DAG doesn't really have a number on top of it. That one is activation of protein kinase C. Protein kinase C. That makes perfect sense. And protein kinase C tends to activate calcium calmodulin complexes. It basically causes phosphorylation of proteins. That leads to activation of transcription factors. This is what happens in the world with all these different types of hormones. So GnRH is what we were talking about earlier. We said GnRH is inhibited by prolactin. So prolactin can inhibit GnRH. GnRH utilizes GQ type of process here. So GQ is the second messenger system that has to do with the splitting of PIP2. PIP2 is split by a lipase. This is a phospholipid, and it has to be split. It gets split by something called phospholipase C. Phospholipase C. That's what splits this up. So then you have your IP3 and you have your DAG. So recognize this system. Recognize this system in order to understand endocrinological effects. Understand this in order to understand pharmacology. This is a huge topic here. If you guys can understand the second messenger systems, you guys are already far beyond understanding basics of medicine, because the idea of second messenger system has to do with how these cells operate, how they actually function in the intrinsic level. So definitely, I separate them by three. Remember, we were separating them earlier today. Those that took class with me earlier, we separated this by 3 different types. We said that there's G protein complex, right? G protein. Then today as well, in this section, we also mentioned intracellular type of activity with heat shock proteins, right? We said heat shock proteins. These are proteins that end up getting displaced once you have something like sex hormones like testosterone or anything like this entering. They're going to displace the intracellular type of receptor. They will displace this, right? And then you'll have activation of hormone sensitive type of proteins that will basically amplify certain types of expression for genes. And it's very non-specific. We can't get too specific just because these type of sex hormones are causing growth. They're anabolic. They're causing stimulating so many different things. They're stimulating growth. They're very anabolic. So we said intracellular receptors using this kind of activity, heat shock proteins. Let's also remember that there's another stimulus that happens inside the cell that's also intracellular. And this is the stimulus with another type of protein called RXR, retinoid X receptor. Retinoid X receptor. This here likes to form a complex with something called PPAR. PPAR. There's drugs that form complexes here with PPAR alpha. Who can tell me what drug forms a complex with RXR, PPAR alpha? What drug? Fibrates. Correct. Fibrates enter and form a complex at this point in order to then have expression inside the nucleus. So you need these type of proteins to form complexes and then take the drug inside the nucleus. Okay, the drug can just jump in there. So what else? There's also PPAR gamma. Who can tell me the drug that also joins the party when it comes to PPAR gamma? Who remembers this type of drug? TZDs. Yes, TZDs are these type of drugs, basically. The pioglitazones, these type of drugs, right? Not really metformin, but metformin are not functioning towards that type of level. But you'll see that in this sense, these PPARs, it's like somebody was sitting down and said to themselves, well, insulin operates with an insulin type of receptor, right? This receptor is a tyrosine kinase sensitive type of receptor. Insulin needs to get into this area and it forms a multimer. Like this will come in and have more affinity. Like it binds like this. This is how insulin will work. It basically comes in as a ligand and it'll end up binding these kind of receptors. They come together. So insulin is what makes them snap together. So this turns into this actual receptor activity. This process, this second messenger system that I'm explaining to you right now, is called the tyrosine kinase because you have non-receptor tyrosine kinase and you have receptor tyrosine kinase. This is the receptor tyrosine kinase type. Let's be very clear. The receptor tyrosine kinase type. So the first aid, the way that the first aid has this down is very simple, very let's just say simplified. Because yes, these type of receptors do cause a very important type of function. You're going to see that they not only do they have anabolic effect stimulating mitogens. Remember, mitogens are those proteins that want to stimulate differentiation and growth. Not only do they have this, but they also stimulate protein synthesis. So this is how the first aid will have this down. Look at that. They'll just show you phosphorylation of tyrosine, and then they'll show you two different pathways. MAP, RAS MAP, and also phospho inositide 3 kinase pathway, all this craziness. So I'll just put it to you like this to make sense of it. This here, this tyrosine phosphorylation is now causing two different types of reactions. One reaction is more of a mitogenic effect. Mitogens are just proteins that stimulate cell proliferation, cell differentiation, in other words, cell growth. So one pathway is stimulating this, anabolic, while the other type of pathway is stimulating protein synthesis. So you're making the proteins, you're making mRNA, you're having translation. You're having that process where there's translation. Does that make sense? Two different pathways being stimulated just because of the activity of one. Perfect. Good. Now, with that being said, all I'm telling you is this. In a case like this, you'll notice that when insulin binds to this type of activity, when you start to engage this type of activity, you'll realize that all in one package, 2 for 1. Yes, that is 100% sure. 2 for 1 package there. Definitely happening. But you see this effect here on the left? This is the effect that has to do with something called mTOR. This is like a mTOR type of effect here, and protein kinase B. So instead of having this crazy phosphatidyl inositide craziness, I'm just going to put this to make more sense of it, because you probably heard of the mTOR before. There's drugs that inhibit that. So I'm just going to put it here, mTOR, and I'm also going to include protein kinase B. This is this activity that's going on here. And this is making protein synthesis. Okay, good. So we modified it a little bit. We tweaked it a little bit. That makes sense. That's good. Now, TZD. So how in the world is TZD taking an effect here? I guess scientists sat down and they thought to themselves, hey, what if we have a problem? Well, we have a problem, actually. We have diabetes. Diabetes, in diabetic patients, you have a decreased sensitivity to insulin. That's a problem. That's a huge problem. Because if your sensitivity decreases, what happens? Well, insulin is around, but it's not causing this type of second messenger system. So scientists said to themselves, hey, why don't we just give a drug that can enter? It can enter. It'll be able to bind certain types of proteins like RXR and proteins like PPAR gamma, and it will create a complex. Once this complex is created, it'll go to the inside where we have nucleus, and it'll actually activate the proteins that insulin regularly activates. All those proteins that are activated, yeah, basically it's just saying, hey, guess what? I don't even need to stimulate this receptor. I don't. I can just go in there and activate the genes that insulin activates. Does that make sense? The only problem with this is that insulin activates so many different types of things. So many different types of proteins, so many different types of mRNAs are being activated with insulin because we're creating a lot with insulin. Insulin is not just something that lets in glucose. It isn't. Remember, it has a lipid type of effect. It has effects on so many different things, so many different levels. So this is where we have a problem, because insulin is under a regulatory system that's very, very strict. It's very strict. But TZD is under no strict regulation. So remember, you have something called adiponectin and adipokines, things like this. Well, in this case of TZD, since, first of all, there's no regulation, what ends up happening? We end up having a higher expression of GLUT on the receptors, You end up having more GLUT4s on the surface of the receptors because it's able to enter and trigger the higher level of translation of these GLUTs. So GLUTs start to manifest themselves on the receptor. The problem is that glucose enters the cell. And then glucose, when it enters, remember, glucose has a high level of osmolality. High level of osmolality. It can push water wherever it goes. Wherever it goes, it pushes water. So think about this. If you have a lot of glucose entering this cell, remember, there's no regulatory system. It's not like, oh, we have so much glucose, let's turn off this channel. These channels are being expressed because of the drug. So a lot of glucose ends up going in there, pushing a lot of the extracellular type of fluid volume into the cell. So now the cells are having a higher level of water retention. Extracellular fluid decreases. Let's go with the dynamics of this. Follow me here. If I have a decrease of extracellular fluid, now my fluid has decreased, extracellular. Remember that in the kidneys, we have the juxtaglomerular cells, right? We have that macula densa. So you have a decrease in renal blood flow, decreasing. It's going to stimulate renin. And this renin stimulation will then start to activate. Well, B1 can activate this, but the number one activator of renin, because you'll see when we mention the battle of the receptors, there's many different types of dynamics here of stimulation. Like the number one is volume status. Yes, volume status. It will be perfusion. It will be the level of volume that can be sensed by this area of the kidney, right? If it cannot sense proper perfusion, it will stimulate renin. And yes, let's be very clear. There are always going to be various factors of stimulation, but there are levels to this. There's high level of regulatory system. The primary regulatory system of the kidneys of renin is going to be caused by perfusion. So renin stimulation is caused by perfusion. Let's say perfusion. Yes, you can say beta 1 activate. You can say that. Overall, king, number one, the one that regulates everything, that will have everything to do with it, will always be perfusion. It overrides everything. I can have a B2 like inhibitor type of sensation, but if I lack perfusion, it'll override. So let's not get confused. Let me just tell you one thing. I'll give you an example. You do have beta 2 adrenergic type of receptors located in the pancreas. And that makes sense. It does make sense because beta 2, beta, epinephrine activates beta. E looks a lot like a B. E and B look very similar. Epinephrine activates beta. So it makes sense that if you have an adrenaline rush, you want to be able to have higher secretion, let's say, adrenergic effect, higher secretion of insulin in order to be able to use all of that glucose that's going to be held up in your body. So, yeah, you'll notice that effect that tends to happen. Lacking perfusion, decreased extracellular fluid. Perfect. Awesome. There you go. Now, let me tell you something else. Let me just flip that into your mind. And this is kind of messed up. I don't want to do this to confuse you, but I have to be honest. What if you have too much constriction? Guess what you'll have? Decreased perfusion as well. So there's two different spectrums to this. I know it sounds like I'm contradicting myself now, but think about this. If these vessels are very tight, if you have a hyper constrictive vessel that's just not allowing any perfusion, guess what will happen? You have lack of perfusion, stimulus of RAS. Lack of perfusion, stimulus of the RAS system. So I should tell you the better way to say it is renal blood flow. That's what stimulates. That's what will stimulate RAS system, renal blood flow. That's what stimulates it. Because renal blood flow could be hindered by a decrease in volume. It could also be hindered because of a potent constriction that does not allow the perfusion to occur. So lacking perfusion is equal to a decrease in extracellular fluid. Yes, 100%. But it could also be due to a potent type of vasoconstriction that does not allow perfusion. So there's mechanisms of not having enough, and then there's mechanisms of not allowing the perfusion to occur. Third space accumulation. What do you mean? Oh, if the blood gets, let's say, stuck somewhere else, you're saying? Okay. If the point is that if you cannot distribute oxygen, which is traveling in blood, to this tissue at this moment, you will end up having trigger of the RAS system. That is what stimulates overall renin angiotensin system. Okay. All right. We understand that. We got that down. That makes sense. Okay. So we were talking about, let me see what we were talking about. We got into this. Okay. Yes. So, okay. Going back. We said TZD. Like in adrenal crisis, there's hypotension. Yes, Mona, but let me explain to you why. That's a bit different. So, okay, now I got to organize this. So yeah, now I have a couple of things we have to explain. This is awesome. So this is why I like the class to be hyper dynamic, because we're talking to each other. Now we're going to basically iron everything out. If you guys have any questions as well, feel free to ask them. That's how I like the class. That way, we list up everything. We start to explain everything. So with Mona, we're going to talk about adrenal crisis, and we'll explain exactly what happens. Hypertension is due to something else, actually, and we'll see that as well. So adrenal crisis. We also have the explanation of RAS, and then we'll talk about right now the primary explanation is the TZD side effects. That's what I'm talking to you about. TZD side effects. So let's get organized. Let's start off with TZD side effects just to finish it off. TZD. We said yes. TZD can actually trigger activation of certain types of genes, let's say, that start to get expressed on the nucleus. We're able to form a complex. TZD is able to bind with PPAR and bind with RXR. It enters in here, and then it starts to make mRNA that pertain to specific things that insulin used to make. So insulin used to promote the activity of transcription. Remember, we talked about two different pathways. We talked about the RAS MAP kinase, which was on one side. That was the mitogenic pathway. Then you had the protein kinase B and the mTOR pathway. That was on the other side. That mTOR pathway has to do with the creation of transcriptive mRNA, right? We made it through transcription in order for this to leave and then make proteins. Utilizing our ribosome, we make proteins. That's what basically happens with insulin. Insulin has two different types of pathways we mentioned. And all I'm saying is that the pathway that's promoting protein synthesis, we tend to say, hey, we can just give a drug that will enter and it will actually work on the genes that are expressed, the same genes that insulin tries to activate. So TZD has this function where it starts to create a higher level of mRNA. So yes, okay, good, that makes sense. Now I'm going to tell you what happens. We said that you have a higher expression of glutes, right? Glutes. GLUT4, let's say. GLUT4. So let's take a look. Let me show you guys. Here I'm showing you this image. Where's the image? This one right here. Remember? Here you have activity. Now you're seeing glutes, right? You're seeing GLUT4 expressed. GLUT4 expression. Okay, activity of PKB and then mTOR leads to more glutes. So you guys are following me now? You guys are good. We're good right now. We're talking. Okay, perfect. So I'm going to tell you one thing. There are three things in our body that we need to understand. Three things that have hyperosmotic value, meaning wherever they go, they bring water. Wherever they go, they're bringing in water. Doesn't matter what we're talking about. If you're talking about them leaving the body, excretion, yes, good. Yes, Miriam knows. Sodium, glucose, and urea. Urea is related to protein products, amino acids, things like this. These are proteins. All these type of products, they have osmotic value. They can drag water wherever they go. They drag water. But remember that glucose is a very powerful one. But okay, let's understand now. What I'm saying is that you have a very powerful molecule with a high level of osmolality entering the cell. Entering the cell. When it enters, it pushes with it H2O. By pushing H2O, it is depleting the extracellular volume. When you deplete the extracellular volume, you trigger RAS system. RAS system is renin, angiotensin 1, angiotensin 2, aldosterone system. That's what ends up getting stimulated. This system is very important. Yes, weight gain as well. Why also weight gain? Weight gain because it is not being regulated. It doesn't stop once we have an increase of glucose inside the cell. Let's say it continuously activates. Insulin is an anabolic type of hormone. If you're having a higher level of insulin activation is going to cause this type of weight gain. There is an exception with GLP-1 agonist drugs. There's an exception there where you have more insulin release, but you have loss of weight. We'll talk about that as well. So we have a couple topics in the air right now. Why does TZD have anabolic activity? Yes, it does, because it's acting a lot like insulin. It's mimicking the actual process that insulin is doing. So it's mimicking the absorption of glucose. It's mimicking all that type of activity that goes on with insulin. So it should be very anabolic in that sense. You see what I mean? Weight gain should make sense. GLP analog, yes, that's why Ozempic. Yes, we'll talk about Ozempic. We'll talk about exactly why is it that it causes this issue with, well, not an issue. It's actually a favorable type of symptom, which is loss of appetite. So we'll go subject by subject. So you're saying what happens to the other side of kinase and mTOR? This is the side of kinase and mTOR. This is the side of kinase and mTOR in this side. Right? Because we bypassed everything that had to do with activation in that sense. We bypassed all that, and we're just going straight up to this point. So yes, GLUT activation, yes, that's what we're stimulating. But there's also other types of proteins like adiponectin and other types of smaller of other things as well that get stimulated. Insulin has a lot of activity. It regulates the lipolysis as well. Remember, decrease of insulin, increase lipolysis. Increase of insulin, decrease lipolysis. You don't want to break down your fats when you have a lot of insulin. Quite the opposite. Insulin is anabolic, right? You want to have as much fat as you can. So, okay, don't want to deviate. Let me just conclude with what I'm saying. What I'm saying is this. A lot of the fluid from the extracellular space gets pushed into the cell. That fluid that gets pushed into the cell then leaves you to activate your RAS system. Then your RAS system will have to basically compensate for your decrease in your cardiac output. You have lost cardiac output. Why did your cardiac output slightly decrease? Why wasn't your cardiac output able to maintain the same level? What was the problem there? Why do we need to activate preload? I'll tell you why. Here we have stroke volume, which is cap. The level of the blood. So let's talk about another important concept. Let's inject more concepts. So this is getting fun because now we have a lot of topics to talk about. So let's look at this. If we look at the cardiovascular system, notice it's called cardiovascular, not just cardio. It's a cardiovascular system. Let's look at this. If I have, let's say, 5 liters of blood, 5 liters, and I constrict these vessels, let's say here, let's just put it like this. Let's say on the vessels, on the vascular system, let's say here I have 4 and here I have 1 liter. Let's just say, if I constrict these vessels, if I constrict the peripheral vessels, I would change the distribution. Now I'll have less blood here on the vascular system and more blood here. So I can tell you that if I am constricting vessels, I am increasing preload because the more volume that I have inside the blood during a systole is basically going to reflect as preload. So let's put this into our mind. Same thing goes in the opposite sense. Let's say I have 1 here and I have 4 here. As long as there is no edema. So to understand this, we're looking at the idea of volume in this sense. You'll notice that edema can happen many different things. So to get into edema is another topic because you'll see that there's a balance between hydrostatic and oncotic pressure. And definitely either the increase of volume, which can cause an increase in hydrostatic pressure, or a decrease in oncotic pressure, which can lead to increase in hydrostatic again. So let me just tell you like this. What's happening is that the volume that we have at the periphery system has now gone lower. Now it's at 3, let's say. Why? Because a lot of it got pushed inside the cells. Let's just say a lot of it got pushed inside the cells. So we are reading the outside. We don't read the inside. We're reading the outside. The outside, we saw that, hey, we lost blood. So let's activate. So if we lost blood, our preload has decreased. That reflects on the cardiac output, decreased. So therefore, we have a cap system. We have the P, which is activating that preload, activating it via RAS. That there will increase our volume to now put it back to normal, what we think is normal. But in reality, it's not normal because all the volume that got pushed into the cells are still there. So we are having water retention. We're having the migration of volume from the outside to the inside. This cannot be given. And this is a problem because a patient with congestive heart failure is already depending on the preload. They're depending on the RAS system. A patient with congestive heart failure is compensating his cardiac output issues with the aldosterone system. Now you're causing more of a burden by tagging the aldosterone system with this extra issue. So a patient with congestive heart failure, this is contraindicated because it can cause exacerbation because of the mechanism of action. Mechanism of action increases the exacerbation. Does that make sense, everyone? This is why TZDs are contraindicated on patients with congestive heart failure. Does that make sense? Yes. TZD causes glucose to enter the cell. Glucose enters the cell, it starts taking water from the extracellular area into the intracellular area. Intracellular fluid is not what the kidney reads. The kidney is reading peripheral volume. So the peripheral volume has decreased. The kidney is going to say, hey, where's my perfusion? Why am I not getting 20 to 25% of the cardiac output? Where is it? What's going on? It's going to be concerned. It's going to activate RAS system. Is that making sense, everyone? Are we making sense? Are we connecting here? Yes. Good. Any questions? Any questions before we get into the next one? This is also done by insulin. So let me tell you the difference. The difference is that insulin is regulated. Insulin does this until our body needs this to be done. So insulin is highly regulated, right? So when you have, for example, a higher level of glucose, then basically you'll have insulin release. And then insulin will be able to sequester the amount of glucose that it needs to in order for us to break it down properly through glycolysis to make pyruvate, and then use that pyruvate to make, basically, if we are going to either make triglycerides or if we want to make this pyruvate into Krebs cycle and make ATP from the NADHs that we make, right? We can do this, and it has a system for this. It listens to us, so it understands what's happening. It's understanding everything. It says, okay, well, now all the glucose has entered the cell. We don't need to have hypoglycemia, for example. It regulates this to a 4-hour basis. So our dietary type of glucose should basically last us about 4 hours, because of the proper insulin release that we have, right? It's making everything work in this fashion. It concurrently runs with our system when it comes to hunger and the ability of satiety. It's flowing properly. So dietary glucose can be ingested properly and consumed and utilized in a proper fashion. 0 to 4 hours, we use all this dietary glucose with proper insulin. Now, here's the problem. Yeah, they stimulate insulin by natural regulate. Yes, they do. And we'll talk about that. So insulin does not do this, Francis, because insulin knows when to stop. It listens to us. So Mona says, this is due to PPARs that have increased in the sensitivity of insulin. No, not really. I'll tell you why. Insulin doesn't use PPAR. Insulin uses that weird pathway that we were talking about that has to do with protein kinase B and mTOR. Insulin is using this pathway. It's basically, let's say, the PPAR and all that. Okay, so it says this is due to PPAR that have increased in the sensitivity to insulin. So PPAR will bypass. Yes. So I'm going to draw it to you like this to show you an example, a visual example, to make it make sense. Let's say insulin is doing this. Insulin is stimulating this pathway, let's say. When we look at PPAR, the activity of PPAR, gamma, and RXR, let's say this here is the genomic material. So let's put it inside a nucleus. Let's say this is the genomic material right here. Let's draw it like this. Is here. Notice that we can tap into this genomic material and bypass all this type of activity if we give TZDs, which will make a complex with RXR and PPAR gamma. And this will be able to form the transcription factor, which is basically allowing RNA polymerase to code for specific genes on this genomic material. Now you're able to code for specific genes, which will release mRNA. Now, check this out. Insulin has nothing to do with this. This is TZD. Insulin is able to activate a natural type of pathway that flows with our physiology, meaning that it's responsive, meaning that it has regulators, inhibitors, activators. It has a group of enzymes, allosteric activators, inhibitors. It has all that. So insulin is able to go in there and tap into this protein kinase B, mTOR, all this, and then end up stimulating the same thing. So it ends up going to the same type of genomic expression and then stimulate the same mRNA type of activation. Does that make sense? Yes, PPAR bypasses all this. PPAR is saying, hey, I know the expression that is stimulated by insulin. So why not just give a drug that can also bind to the same expression and activate the same kind of activity? The only issue is what I mentioned. One of them is heavily regulated by our own metabolic physiological responses. So if we have too much insulin increasing inside the cell, then why are we going to have more insulin packing it more? It will stop. It'll stop. It has regulators. TZD doesn't listen to any of that. Insulin does not steal as much water in the heart because of it's heavily regulated. TZD does not care. TZD is just stealing as much as it can. But I'll tell you one thing. It's not that it's locally doing this in the heart. What it's doing is it's doing this to all the cells that are going to use GLUT4. What it's doing is that the periphery system now decreases in volume because so much glucose seeps into the cell. So now we activate RAS. Yes, all cells drag in that water. RAS gets activated. Now we have overactivation because now we're carrying the volume inside the cell. We're carrying the volume outside the cell. We're having way too much stimulus. Congestive heart failure will suffer from edema. Congestive heart failure would have so many issues here. So congestive heart failure, we do not give this drug for patients who have congestive heart failure for that concept. Yeah, definitely. Thank you guys. Definitely. That's what we have here when it comes to TZD activity, not listening to the regulation system that we have. Drugs typically tend to do this. They don't listen to us. They're drugs. We give it and then it does reactions. Okay? Definitely. How does TZD, how we use TZD safely? We load those? No, you can use it. So let's be clear. I'm talking to you about the bad side of it. I'm talking to you about the evil side of TZD. Typically speaking, regular patients who use TZD won't experience all of this type of problems. If they don't have congestive heart failure, it'll be a lot harder for them to experience this. It is deemed to be a safe drug. I'm not, of course, I'm not here promoting the drug, but I am telling you that it's deemed to have safe usage. It's deemed to actually benefit the patients a lot, actually, in that sense. But yeah, it's typically used normally. It has no issue. I'm just talking to you about the side effects. If you misuse the drug, or if the drug is used on a patient who has congestive heart failure, now we're going to have a problem. Yes, you have to know the comorbidities as well of the patient when you're diagnosing these kind of drugs. The same idea. So keep that in mind. This is something very important in that sense. This is the idea of PPAR. I had a question on this in med, and it said it was safe for CDK. Yes, I'll tell you one thing. I'll tell you something about CDK. CDK, chronic kidney disease. Chronic kidney disease, the most common cause of chronic kidney disease will always be hypertension and guess what? Diabetes. So most of the patients who are being treated and managed for CKD are patients who either have diabetes or have hypertension, glycation products. So yes, yeah, that'll manifest itself with a lot of issues. And basically, glycation products. Let's look at that. They call that age. They just call that age. Glycotic end products. Age. That's the little accumulated glycosylated proteins. It's like age. That's the name that they have for it. Anything that undergoes glycation. So what ends up happening is that you have. So let's just look at the mechanism behind this really fast. We have our glomerulus, right? We have our glomerulus. Remember, we have different types of cells here responsible in the glomerulus. We have an endothelial portion, endothelial, and we have epithelial. Remember that the epithelial area has the podocytes. Podocytes have a very strong responsibility. They have to keep out things that are negatively charged and things that are large. Large proteins and anything that has negative charge must be kept out. That's the job of the podocytes. Okay? But you also hear on the GBM, here you have your GBM. And what was the other thing? You have GBM. And I believe right before that, let me see. It was you have mesangial cells as well. But hold on, let me put this here. Mesangial cells. Mesangial cells. That you also have. I think this was for the endothelial type of area. Lamina densa and the reticularis. No. I'll put it as it comes to me. I'm going straight. I'm basically freestyling right. I'm going straight from the top of the head right now. So what I'm going to say was this: the integrity of the glomerular basement membrane. It has specialized types of cells called heparan sulfate. Heparan sulfate are as well very important, just like the podocytes. They actually keep out negative charge and they keep out large type of proteins. They make sure that these things cannot permeate through the glomerular basement membrane. But the real job of the glomerular basement membrane is to make sure that RBCs do not pass. No RBCs should be passing through here. But if you ever have damage of the glomerular basement membrane, you start to create little holes. These little holes, when you have something like, for example, RBC trying to get through it, it starts to create a cast. So you can have RBC cast, for example. Or let's say you have a nephrotic disease, you're releasing higher levels of lipids. You can have lipid type of cast because they squeeze through these little holes in the glomerular basement membrane. So glomerular basement membrane, if you ever damage this or have some kind of inflammatory action here, you'll notice that you'll have deposition of RBC. So you have hematuria tends to happen in this sense. And you do have release of proteins because proteins can seep through these little holes, but usually it has to be less than 3.5. Now, if you damage podocytes, we're talking about real damage. Now you have more than 3.5 proteins permeating through this area. Nephrotic diseases are associated with damage of the podocytes. Some things can start off as nephritic and start damaging the glomerular basement membrane, and then can graduate and then cause damage of the podocytes. Then, of course, you'll have issues in this sense with both. It goes from nephritic and then turns into nephrotic. Yes, good. You remember membrano and diffuse SLE. Okay, definitely. This is going to cause those type of issues. You guys remember. So let's take a look at this and let's understand this properly. What we're talking about in this sense is if the patients tend to have diabetes, they have this process, they have this damage, this glycation that occurs, and it occurs on proteins. You're able to oxidize. Why? Because I'll tell you, glucose has the ability to reduce. They are reductive type of products. They can reduce. Let's not forget, guys, when we talk about the idea of making glutathione, like where does all that come from? Reduction, oxidation, like what's the precursor of all that? If you look at deep down into it, you'll start to notice, okay, this is actually something that works in this process of reduction and oxidation. And we're seeing here that glucose itself has the ability to reduce. It can reduce things. Remember, when you reduce, we say RIM. Reduction is more, meaning that you're adding hydrogen to a molecule when you are reducing. You're adding hydrogen to a molecule when you are reducing. Therefore, glucose has the ability to reduce. If you start to reduce, and what does it like to reduce? Proteins. So what do you start to reduce here? Heparan sulfate starts to get reduced. And whenever something gets reduced, we call that glycylation. There's a glycylation process that's happening here. This glycylation process is happening to heparan sulfate. You're losing the ability to allow, to block negative and large proteins from making it through the glomerular basement membrane. So now you're having more proteins make their way in there. But this is very progressive. Efferent augmentation, hyperfiltration, more proteinuria. Yes, that's another thing. So let's understand this. So this is happening gradually. Also, this is not something that just one day to the next will happen. This is happening at a very gradual level. You start to lose the ability to have, let's say, restriction of proteins through this glomerulus. There's other things that become a lot more permeable as well. So you have a hyperfiltration. Think about it. More proteins are getting in there. More glucose is getting in there. All those being reabsorbed without a problem. It's not an issue yet. Everything is looking good in that sense. But increased GFR, yes. Overall, that's what we want to say. Increased GFR in the very beginning. Yes, definitely increase in GFR. That is what we will have. So if we want to measure functionality of the kidney, remember one thing. We look at the GFR. GFR is done with a calculation of creatinine. So we're able to say that we are measuring the functionality of the kidney, but then we also have to consistently measure the damage of the kidney. And what do we use to measure the damage? Does anybody know? What type of lab, what type of marker, what are we using for damage of the kidneys to measure that? Can anybody remember? Well, not creatinine. Creatinine is the functionality, not myoglobin. That you can't, not BUN. There's one thing that's highly specific for damage in order to look at damage. Not CAST, not CK. No. One thing, just one thing for damage, and it's highly sensitive as well. Like it's very specific, actually. Like you can notice when you have damage of it. So I'll tell you. Okay. All right, everybody. Okay. Let's see. Charge. Well, good guess, Mona. Good guess. But how do we read? How do we read the idea, the fact that charge has been hindered? What can we use? Urine concentration, albumin. Boom. That said it. Blurina has won the prize. Ding, 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 ding. She won because, yes, you'll notice that it's all about albumin. All about albumin. So check this out. Look at this, what it says here. Albuminuria, categorize, description, and range. This is basically used to determine the prognosis. We're using two things. We use GFR over everything. GFR over everything. That even includes the staging. Wherever you're going to stage a patient with CKD, when a patient has CKD, you have to stage them with your GFR. That's the number one thing that will determine their staging. This on the side, the albuminuria, just lets you know how are they actually monitoring themselves. If, for example, if I have a patient who's on G2, right? They're in the second phase, CKD second phase. I can say, oh, she's in second phase. Well, I can say, well, is she green, yellow, orange? How is she managing herself? How is this management going on? How is the progression of this happening? But what do we use to measure prognosis? Over everything, it would be the functionality, the GFR. And you're seeing it here. It's staging as well. We can stage with the GFR. But here on the side, we're seeing albuminuria. Albuminuria is used to measure the damage of the kidney, the damage. How much damage is this kidney actually taking? Albuminuria will let you know. And that makes perfect sense. Why does it make sense? I'll tell you why. Because we already mentioned the idea of the structure of the glomerulus. The glomerular structure has certain types of cells that pertain to permeability that stops negative and large proteins from entering. GBM had its cells, and then podocytes has its own cells. So as it gets worse, more protein will enter. As it gets worse, more protein will enter. As there's more damage, more proteins are able to enter. So keep that in mind. That's a good measurement of damage. If ever there was one of kidneys and you're asking you what measures damage, it's always going to be albumin. Okay, that makes sense. That makes perfect sense. So TZDs, yes, it can be given to patients who have issues with chronic kidney disease. I mean, there's no issue there. I mean, why not give it to them? It makes sense. It'll make sense, definitely. Now, okay, so going back to the little list of topics that we had a nice little list here. It was a nice list. Let me see, where did I put that list? Wow, our board is getting full again. We can start off a new board, but let me see. I think the list was right here. Okay, so we understood TZD. We explained that pretty well. Let's go into the adrenal crisis. Let's talk a little bit about that. Why do patients with adrenal crisis actually have hypertension? It actually has more to do with cortisol than it does with aldosterone. That's why cortisol must be supplemented immediately. Can't play games with that. You have to immediately try to supplement your cortisol, because cortisol has a permissiveness effect on the vessels. Cortisol will actually allow for more types of receptors to express themselves on the vascular system. Therefore, norepinephrine, which will have affinity for alpha 1, yeah, basically you'll have this process, which is very important. You have to understand the permissiveness effect. That's the vocabulary that likes to get used. So what's the difference between synergy and permissiveness? You'll notice that synergy is going to be when two drugs, let's say one drug by itself has the action of, let's say 2 has the action of 2, and then another drug 2 has the action of 2. But when you give 2 plus 2, the action is now 7. But notice that these drugs are not helping themselves. Both of them are executing a mechanism of action, right? And they're both just increasing the effectiveness of that action, let's say. It's being increased in that sense. In permissiveness, they are directly helping themselves in the sense where you're having more expression of receptors because of cortisol, upregulation of receptors, sensitization of receptor, allowing for norepinephrine to then bind and then cause a vasoconstrictive effect. Remember one thing, guys, one thing that's very important. All catecholamines at a very high level, if I give any patient a high level of epinephrine, if I give patients a high level of dopamine, high level, high dosage, what will they all bind to? What will they all bind to? What is the number one affinity? Alpha 1. Alpha 1. Yes. At higher levels, all catecholamines bind alpha 1. They want to bind alpha 1 to cause vasoconstricting. So just letting you know, norepinephrine, for example, it binds alpha 1 regardless if it's high or low. So norepinephrine you're seeing will have perfect activity with cortisol. They love each other. They're working perfectly. They're working off each other, which is great. It's awesome. It is awesome. Right? So that's why you have hypo in a adrenal crisis. You end up having hypo. I was going to say hypo blood pressure. You end up having hypotension because of this lack of permissiveness effect by cortisol, which is why when patients are having an issue like this, you have to replenish cortisol. If not, the patient could die. It could be fatal. It could be fatal. That's why you have to replenish this immediately. Hopefully that makes sense. First, cortisol. Yes, over everything. Always, always cortisol. Cortisol is the major one. Okay. Let's keep that in mind. So, yes, I'll tell you what, guys. Was it is the same for Waterston Fredrickson. Waterston Fredrickson can be lethal as well. It can end up causing death on the patient, actually. Many cases end up in death. Actually, what is the mortality rate on that? I'm interested because from what I've read, it basically is very lethal. It's explained to you how the patient dies because it's hemorrhage of these vessels. It's not that you have a decrease, like in let's say adrenalitis. Like, so the most common cause of adrenalitis is actually autoimmune. It's autoimmune. Yes. For adrenalitis, I'm saying for the inflammation of the adrenal glands is going to be autoimmune. That's the most common cause. But when you're looking at hemorrhage, oof, that's terrible. We're talking about some terrible, terrible type of effect where now you have zero cortisol. Yeah, zero cortisol there. It's destructed. It's so I wonder what the mortality is there. I don't think a patient can just undergo Waterston, have hemorrhage of supraadrenal glands, and then just be given some kind of cortisol and then walk away without any problem. So I would have to look at the mortality rate on that. But yes, this is Definitely concerning. I think it's not 505 50/50. Yeah. I think it's pretty bad. I do think it's pretty bad because it's not like partial damage. It's terrible. So yes, yes, yes. Just to let you guys know, we were able to mention tonight the idea of tyrosine kinase. I want to continue. I want to do more class. I don't mind going for hours, actually. I know I sound crazy, but I don't mind going for hours. I don't mind because usually I have a student in the morning. I have a one-on-one session in the morning. Student is not active. Student is going to take an exam tomorrow. So I'm used to basically going to sleep rather early. But tonight I'm going to stay up. I'm going to be working on more projects that I do have. So I don't mind taking a break and coming right back. So let's do that. I'm going to leave the link open, leave everything open, basically. I don't mind. Yeah, you guys are amping me up. That's great. As long as we have everybody's active, everyone is responding, this is perfect. So next, yeah, I want to get into more topics next. Yeah, I don't mind. I don't mind. We have a lot of good topics coming up as well. Yeah, get your pajamas, get your midnight snacks. I'm going to do the same. I'm going to see if I eat something really fast. We can take a little 15-minute break, 20-minute break actually, and come right back. But I don't want everybody to just run away and leave, which is why I'm going to also probably drop the link somewhere else as well. Get some coffee as well. That's perfect. Yes, and get something for me not to dry up all my. Let's say I need some kind of water, some hydration. So basically, when we come back, let's talk about more topics about aldosterone. How aldosterone activates these type of cells. Let's get into the whole endocrinological effects of aldosterone and how everything like that works. Definitely. If you have friends as well that are being lazy or anything, send them the link. They can just listen to this while they're sleeping or something. Just all I'm telling you is that when we come back, we're going to talk more about aldosterone system. We'll be talking about, man, wow, we mentioned so much. We mentioned EPO already. We talked about all of this. So this is awesome. We'll mention everything else. I'm going to try to go through the endocrine system. That's what we're doing right now. I don't know if you have noticed, but we've been slowly picking and prodding at the endocrine system from different angles. We even got into insulin. So I'll be right back. I just have to eat something. That's what I have to do. And I have to also hydrate myself. I'm going to leave this link open. Definitely anybody's welcome to join. And I'm going to pause the recording. That way, when I come back, I hit resume. Remind me to resume when I come back. Remind now it is. Okay. Let me see. Let's open this up. Am I sharing the screen? Can you see it? Can everybody see my screen? Okay, yes, yes, yes. Definitely, definitely, definitely. Yes. This is a good topic. This is a really good topic. And we could also do some questions based on this topic as well. So definitely gonadal type of dysgenesis. Okay. So for example, let's take a look at that. Yeah, let me open up this stuff in order to include everything. All right. Let's look at this. So one thing we need to take into consideration when it comes to all these different types of diseases. So who gets these diseases like wrong in this kind of a test? Is this anything like for me? This is a topic that if you understand it properly, you really should not get it wrong. The idea of differentiation, those kind of they want you to differentiate basically. So the question is this: they give you certain features, and they would like you to differentiate with all these features, like what diagnosis you're getting. So I think this is actually a good topic to open up and then explore it through this angle. So yes, definitely let's do that. Let's do that, but let's open it up and let's open up the topic from a point of neutrality from the very beginning. One second. Let's see. 1 second. Give me 1 second. Yeah, I'll be getting a lot of messages on Instagram and all this. Let me just close this up. Because I did send the link to a couple people. Let me see if they actually are joining or not. Not, we're good. But okay. All right, good, good, good. Let's just continue. Okay. All right, so let's look at it like this. Sexual differentiation, super important. We already talked about this a little bit. We briefly got into it. So let's understand what's going on. You have naturally everyone at one point had undifferentiated type of gonads. We did not know what they were going to be, but one thing I can tell you is that if a person has Y, if they have Y, if they have the Y chromosome, they end up having the SRY gene. SRY gene. This SRY type of gene can stimulate testes differentiating factor. So let's be very clear. Let's be very clear. Is there anything in the whole world? Is there the creation? Does it exist like a hermaphrodite? Someone who is both male and female? Can this happen? Can a person have functional genitalia, male and female? Does actual hermaphrodite, do they exist? Let me know. Not functional though. Okay, not functional though. So that way, that means that it does not exist. It can't exist. Let's understand why. Both genitalia, phenotypically yes, trans, mm, trans only. I can tell you one thing. Think about it like this. Imagine here I have something that will grow. Let's say I have something here that would grow. Just drawing it as a box, but it could either grow to become one thing or it could grow to become another thing, right? Let's have a general understanding of this. It could either grow to become one thing or grow to become another. So this is the thing though. If I don't stimulate this, let's say, growth, this has to be proactively stimulated. Let's be clear. This has to be proactively stimulated. I have to proactively make sure that I release something that can stimulate this. Let's just talk concept first before we start to put names on anything. Let's just put it like this. If I do not stimulate this properly, by default, it becomes this. I'm just going to put A. If I don't stimulate B, if I don't stimulate the neutral structure to become B, it naturally would become A. It naturally would become A. It needs to have a proactive stimulus in order to become B. Let's understand that first off. Now, many of you might be thinking that I'm talking about the Wolfarian ducts, but I'm not. I am not talking about the Wolfarian ducts at all. I'm only talking about the testes. I'm talking about the gonads. That's what I'm talking to you about before anything. I'm talking to you about the common denominator, the most simple type of function. I'm talking to you about having undifferentiated gonads and then making these undifferentiated gonads either ovary by default, or actively stimulating this in order for it to become testes. These are not, I'm not here talking about Wolfarian, Mullerian duct, none of that. Just basic idea of stimulating testes. Now, here comes the problem. You can't have a 95% testes, for example. You either make the testes or you don't make it. It's like an egg, right? If I don't have an egg that's open or I have an egg that's like kind of cracked, either I make it or I don't. Either it's functional in this sense, in the creation of it I'm talking to you about, or it's not. Right? We can talk about how the testes have a lot of anatomical features in the inside, right? They have seed, the seminal vesicles, all that. That has a lot to do with its function. But I'm just talking to you about the idea of creating it in the first place, having a viable gonad as a male, having testes. Yeah, it's just a concept. Think about this idea now. If, for example, by default, it would have became this A, this ovary, let's say. If this SRY gene was not able to penetrate properly. It was not able to manifest itself properly. When you were coding for this, when you were making your RNA polymerase 2 that would code for testis differentiating factor, yes, there was some kind of problem there with the expression. It wasn't expressed properly. You have somewhat of release of testes differentiating factor, but not enough. Something that decreased its action there. You'll see uh, a structure that will look like it tried to differentiate, but it didn't properly differentiate. So it would look a lot like, because remember, by default, it becomes purple, let's say. By default, it becomes purple. You'll have something that will look like this. In no way can you ever have the proper development of A and the proper development of B, because you only have one type of precursor, and it's either trying to become A or trying to become B. There's no way that you can have, let's say, proper A and proper B, because you're not cloning this. You see what I'm saying? You're taking one structure and maturing it. Does that make sense, everyone? No midterm. Yes. Either you have damaged, either you screwed up the process of making testes. It got definitely destroyed. Something went wrong, or it got made correctly. That's the idea. So when we're talking about the ability, let's say, to make the testes in the first place, the name that you said was you said gonadal dysgenesis. These are the types of problems that you will have, definitely, in this sense, at a pathological, from a pathological point of view. You're not able to properly make these structures. So let's see exactly how this can happen. The DSD problem. If the situation that I mentioned was a patient who has XY, let's say, it did not get formed properly, right? You have an issue in that sense. Let's say XY did not get formed properly. This is the oval testicular type of issue. This is the oval testicular problem. That's this one that you can describe as oval testicular. It could also happen with XX in this sense. XX, let's say, expressed some kind of factor that promotes the idea of having it as testes when it should never have expressed that. Let's say this will cause atypical type of genitalia. It will cause the formation of B. So let's be very clear here. We're talking about the idea of making these testes, making them in a way where there was faulty type of maturation. It ends up having some of A, some of B. It ends up looking wrong. Something is definitely not working in this sense. Here you have testicular type of tissue, which also resembles ovarian type of tissue. Here you're having oval testes, they call this. They call this oval testes. That's the issue there. That's the problem there. It either happened because of the an issue with the expression of testes differentiating factor, or it happened where this type of factor, let's say, was or something similar to this factor was promoted and it caused this kind of issue. But it should have never happened in that sense. Does that make sense? Good. So it's that simple. It's just that simple when it comes to the actual creation in that sense. But there's many different types of disorders that you're going to see that have to do with testes that are actually functional, fully functional type of testes that are secreting, releasing testosterone. You'll see issues like this. Let's understand when it comes to that pathway, when it comes to that cycle of developmental issues. For example, you have to learn how to understand the differentiation and get these things right, because this is not really difficult. This is rather easy. You understand that there's different types of hormones. Let's say here we have the undifferentiated type of gonads. So I'm going to run it down I'm going to run it through completely, and then we do some questions on this. Okay, we'll do some questions on it right afterwards. So let's see. Here we have undifferentiated type of gonads. This is of a person that has XY. So let's talk about it happening correctly. Actual process where it happened the right way. Y will express type of genomic structures that allow for the release of SRY gene will express testes differentiating factor. It now differentiates these gonads into testes. Testes have both Sertoli and Leydig. We mentioned this. We said Sertoli is what? What does Sertoli have? What does it release? What is the activity of Sertoli? Can somebody tell me that? What does Sertoli have at this level? Anti-malariating factor, yes, also known as MIF, Malarian inhibitory factor. Same idea, same thing. Yes. MIF, anti-malarian. Yes. It's going to basically inhibit the paramesonephric duct, also known as the Malarian duct. So Sertoli has Miss Sertoli. Miss Sertoli, remember that? Miss Sertoli makes everything a lot easier. Spermatogenesis, inhibin B, and MIF. Miss Sertoli. Okay. So here you go. What happens here is that MIF will directly inhibit the Malarian duct. So the Malarian duct is kind of important for females, especially. Why? Because this will help with the internal female genitalia. Internal female genitalia is FUP. Remember that little mnemonic there, FUP. Like well, let me not even say nothing, but FUP. Here you have fallopian tube. Fallopian tube, definitely. You have the uterus. The uterus. Now, this kind of goes in order, which is kind of cool. If you think about it, you have the proximal vagina. Because if we are looking at it like this, we're able to say this. First, the ovaries have gotten created, let's say. Then, of course, you have the fallopian tubes. Then, afterwards, you have your uterus. So it is kind of going in order. You see that? Uterus, fallopian tube, ovaries. And then up here, you have your cervical area, of course. And then you have the proximal vagina. So let's say here, this is proximal vagina. But okay. As we continue down the line, of course, let's say this FUP will be created. Now, if they said they have like a blind type of pouch, that means they had a problem here with the uterus, the fallopian tube, and the proximal. If there's a problem here making your paramesonephric duct, patients will have a blind pouch. Does that make sense? That's the problems that you'll have here with this development. Good. Perfect. This is your paramesonephric. Paramesonephric. And we'll look at questions like this. We'll try to make the best sense of it. All right? Paramesonephric. So, okay. Now, for males, you have something else. You have the Wolferian duct. That's called the mesonephric duct. And that there has the internal male genitalia. Internal male genitalia, remember, this is stimulated. You have to have testosterone in order to stimulate this one. So males have it hard that way. We have to both inhibit and stimulate. So here we are stimulating the mesonephric duct. Mesonephric. And then mesonephric, yes, will have seed. S-E-E-D. So these are basically going to be the seminal vesicles. Seminal vesicles, the ejaculatory duct, the epididymis, and the ductus deferens. Said, ductus deferens. Ductus deferens. Perfect. Dead end, yes. Yeah, you're right. Dead end then there. Yeah. Okay, that makes sense. That makes perfect sense. But this is the thing, though. In order to have stimulus of this mesonephric, you need your Leydigs. You needed your Leydig cells to be able to release testosterone, Leydig. So ladies dig testosterone. So Leydig will go and stimulate this. This is testosterone that's stimulating this. So far, MIF, we spoke about, inhibits the paramesonephric. The mesonephric is inhibited by testosterone, which is released by Leydig. So far, so good. Now, you have to continuously develop more. You have secondary sexual characteristics. Now, these are the phenotypic type of characteristics that we have that would distinguish us, that would kind of make somebody think that we're male, think that we're female, right? The abilities, you can see this. The idea of, let's say, the distribution of hair, facial hair, Like you see how I have a beard, basically. Like these kind of activities, these I would say secondary male characteristics. This secondary male characteristics, let's distinguish this on its own. So let's take a moment to distinguish this because I'm going to mention something. This is where we have to organize ourselves when it comes to looking at these features. Let's distinguish this. Secondary sexual characteristics. This is the idea of what we mentioned before. We talked about the idea of DHEA. We said that androgens are on a spectrum. Yeah, they're on a spectrum. All these androgens are on a spectrum. We said androstenedione. Androstenedione. Then we mentioned the idea of testosterone. Then we said DHT. It's on a spectrum. So, what do I mean by this? Well, you'll notice one thing. A lot of this sexual characteristics that we see are these type of androgens engaging with specific parts of our body in order to express how we are looking. Right? How we are looking. This is the general type of expression here. And this happens to us mainly during growth, like puberty. And why do I say there's something called Tanner staging, where you can actually stage a person to see if they are concurrently maturing and going through puberty properly. Are these androgens actually having their function? You see, with females, it's a bit more complex. With females, we have menstrual cycles, right? We have the idea of telarchy as well, their breast development. So we have to understand all this type of development, how it works. But first, before anything, you have to be able to create the structure before the structure can then mature. So in the very initial point, the primary sexual characteristics that we're looking into right now, this is something that we do need to understand. They can be divided by two. Primary characteristics will be internal and external. Internal and external. We went through the internal type of structures. Now we'll look at the external. The external structures, you'll notice, are basically like, for example, in the first aid. The first aid does have a nice image of this, where they show you the difference between differentiated and undifferentiated. But they put they put a lot of information on it, which can confuse anybody. But what I'm going to tell you is that if you look at it like this, for example, undifferentiated, you're seeing all these different types of structure. But notice the genital tubercle. In females, this would become the clitoris. In males, the glans penis. So there's many different aspects of this that are super important to understand. But what actually differentiates these type of structures? So I'm going to tell you. All of this is going to be the major hormone for males and the major hormone for females. That's the easiest way to remember. For males is testosterone. Testosterones will differentiate these type of primitive structures. While for females, it's estrogen. Estrogen will differentiate these primitive structures. Okay, these primitive structures are differentiated in this fashion. So we don't have to go off memorizing anything. Just know estrogen is the principal type of hormone for females. So this differentiation is being manipulated by estrogen. Testosterone for males, this differentiation is going on because of test. Okay? So PSP was the mnemonic there for external for male. External male, external male, PSP. Penis, scrotum, prostate. Penis, scrotum, prostate. For females, it is basically is going to be carry on from where we left off here. So here we left off at the proximal vagina. Now you go towards the distal vagina. Yes, perfect. Distal vagina. So this is distal. And then you complete it completely outside, which is the clitoris, the labia, majora, minora, all of that type of activity. That's what you see in the external type of female genitalia. So definitely this will make sense in that realm, right? Female is very easy because it follows that path. So for males, prostate, penis, scrotum. That's the external. The external will be basically stimulated by, look at it like this. You'll notice um, testosterone. So testosterone has to be amplified to the maximum potential. What is the maximum potential of testosterone? DHT. DHT. So DHT is the maximum potential of testosterone. You have to have it at its highest degree in order to have this type of differentiation. 5-alpha reductase is needed in order to make your DHT. Let's be clear. DHT, I said testosterone is the primary one to differentiate these gonads. Remember that it has to be testosterone graduated to its maximum strength, which is DHT. DHT is a lot stronger than testosterone, dihydrotestosterone. And this gets converted by 5-alpha reductase. So yeah, let me make that very clear because I said testosterone. What I mean is androgen, but the highest point of androgen, which is DHT. It's very important in that sense. If we were to tell you the things that DHT is known to do, for example, it causes male pattern baldness, but it's a real differentiating feature here when it comes to the external genitalia. DHEA is known as the weakest in that sense. And I'll tell you one thing, if it comes from the supraadrenal gland, it has an S on it. It has an S on it. So it's sulfated if it comes from the supraadrenal gland. If it comes from the ovaries, no S. No S if it comes from the ovaries. All right? It has sulfa on it, yes. But I just think the S for supraadrenal gland. S for supraadrenal. Okay? Does that make sense, everyone? Yes, definitely, definitely. So is going to have excess of testosterone in this situation if we use finasteride to block 5-alpha reductase. Well, I'll tell you what the problem is with that. The cause of gynecomastia. I'll tell you what the problem is with that, Blarina, is that testosterone itself, it has the option of two different things. So he says here, is it going to have excess testosterone? This is the problem. Testosterone can turn into two different things. Test can turn into estrogen as well. Estrogen by aromatase, that's called aromatization. And testosterone could also turn into DHT. So if you block DHT, you can have more testosterone turning into estrogen, and that will cause an imbalance. So whenever there is an imbalance, that basically leads to these kind of complications. Imbalance of testosterone and estrogen leads to these problems with these complications. If ever you are blocking androgen receptors, let's be clear, if you're blocking androgen receptors, you're going to notice that there will be more activity of estrogen. I know it sounds crazy, but whenever androgen relationship as a ligand is blocked, then you'll notice that estrogen will have more activity. So I'll give you an example here. If you look at the idea of spironolactone blocks aldosterone, right? There's two different types of potassium sparing drugs. We have drugs that have as a mechanism the blockage of ENaC channels. And we'll talk more about that down the line when we talk about aldosterone. But there are these channels called ENaC on the principal cell. Then we have these type of drugs that directly will block, they're antagonist to aldosterone receptors. So let's take a look at this. The principal cell. In the collecting ducts of the kidneys, you have the principal cells and the alpha intercalating cells. Aldosterone is supposed to enter and upregulate. Remember, we said we know the mechanism now. We understand the HSP, right? Displacement of HSP. We understand the idea of aldosterone going in and stimulating the expression of our genomic activity. it can express the sequence that will actually code for ENaC, ROMK, and sodium potassium ATPase. Sodium potassium ATPase. Yes. Yes, that's the problem. So, Pablo, what you're seeing is that aldosterone. Notice that aldosterone looks a lot like cholesterol. It's one of those derivatives. So what ends up happening is that when we give spironolactone, it starts to block the receptors for aldosterone, but it can also have an affinity for these receptors of androgen, leading to a dysregulation, like a disbalance, I should say, of activity. So estrogen can now start to stimulate, and estrogen starts to cause gynecomastia. Yes, it is used in PCOS. So in this case, for example, aldosterone will have a higher expression. Well, when it binds to that HSP, it stimulates higher expression of mRNA relating to 3 channels: ENaC, ROMK, and sodium potassium. So you're able to block this activity if you give spironolactone. Acne as well. Yeah, it causes a dysregulation of all this type of reaction, a disbalance of everything in that sense. So that's terrible. But something that you'll see here is that there are drugs that do not cause this problem. There's some drugs that just block ENaC. Who remembers what is the name of that drug? They are also potassium sparing. So potassium sparing will have 2 different types of drugs. One responsible for the blockage of ENaC, eplerenone. Eplerenone. Yes. Perfect. So the mnemonic is SEAT. SEAT. The first 2. Well, hold on. No. Eplerenone. Let's be clear. Eplerenone and spironolactone both block aldosterone. Let's be clear. Both of them block aldosterone. The triemterene and amelioride. Yes, these are the ones. Yes. These are the ones that are blocking ENaC. ENaC channels being blocked by these type of drugs. So, of course, these type of drugs do not cause gynecomastia because they're not involved in any antagonistic effect of aldosterone receptors, any antagonistic effect of androgenic receptors. They're only involved with the blockage of ENaC. Now, ENaC and ROMK operate from the level of electronegativity. So if I block ENaC, guess who I'm also blocking? ROMK. Both of these channels will not operate if I block ENaC. Both of these channels are not working if I block ENaC. Remember that. They operate from the level of electronegativity. Good. We understand that. That's perfect. So going back to what we were saying, testosterone can become dihydrotestosterone or can become estrogen. It just depends on the enzyme that catalyzes this reaction. And we can manipulate this by giving finasteride. That way we block the HT conversion with finasteride. Now there's also a drug called anastrozole. Anastrozole blocks aromatization. Anastrozole blocks aromatase. Then you have finasteride for this one. Finasteride. So understand that manipulation that's going on there. Understand that, right? Let's not get confused. Yes, finasteride will inhibit 5-alpha reductase. Anastrozole, flutamide is a bit different. Flutamide will actually block. Okay, yeah, let's get into that. Let's jump into that topic. Definitely. Flutamide will actually block the androgenic receptor. Flutamide blocks the androgenic receptor. We'll talk about SERMs as well. We'll include the topic of SERMs. We'll include that topic down the line. Leuprolide to increase your GnRH in a pulsatile fashion. To increase your FSH and LH activity. Leuprolide is an analog. It's an agonist. It acts like GnRH and increases your FSH and LH. Yes, it works as an analog. It acts at this with this activity. Okay, but we'll talk about that. For now, let's get the differentiation here on to date. Let's place this correctly. So we just said the external, you have penis, scrotum, and prostate. So that all makes sense. That's all wonderful. But of course, we also have to mention the idea of the sexual characteristics like pubic hair and axilla, facial hair, all that type of development, right? That happens down the line during puberty. And there's different hormones that will play a different role in that sense. During this time of maturation and puberty, we are establishing the proper hypothalamic pituitary axis. It has to properly develop, it has to mature. We don't have the right idea yet. So many patients, female, can have amenorrhea. Like the time of their menstrual cycle can vary because of this. Like the most common cause, amenorrhea. Typically, you want to screen for any kind of abnormality. But at the same time, you also want to take into consideration that their hypothalamic pituitary axis might not be mature. And if that's the situation, that's the case, it fixes itself. It will eventually fix itself in that sense. So a lot of people have acne. A lot of people have deepening of the voice. Like everything starts to change. Pulses of GnRH vary when they start their menstrual cycle. Well, what happens here is Mona, you need to have a certain amount of continual stimulation to the follicles in order to mature your follicles properly. They have to become a primary oocyte. You have to have rupture of the follicle. And this could only happen when you have continuous stimulus of FSH, right? So this type of process does require a continual relationship, like an actual very responsible type of hypothalamic pituitary axis, something that can continuously keep pushing for the maturation. If you, let's say you mature it a little bit and then you just stop, the follicles will not rupture. They won't rupture, then it won't be any kind of ovulation. So anovulatory effect. During childhood is steady, but puberty starts pulsatile. Yes, it starts to increase. It starts to get to the point where at this level, you have to promote differentiation in hopes of getting a primary oocyte. That's the main goal there, to then have rupture. So the follicle that has the most FSH receptor, yes, basically. Yes, that's what happens. They have upregulation of receptors at one point while they're maturing. There's going to be a couple of them that stand out. And you'll notice that the one that wins is the one that's able to have more FSH in that sense, receptors. They were able to stimulate, to activate, to work on the FSH level. At the same time, you have a whole bunch of estrogen being released. Remember, when you have estrogen being released, whenever you have estrogen at higher levels, remember that we have to stabilize the uterine wall. The uterine wall must be stable, right? We have to create this wall. This wall has the spiral type of arteries that have to give life to this wall. When the menstrual cycle is terminated, you'll see that this wall is what ends up sloughing off. Sloughing off of this wall is what you end up having. Now, if you're having a menstrual cycle and the wall is not being built, that's because you're not having the proper amount of estrogen. That's because you're not having estrogen. So what ends up happening in that sense, they cut down on the FSH at some point, less FSH, so follicles that develop the most mouth to eat and it thrives. Yes, this is what typically will happen. It starts to thrive in that sense. But they do in the end need to rupture, and you need to have release of this oocyte in order for fertilization to occur. So remember that yes, the release of the oocyte, and you would have this sperm, let's say, would have to make its way, and then you'll have to have fertilization. Then you have your blastomere differentiating more and more, becoming your blastocyst. I don't know if you guys remember. Then it will eventually split into the syncytial blast and the cytotrophoblast. Yeah, it has to be fertilized in that sense. And what ends up happening is that you have proper attachment, and once it becomes cytotrophoblast and syncytial trophoblast, you'll finally have this connection. They start to connect to the arteries, and they start to release higher levels of beta HCG. So HCG starts to get higher in the body when it starts to attach. Once it's attached to the arterial system, it starts to it starts to release a higher level of HCG. So HCG gets released, and that's in that stage by the cytotrophoblast. Well, you have the syncytial trophoblast and the cytotrophoblast. Syncytial was when so the cytotrophoblast is going to become, let's say, the fetus in that sense, and the syncytial trophoblast is more like the the amniotic fluid, I remember, and the placenta in that sense. So yeah, I'm going straight from top of my head. Let me confirm that. When you look at the cytotrophoblast, which one will differentiate to that sense? Cytotrophoblast versus syncytial trophoblast. Those are going to be two tissues that have differentiation in that point. And then one of them will, syncytial is the vessels that come onto it and maintain the corpus luteum. The vessels, they do have a connection. I believe that the connection happens with the syncytial trophoblast. It's a very strong connection that does happen there. But the cytotrophoblast is more like the fetal parts. And then you have in between that amniotic fluid here. So one is like the connection of placenta to the system, and then the other one is the syncytial blast. So yeah, let me pull up those notes. Let me look at that. That idea is the idea of, I would say, when you are already going past the blastomere and blastocyst part of differentiation at this point, this section here. So yeah, this is more reproductive at this point here. Let me just see. Syncytial blast is the vessels. So yeah, no. Syncytial blast, I remember it splits into two. You have the placental area, which is more syncytial trophoblast. The placenta is what connects to the vessels, let's say. So you have the arterial connection from that area coming out of the placental area, let's say. And the placenta as well has aromatase and all these different types of enzymes as well that we need to understand. So it does play a very important role. So, but yeah, let me pull this up. Let's make sure we are on the same page when we're talking about all this craziness. 1 second. Wow, somebody is cooking. I can smell eggs right now. Kind of crazy, but yeah. 941 eggs. Okay. So the inner part, basically, which proliferates and divides into new cells to fuse and form the cytotrophoblast. Let me see. Yeah, so okay. The syncytial trophoblast is what will be responsible for implantation. So yeah, on the side of the implantation is the syncytial trophoblast. So that's the one that produces the HCG in that sense. That will be detectable. That's the one connecting to this in that sense. The proliferative layer is what basically maintains cell structure. So yes, the cytotrophoblast will develop. It will develop into placenta, and what else? The cytotrophoblast is hold on. Yeah, let me get this straight. Cytotrophoblast. So yeah, it's getting confusing. Hold on. 1 second. Let's see. Cytotrophoblast. Put up right here. The fetal origin. The cytotrophoblast comes from so from my understanding, I remember is definitely that the cytotrophoblast becomes a fetus while the syncytial trophoblast becomes the other part, which has to do with the corpus luteus produces HCG. So hold on. The corpus luteus. Okay, hold on. Follow. So the corpus luteus, remember, it gets stimulated. It does. It produces the progesterone. So you have production of progesterone. So but HCG at that point. So yeah, so this is a very convoluted topic if you think about it, because you do have to know the hormones and what stimulates what at this point. So when you have, um, let's say fertilization, um, the corpus luteus, I remember. So beta HCG. So one thing, let's keep this clear. Okay, yeah. Let's not get confused. Let's stay on the topic here. One thing that is important: the connection. That's why we need to maintain alive through beta HCG from the uh, trophoblast. So hold on. Yeah, this is extensive in this point. One thing I'll tell you is this: the outer layer versus the inner layer. I remember the cytotrophoblast is what creates, uh, let's say, the cytotrophoblast is like the fetus, and then the syncytial trophoblast, I remember, was the connection that we have here when it comes to the placenta and all this. So one thing that we have to remember is that the beta HCG does get induced into the body in this point by the syncytial trophoblast. So let's see what else I remember. Yeah, this here gets confusing. Definitely have to look this one over. This is the idea of the hormones and at what point exactly. That's why we need to maintain alive through the beta HCG. So the corpus luteus, you'll notice that at this point where you stimulate the corpus luteus, it doesn't produce HCG. Um, what you do have, the corpus luteus, is that HCG. So it says here, after the placenta produces its own progesterone to maintain the pregnancy. Yeah, but the idea of the cytotrophoblast, one thing we need to understand is this. So yeah, coming back to this, let's not get confused. Let's just tell you this. Cytotrophoblast. If we were to make this very clear, so one thing we take from all this information, all this abundance of crazy hormones, let's just take on this. The syncytial trophoblast of the embryo will be responsible for HCG production, right? We can all agree on that. Syncytial trophoblast will be releasing beta HCG. So much so that when we're taking like some kind of pregnancy test, let's say a female is taking pregnancy test, it's the HCG coming from this part, coming from the syncytial trophoblast that you're actually reading, right? Now, okay, we agree on that. Now, the corpus luteum, let's remember this. The corpus luteum is very important because it will start to produce progesterone. That's what will support the endometrial lining, right? When we want to have this endometrium for implantation, we need to support this with progesterone. Remember, it's progesterone. It wants to stimulate the pregnancy. That makes sense, right? Perfect. So that happens. That prepares it for implantation because this does need to stick to it. Although we explained it backwards, because first you have to have progesterone at a higher level in order to maintain this uterine wall. That has to happen. Then once you have the attachment, now beta HCG gets released. So does that make sense? Good. Perfect. Now, what takes over? What takes over this production? What takes over in that sense? What will, for example, once there's implantation, yeah, what takes over in this sense when you have now, let's say, I would say the placenta. Yes, perfect. Joy. Yes, that's what I wanted to get to. That is perfect. That's what I want to say. Yes, the placenta. The placenta says, hey, I got your back. I'll take over. Let's do this. Let's make this work. Yes. Yes. It's about 10 weeks. It's about 10 weeks. That's when you have now the placenta, 8 to 10. Well, what ends up happening is that it takes over, yes. And it does have to do with this type of function, which is great. So there's a lot of crazy hormones here and things we do need to understand, especially when it comes to menstrual cycle and it comes to actual fertilization and implantation and all this is happening. So many things can go wrong here. So many things can go wrong. Like there's like these specialized cells that are like cilia that are moving. That's what moves that ovum, that oocyte. It's moving due to this little wiggling of this type of cilia that you can find here. They wiggle all around. The wiggling causes a vibration that makes this move down the fallopian tubes. If there's any scarring of this type of tissue, then you won't have movement of this ovum, and then fertilization occurs at a more proximal level. That leads to ectopic pregnancies. And what ends up actually causing these scars, what would end up causing these scars, are recurrent infections of pelvic inflammatory disease. Right? Patients who have pelvic inflammatory disease because of chlamydia, gonorrhea, any type of these type of infections that start to cause damage of this types of cells, these ciliated cells, it's going to cause issues at this point where you will have lack of propagation. So what ends up happening is that these ovums that get fertilized, they tend to go and attach themselves to the nearest site because the propagation is not working. That wiggling is not happening. So that wiggling doesn't happen. And this oocyte goes all the way down towards the uterus. Well, it's not able to go all the way down towards the uterus, and it implants itself prematurely, leading to the idea of ectopic pregnancy. The ampulla, this is at the level, yes, this is where you'll find this issue here. But you'll realize amenorrhea, the patients will have these kind of problems. That's why we always try to go for pregnancy tests. Patients that are coming in with these type of symptoms, pregnancy test before anything, right? If it looks like they have symptoms, let's say, especially for step 2, remember this. If it ever looks like they have symptoms of an appendicitis and it's a female, and she tells you she is a virgin, she is not sexually active, virgin, no, nothing. She's working in a Christian monastery. She's a nun, yes. Pregnancy test. Yes, it's all about protection to yourself as well, right? As a physician, you must also be protected in that sense. So you want to have, just in case there's anything, you have the pregnancy test result. Okay. Definitely. Perfect. Okay. Yes. So even if patients are, let's say, get offended, what is going on? I've never done anything. Say it's not even for you, really. It's just a procedure that has to happen in that sense. So, okay, going back. Here we're looking at all this type of process here, and we said that, yeah, getting back to this portion, we talked all about these type of hormones. We talked about how they can establish some kind of maturity in this sense. And then we talked about the idea of philarchy is the idea of having breast development, right? You have that type of development, which you will notice happens because of estrogen. Higher levels of estrogen can stimulate this type of activity. So this is what happens in that sense. Remember gynecomastia? Gynecomastia can be physiological in two type of people, two types of demographics or age, let's say. Type of age, can tell me 2 ages where puberty is 1, and what other population? Well, not too much newborn in that sense, because newborn, yeah, they to measure gyno in newborn, it's more of elderly, the elderly type of patient in this point. Gynecomastia usually would happen at that sense. Does that make sense? Does that make sense? The two physiological positions where it can be physiological. The testosterone drops naturally at the age, let's say once you are over the age of 65, let's say the testosterone has a very, very low activity in that sense. And they can be manifestations of gynecomastia. So try to remember this. Hopefully this makes sense. Yeah, you have a sharp decrease, but I'm talking to you about like a really advanced type of age. Definitely. Okay. Good. This all makes sense. Now with female, when it comes to the female type of maturation, it's a lot easier. It's a lot easier, guys. All you have to remember is that first you had the undifferentiated type of gonads, and what ends up happening is that XX, you don't have XY. So what happens? These type of the ovaries, basically, remember you have your granulosa cells and you have your theca cells. Granulosa and theca. Yes. So you'll notice that you'll end up having a higher level of, so you'll have a higher level of estrogen, definitely. So let's just look at this. Let's go back and look at the actual physiological ability of cells to um, become estrogen. Remember that you have your granulosa and your theca. Granulosa, you'll have FSH activity. Your theca cell, you'll have LH activity. A nice way to remember this is just this. LH. For males, L, Leydig. Leydig. For females, that H, this H, theca. So the second letter here is H. So you see how the second letter for both, theca. And this one here, first letter, Leydig. Both of these are basically getting activated with LH, right? LH. LH. So let's take a look at that. How is that actually working? So if we were to look at it, we'll say granulosa will end up having androstenedione, and that goes through, permeates basically into the theca cell. Then you'll have your estrone, your estrogen, which will then crosses over, gets into the bloodstream. Then you have estrogen, definitely. Keep that in mind. And if we are looking at, let's say, for example, if we look at estrogen, the one estrogen that gets created in pregnancy is estriol. It's called estriol. That's the one for pregnancy. That's created by the placenta, synthesized by DHEA. DHEA, which differentiates, aromatizes, turns into estrogen. Definitely. Now you have estrone. Estrone, that's very strong in postmenopausal women. So yeah, it's DHEA. You have the whole idea of cholesterol breaking itself down. So let's be clear. Let's be clear. In the placenta, you are breaking down your cholesterol derivative, basically breaking this down all the way. Well, hold on. In the placenta, you have your DHEA, first of all. DHEA. This DHEA in the placenta will break down, aromatize into estrogen. Estrogen. Normally, what you do have, let's say, at the level of the periphery system, let's talk about the periphery system. If you have, let's say, for example, estrone, we can say, estrone is associated with obesity. Let's say you have a patient who is very obese. They end up having higher levels of adipocytes. Adipocytes are increased in a patient who's obese. So any type of androgen that's going through circulation, you'll notice that they will have high aromatase activity. So these androgens tend to aromatize a lot at a higher level. So patients with obesity tend to have more estrogen. This is the actual mechanism of anovulatory cycles, right? This is the actual idea of amenorrhea. Let's say amenorrhea. Why? Because the increase in estrone decreases your GnRH, turns off GnRH. This is a secondary type of amenorrhea, turns off your hypothalamic pituitary gonadal axis. This is the actual mechanism. And today we also mentioned that, just in case, anorexia. Anorexia, you have a decrease in GnRH. Decrease in GnRH in that sense. So yes, all of this type of activity will definitely cause a lack of menstrual cycle. Okay, continuing with this. Estrone, estrogen, all this type of release going on from the ovaries, leading to external female genitalia, promoting its characteristics. So clitoris, the labia, and the distal vagina, we basically continued the pathway that we were drawing before. That is going to be the external type of genitalia, and that's stimulated by estrogen. Okay. Now, as the females start to develop, they also have testosterone. They also have androgens, although their androgen levels are a lot lower than males. Males have a very strong range. I remember it's about 300 to 900. You can have a male have 3 times as much testosterone as another male, yet they're both in the normal range. So the level of testosterone is varies a lot. Let's say there's a lot of variation of that. Also, there's testosterone sensitivity. Some males are more sensitive to testosterone, while other males are less sensitive. So the number does give you a good idea, but you also have the idea of sensitivity. Yeah, there's some people that take exogenous type of testosterone, let's say for the abuse of drugs outside of it, like they taking steroids, let's say, and you'll notice that they can have type of reactions like acne, an increase in acne. Their sensitivity of testosterone is high, so they tend to react in a very abrupt manner, where there's now having acne located in their back, in their chest area, where they would normally not have this. The idea of acne, remember, is 3 things. You have to have 3 things in order to have acne. 3 things. One is going to be a pore, right? You have to have an actual pore created, right? Where this is like a home for the bacteria. So you have some kind of area where the bacteria could enter. You have Propionibacterium actini, which is an anaerobic type of bacteria. So it likes to hide. So you do need a pore so it can dig itself deep in there where oxygen is not available. And also you need to have food. So they love sebum. Sebum from the sebaceous glands actually allows this to have a better cycle. Remember when we talk about bacterial life cycles? Bacterial life cycles have a lag phase, a log phase, stationary phase, and death phase. In this sense, if you have an area of your skin that's basically has higher levels of sebum, higher levels of this sebaceous gland activity, you're creating a better home for this type of bacteria. It's able to eat, it's able to prosper and grow. So it starts to proliferate at higher levels. If it has a pore, it's found a home. And then it grows basically in this sense. It's able to grow. So you have the pore, the bacteria, and the sebum. 3 things that you have there, all available for this bacteria to basically manifest itself within a pore. And it starts to grow and it causes this type of acne. Now there's cystic acne, which means that its wall will be closed off. It successfully closes off its walls and starts to proliferate, that sense triggers the immune system. You'll have problems with pus and all these type of damage. But what ends up happening though is that if there's any type of rupture, let's say the person starts to pick at his face and rupture his face, the skin itself has a layer where there's stem cells that could regenerate the superficial layers of the skin. We have regeneration of skin. If I scratch my skin off, it's able to regenerate, right? Towards the last pieces of layer. The last piece of layer is just a piece of dead skin, basically. Remember? You have the keratinized type of tissue. But yeah, you're able to regenerate with your cells that promote this generation. What ends up happening is that if you have actual damage of this, if you scar this type of tissue, you will lack regeneration. So people who have picked on their face before and has damaged their layer, you'll notice that they'll have like small little holes, it looks like. Well, it looks like small little holes because of the lack of regeneration at that point. So what's the point of me mentioning all this? Well, I'll tell you one thing. There's actual treatments management that people are targeting for acne. So the best type of treatment that has the number one, I would say, results everywhere, the one that actually works is isotretinoin. Isotretinoin, which is known as Accutane here in this country. Isotretinoin, which is like a retinol type of drug, right? Like based on vitamin A. What it does is that it will basically turn off the sebaceous gland activity by hyperstimulating it. Yes, it can cause birth defects. So there's women who have to go on birth control in order to take this. Yes, they have a whole lot of different standards. Different places have created different standards. They used to actually have psychological testing in order to take this because they believe it increases suicidality. Women would have to go under birth control. They have different different types of strategies that were built in order to diagnose this type of drug. But at this point, you'll see that it all varies in this sense. It all varies. But one thing that is important is the idea that yes, it can cause birth defects. It does cause birth defects, and that can be the cream as well. It's not just the pills. So keep that into your mind. That's very important. But it does work. It shuts off the food. If there's no food, then you can't really have the bacterial growth. Food kills everything. If there's no food, it's done. If you don't have an access to proper nutrition for these life cycles of these bacteria to proliferate, then it won't grow. Now, the other types of medication that used to be used was, well, they still use them. Let's be honest, they still use them. Things like tetracycline. Why tetracycline? Well, they found, hey, tetracycline can destroy the bacteria. So the drugs are always going to be within those three things, the three elements that I gave you. The element of the pore, the element of bacteria, and the element of sebum. The best one is the sebum, the one that targets sebum. That's isotretinoin. Isotretinoin. The bacteria one was tetracycline. Tetracycline, what they love to use in that sense, and it's a terrible type of idea. Clindamycin is kind of dangerous because it's wide spectrum. Clindamycin has more of like a wide spectrum type of activity that will knock out a lot of bacteria in your gut as well. That can lead to issues with patients can have C. diff, right? Okay, you're saying a topical type. Okay, I can see that. The pore is going to keep is to keep good hygiene. Step 3 question on the pore. I saw that someone who was using like these things to exfoliate their skin that actually causes skin damage. Like there's evidence of a disruption of the skin. But pore, let's say keeping good hygiene, that's a good one. But pore, you see these over the counter things like oxy pads and all these things. That's the idea of basically forcing oxygen into the pores, oxy pads, all the types of medication. Yeah, Accutane is a very powerful type of drug. Dry out your face. Yeah, they have a lot of different types of over the counter stuff. Definitely. And also giving it a type of environment, changing the environment. So they also said acid. If you create an acidic environment, propionic bacterium won't be able to sustain itself. So they have all this benzoic acid, all these different types of applications that you can put on your face in order to not allow the proliferation of these these bacteria. So I always saw that throughout the years, it was such a terrible type of management or medication type of regimen that they had. The idea of trying to combat these bacteria when just decreasing the sebum, decreasing the food that it has was the actual right approach. That one there solves all the problems. So that will solve all the problems in the sense of acne. Isotretinoin is the best medication that can be used in that sense. So remember that it is a very strong drug. You can't tell your patients to drink or anything like that because remember, vitamin A is a fat soluble type of vitamin. So let's recall, vitamin A is actually something that can get stored in the liver in that sense. Remember, liver is able to store a lot of fats. Remember, fat soluble vitamins. You have A DEC, right? Is the derivative of vitamin A used in leukemias? Yes, you can use one of them for leukemias. Do you remember which one? I remember it was just going off AML. You have M3. AML M3. This is the M3 protein, the pro-myelocytic type. That is the one basically that will do this because differentiation of epithelial cells is something that you need to have vitamin A for. So yes, 1517 is correct. 1517 is correct. That is true. That is true. So one thing I will tell you is that vitamin A, okay, so hold on. Vitamin A, you also use this for a type of viral type of treatment. Does anybody remember what type of treatment? Oof. Yeah, we're going deep here. We're associating things. Measles, a measles type of infection. Yes, I do remember that. I do remember that you want to treat one of these with actual vitamin A. Was it rubella? Let's see. Hold on. So yeah, Yeah. I remember measles. Yeah, measles. You're right. Measles. So measles, great answer. Vitamin A predisposes you to it. Yes. Vitamin A predisposes you to it. Yes. Why? Now this is the important part. Why? Why is it that vitamin A will predispose you to these problems? Let's talk about that. Let's talk about that really quick. Antioxidant. Well, I wouldn't say too much in the brain. I wouldn't say too much in the brain. I mean, I know it does have antioxidative effects, but it's more of like the epithelial cells. I remember it was like the structure, like borders, like cells that have to do with borders. It has a very high antioxidant type of effect there. Yeah, antioxidant CSF production is true. Vitamin A does promote CSF production. You can see that in pseudotumor cerebri. Patients who are have more adipose tissue can have a higher uptake of vitamin A, leading to increase in CSF production. But really quick, let's look. Let's see this. Vitamin C has the ability. Vitamin C has antioxidative effects in the GI system. Vitamin E has antioxidative effect in the blood. I believe E was the one that's related to something in the brain. I remember that one has an antioxidative effect. For vitamin A, I remember it was the protection of epithelial cells, which is why you have to have proper vitamin A in order to not have measles. Like you have a low level of vitamin A, you're more prone to get it because it protects your epithelial cells. The idea of your squamous type of epithelium in that sense. Yeah, if you have vitamin E deficiency, yes, vitamin E deficiency. Let's remember, vitamin E deficiency will cause a problem. Where exactly? Let's see. Let's see. Remember, we have this. We have this. All right. So we're looking at this exactly. Remember, back here we have your dorsal column, which is composed of the gracilis and the cunatus. The gracilis is the ones located in the middle. That has to do with your lower extremities. Remember, right next to it, you have your cortical spinal tract. This has to do with contralateral spastic paralysis. If you have damage of the cortical spinal tract, contralateral spastic paralysis. Then down here, you have your anterior horn. This is where your peripheral nerve will actually start. And then remember, it goes all the way towards the specific type of muscle that you're trying to engage. So your peripheral nerve, you can name it by the column. If this is like a C5, you'll say, oh, C5. This is anterior horn activity. Right next to the anterior horn, you have your spinal thalamic, the lateral spinal thalamic tract. This has to do with pain and temperature. Spinal thalamic is sensory. Remember, spinal spins. The actual spinal thalamic tract is picking up the information from the opposite side. Remember that. Then on the sides here, you have your spinocerebellar tracts. Spinocerebellar tracts. Spinocerebellar tracts, let's remember that has to do with proprioception, but it has to do with the unconscious type of proprioception. The unconscious proprioception is the type you use to ride a bike. It's the type that doesn't rely on your vision at all. So this type in the posterior column, it's the conscious proprioception. It does utilize your vision as part of the factors for proprioception. It does use your vision as part of the factors for proprioception. So for example, when you're doing a Romberg sign test, you tell your patient, hey, close your eyes. And if they fall over towards the side of the lesion, it's because they have a problem with the dorsal column. Yes, sensory ataxia versus cerebellar. Yes, if they fall over, if they close their eyes on Romberg test and they're falling over, that means that their proprioceptive problem includes the characteristic of vision. It includes vision. That means it's a dorsal column problem. It's a dorsal column problem. It includes vision. If they're falling over the side of the lesion without them closing their eyes, if they're falling over when they close their eyes as well, then yes, spinocerebellar tract is involved. Spinocerebellar tract will be involved. So yeah, that's the difference between those two. And remember, cortical spinal tract is upper motor neuron problems. Upper motor neuron problems. So I'm going to repeat it. I always preach this to my class. I always tell them, hey guys, when you have upper motor neuron problems, hypertonia, that is not the same as muscle strength. Both lower motor neuron and upper motor neuron, both of them will have muscle weakness, but the tonicity is increased with upper motor neuron. The tonicity is decreased with lower motor neuron. the reflex hyperreflexia. And then remember that one little sequence, that one little weird type of symptom that appears in both. Remember this one thing. Lower motor neuron, fasciculations. Fasciculations. Upper motor neuron, Babinski sign. Babinski sign. Okay? Get that out 100% into the opening. To expose these problems, definitely. Now, cerebellar type of symptoms. Who can tell me the symptoms of the cerebellum? Let me just start off by just giving you one and say dysmetria. Dysmetria, dysdiadokinesia. Issue with rapid alternating movements. You can't create alternating movements. The tremors, intention tremors, I would say. I would call it intention tremors. Ataxia, definitely ataxia. So let me give you a little clue, little aspect here when it comes to this. Let's take a look at this. Imagine the cerebellum looking like this, right? This is what I love about the cerebellum. The cerebellum follows the shape of the human. For example, if I put this guy right here, he's a little shy. Look at his smile. When I open his arms like this, and notice this, if you have damage here in this far away part, you'll have far away damage as well here. It matches. The middle area, the medial area is called the vermis. If I damage the vermis, I should have truncal ataxia. It should be truncal ataxia. The guy looks like a drunk in that sense. He's shaking like this. Yes. Yes, definitely. Look at this guy. He's hugging you. Yeah. So let's see. Definitely. If it was Dr. Batista, we have to put a little beard on him, definitely. There you go. He can't be bald. He has to have hair, of course. There you go. There. Now, yeah, that kind of looks like me. I'm not going to lie. It kind of does there. Yes, perfect. So there you have the hug. And you're looking at it right there. The middle portion here, you have truncal type of ataxia. Outside here, you'll have the limb type of ataxia, right? This is like the fingers, basically. These type of tremors that you can process. But yes, this diadokinesia, rapid alternating movements, you can add that in there. Nystagmus. Ooh, nystagmus. So nystagmus, let's talk about nystagmus. Nystagmus likes to happen a lot with cranial nerve 8 type of damage with the vestibular. So the cerebellum itself is highly related to the proprioceptive type of function, but we do have this vestibular system that is it's very different in that sense. Because remember that, yes, the vestibular side of, let's look at it like this, vestibular. Imagine we have some kind of fluid near our ears, and wherever we move, the fluid can tilt. So vestibular is very important for understanding one thing. It's important in the sense of knowing the things outside of us, like our relationship of the objects and everything, the world outside of us. So notice that we're on sea, when we're on like the ocean. The vestibular system is experiencing some kind of irregularity where that water, we're moving, but it's like our body is not moving. Like we're keeping our body straight, but yet the vestibular system is being modified. So patients tend to get in some kind of motion sickness, they'll call this. The vestibular system has to do with balance, but it also has to do with this one thing I'm going to tell you. Notice this. I can keep my eyes straight looking at the camera, and I can move my body all over, but my eyes are staying at the same place. You see that? That's because of this vestibular type of system. Yes. Basically like this, all over. But the eyes are staying in one place. So think about the coordination that's taken into consideration there. It's kind of like the MLF system. Cranial nerve 8 has to do with the MLF system, something that people won't basically preach. But try to remember this, guys. If I have, for example, frontal eye fields, that's the neutral idea of where our eyes are situated. So neutrally, our eyes will be situated in one spot, let's say, because of the frontal eye fields. Yes. If you have damage of the frontal eye fields, you would look towards the side of the lesion. That typically happens with MCA type of injury. MCA injury will show you looking at your lesion. You will be creeping over and looking at your lesion. That's the frontal eye field. Okay. When I talk to you about the idea of you moving around and having your eyes in the same place, that's more of the vestibular type of action. If you damage the vestibular system, let's say, you can have nystagmus. You can have nystagmus. So let me write this out really quick, just in case so you guys can remember. Remember that we have, so if we look at the brain like this, let's just take a little look at the brain right now. Let's understand this. I don't know how we ended up getting to neurology. I really don't remember, but I can tell you it's my favorite subject. So once you guys got me started here, of course I'm going to keep going a little, right? So let's take a look at this. Let's say this is the brainstem. Okay, I inclined it a little bit more from placenta to acne to cerebellum. Yeah, I think it had to do with vitamin. It had to do with vitamin E, I think it was, or vitamin A. Not sure. Yeah, definitely, definitely. But let's look at this. Here, I'll tell you one thing. You have the central sulcus. So the central sulcus will divide the primary motor cortex. Primary motor cortex. Right behind that, you have the sensory cortex, right? Yeah, definitely. Definitely. Now, I'll tell you why this is necessary. The real exam is also jumping from subject to subject. You'll see one question based on neural. Next question was endocrine. Next question was reproductive. And you have to be able to, your mind has to be able to jump around, but you have to also be able to connect a lot of connections. Yeah, you have to form a lot of connections. So right now we're looking at the primary motor cortex. The frontal eye fields will be located in front of this area right here. You will have your frontal eye fields. The primary motor cortex is right here. Remember, when we split it open, we have the homunculus. It'll look a lot like this. And in the middle area here in the homunculus, here you have irrigation of ACA irrigation. Now, towards this side here, towards these sides over here. So this is all, let's say, ACA. Now, if I go towards the side, yeah, this is the occipital around here. If I go towards the side, this is MCA. MCA right here. Okay, perfect. So lower limbs, sphincters, yes, is ACA. That is correct, lower limbs and sphincters. So just remember this guy. So here, remember again, Dr. Batista right here. He's back with his little beard and his hair. Remember him. He's having M, look at M for MCA. This MCA is your upper extremities, also the torso area, right? The trunks, the upper extremities, and the face. It's all MCA. MCA. ACA is the bottom. The legs, the pelvis, all that area, right? ACA. Okay, so remember this and connect that definitely. That makes sense. But now we're talking here about the idea of the homunculus. We mentioned the homunculus. We're talking about all this action, but I'll tell you one thing. Here we have splitting. This is the best part about it. This is ACA, we said, but the nucleus here, they change. You have different types of nucleus. MCA here, I mentioned, was the face and the trunks and the upper extremities, all this area. But I'll tell you one thing that's very important. This area here, the nucleus that we find here, are going to be cortical spinal tract nucleus, all of this area here. The area here that pertains to the face is cortical bulbar tract. Cortical bulbar tract is a tract responsible for sending the depolarization signals towards the nucleus of the cranial nerves, the nucleus that are motor. The motor nucleus of cranial nerves will actually have stimulus via the cortical bulbar tract. And this is where they're born. The activity of sending the message off towards the upper motor neuron. This is the upper motor neuron. All these little dots that I drew here are known as the upper motor neuron. Just in case you guys ever wondered and were curious about what in the world is the upper motor neuron, this is it. These are neurons that are actually located in the primary motor cortex. These are the neurons. This is where you get the idea of moving around. So all this idea comes from this area. Here you're seeing upper motor neuron that's actually sending the information off towards cortical bulbar tract. They call these pyramidal tracts. Both of them together. Okay. Gigantocellular Betz pyramidal cells. Well, I'll tell you one thing. They make their way down. They are descending. So they have to descend to the brain stem, right? They have to go down the middle portion of the brain stem. You have to have all this going down towards the middle portion of the brainstem. Remember that. They have to go down the middle portion. So here you have midbrain. They cross lower the 1/3 of the medulla. So check this out. Yeah, so but that's what they would tell you in the books. I know it's kind of crazy in that sense, but I'll tell you one thing. Uh yeah, below the medulla. That's what would make sense. So I'll tell you one thing, for example. Yeah, decussation. Decussation. Okay, so yeah, let's make sense of this. So yeah, I'll show you guys a question that will blow your mind after this after this explanation, because it does get confusing. So I'll ask you one question then. If I have damage, for example, well, actually, no, we'll talk about it. I'll show you a question that will contradict kind of what you guys are saying on the MBME, and then we'll explain it properly, just so you guys don't get this question wrong down the line. Kind of goes against what we have learned. Okay, remind me that just in case we get lost in the sauce of all this. So, okay, all I'm saying is that the cortical spinal tract, the cortical bulbar tract, it does actually go down towards the middle. Yes. Remember, you have midbrain, you have the pons, and then you have the medulla. Yes. You have this type of activity going on here. This is the brainstem. This is the colliculus, the superior and the inferior colliculus. Right? All you guys know this, right? You guys are already tired of seeing this, definitely. Remember, the pineal gland is back here at this area. Pineal lomas will push this area forward, causing sunset gaze and these kind of issues. But okay, that's Parinaud syndrome. But yeah, that's Parinaud syndrome, definitely. You can see that from pushing this forward. Remember that here you have, right, the CSF is able to also pass down through this one area. You have the cerebral aqueducts located here. This part of the midbrain. On top of the midbrain, we do have, cranial nerve 3 palsy problems. What type of cranial nerve 3 palsy? Let me know, Amna. Tell me, what type of cranial nerve 3 problem will we have? Let's see if you remember. I know it's a tough question. It is a tough question. First, parasympathetic, then motor. Yes. Yes. Why? Remember this, guys. Remember this. Edison-Westphal nucleus is in the outside, and the general somatic efferent is in the inside. So if I have something pushing, like I said, anything that pushes, it can be a hernia, it can be a tumor, it can be, yes, you'll have blown out pupils. That's the parasympathetic type of issue, blown out pupil. Yes, definitely. Now, if it keeps getting worse, if this push is entering more and more towards the general somatic efferent, you'll have down and out, down and out. General somatic efferent is actually giving innervation to the medial rectus, to the inferior obliques, to all the other types of muscles. Yes, the only muscles then down and out because of unopposed. Yeah, the only muscles that you'll see that actually have the innervation of these ocular muscles, you'll see lateral rectus, superior obliques. Lateral rectus is cranial nerve 6, superior obliques, cranial nerve 4. Well, all other rectus and upper obliques, all of them are under the rule of cranial nerve 3, general somatic efferents. So yes, hopefully everybody understands that. Hopefully that makes sense to everybody. Okay, that's good. That's good. Now let's continue. So yes, here we're talking about all this type of issue, all this type of problems. Going back, we just said one thing. So now let's add a level of difficulty here for everybody. I know this is a little bit too easy for everyone, so let's add a level of difficulty. There is going to be a communication. There is going to be a specific type of communication that we need to be aware of. One communication is the idea of the upper motor neuron that's traveling down these tracks. They're traveling down the tracks towards the midbrain, the pons, and the medulla to make its way towards the pyramids in order to have decussation. Well, yeah, before we get into that, we're talking about just the idea of these tracks, the tracks coming from the upper motor neuron, making its way down. Really quick, let me just mention it like this. Cortical bulbar tract coming down, remember? Midbrain, pons, medulla. Okay, yeah, that's what I'm going to jump into next with the PPRF. Definitely when we talk about the MLF and the activity that you have there. But looking at this, there's one structure where it must pass through. it must pass through these one type of structure. Who remembers what this structure is? It's an internal brain structure where your cortical spinal tract, your cortical bulbar tract must go through. It's a very narrow type of structure. So it is prone to have issues. It's prone to have obstructions and problems. Who remembers this structure? Internal capsule, posterior limb. Yes. Good, good, good. Perfect. So let's understand that. Let's get this into our brain 100%. Yes, she's right. The brain itself. We talked about all this type of cortical bulbar tract making its way down. Well, guess what? Cortical bulbar tract and cortical spinal tract, they are packaged, specially packaged into the internal capsule. Here you have the anterior internal capsule. Here you have the posterior limb, and then here you have something called the genu. Think about genu like genuflex, like bending your knee, the genu. So yes, good. Well, yes. So yeah, let's understand this. Here at this level, the posterior part is the part that will contain the specialized tracts of the cortical spinal tract. Basically, it's located here, the posterior limb. In the genu area, the middle area here that we're looking at, you have the cortical bulbar tract. So just to summarize, this right here is all motor. The only thing that has anterior is going to be the sensory. Sensory will have the anterior. Well, the anterior has the sensory. Okay. So the sensory actually has irrigation by the medial striate arteries, the medial striate vessels, Medial striate vessels are a branch of the ACA. ACA has a branch called the medial striate vessels. Now, the medial striate vessels gives irrigation to this part, to the anterior part. Okay, this is what causes, let's be very clear here, pure sensory stroke that spares the face. Spares the face. Why is the face being spared? I'll tell you. Because the space did not get packaged into the anterior or the anterior limb. Why did it not get packaged? Because in your thalamus, you have several types of nucleus. You have the VPL, the VML. The VML, let's say, is responsible for the packaging of the sensitivity of the face. So what ends up binding here? What ends up making its synapses here? The spinal, the trigeminal. Let's just say the sensory tract, the sensory part of cranial nerve 5. Remember, cranial nerve 5 has dual function. It's motor and it's sensory. The sensation of the face, the sensation of the tongue. So all that sensation, it's making its way to the VML. The VML. That's where it makes its way. It's ascending towards that path. Now, this one here has thalamocortical tract, which ends up going to the cortex, yes, to that sensory area, yes, but not through the internal capsule. Not through the internal capsule. Now, the VPL is different. The VPL is the sensation going towards the body, the sensation of the body. Here, you're going to have the dorsal column medial lemniscus binding here, and also the spinal thalamic tract. Both of them have their home here in the VPL. So the VPL does get packaged in the anterior limb of the internal capsule. The anterior limb of the internal capsule does package this VPL. So all that makes its way up there. So if you have damage of the anterior limb, you'll have sensory problems. Now, let's be very clear. This area specifically of the thalamus has irrigation from the PCA. PCA. Yes. So if you have a PCA, an internalized vessel of the PCA, the small vessels of the PCA, if you actually have some kind of stroke here, you'll have pure sensory that includes the face, right? So we just call it pure sensory. Pure sensory. Pure sensory. Awesome, awesome. Both of them are included here, face and VPL. Definitely. Good, good, good. So let's continue. Let's continue. So what happens if your patient gets this type of stroke and let's say they get a lot better? Oh man, they start to feel a lot better. Everything is going good. And they ask you, hey, am I expected to get any problems? What could happen? What are the potential types of complications that a patient can have just by having this type of stroke? Post-thalamic pain syndrome is 100% correct. Yes, yes. Patients can now have pain on the opposite side of their body. They get this. Was it the opposite side? Was it the same side? I believe it was the same side. I believe they get pain on, and it's after they're getting better, basically. So think about that. You're getting a lot better from a stroke. You're improving. Your condition is getting better, and then out of nowhere, you get this very strong pain, and it happens for months. So that sounds grueling, but that's post-thalamic pain syndrome. That can happen after some kind of thalamic type of stroke like this. So let's remember that, guys. Let's remember that. That's perfect. That is perfect. Okay, so then we talked about going down the line. We talked about the actual down here. We talked about this activity. So really quick, I'm just going to tell you midbrain, pons, medulla. You have to know the distribution. You have to know everything. So I'm going to show you guys a real image just because nowadays they're using real images. Nowadays you're getting real images. You're not getting these fake little circles. You're getting something that looks like this. All right? You're looking at the midbrain right here. This midbrain structure, you can slice and dice it, cut it into 3. Here you're having the tectum, which is back here, tectum. Then you're having your tegmental area, which is here, tegmental. Then you're having your crux cerebri. This area here is the crux cerebri. So let's understand here what's going on. This midbrain area here, it's a very important part of the brainstem, very important. You have your red nucleus right here, red nucleus. And yeah, you have your cranial nerve 3 basically coming out of here. So we can say cranial nerve 3, just to generalize here. I don't like to generalize too much, but we're saying cranial nerve 3 here, 4 here. And as we make our way down, we have the pons. Wow, the pons is so important because the pons here has something called the reticular activating system. The reticular activating system, which has to do with your suprachiasmatic nucleus, which has to do with the diurnal pathways. Yes, lucency, diurnal, let's say recognition. When is it daytime? When is it nighttime? This is all stimulated by norepinephrine. All stimulated by norepinephrine. So there's these cells called the locus coeruleus cells, which are responsible. They're the catecholamine type of cells that are responsible for releasing norepinephrine. And you'll find them in these areas. They're found in these areas. So you're able to actually stimulate norepinephrine for wakefulness. This is having a direct connection to your retina. As crazy as that might sound, yes, your retina is what's involved here. So you're able to pick up light stimulus and you're able to activate this system. This is a very important system because with this system, you'll be able to maintain your cycles of wakefulness. Okay? If you ever damage the reticular activating system, if it ever gets destroyed completely, patients can be in a coma. They can be in a coma, right? There's types of hernias as well that affect this type of this specific type of part of the brainstem. Keep that in mind as well. So this is very important. You should know that the brainstem is the most delicate part. If you damage this brainstem, let's say, the consciousness of the patient is at risk. Okay? And right in the middle, yes, you have cranial nerve 6 activity. You have PPRF as well located here. The pontine, the paramedian pontine. What else does it stand for? Someone with good memory, let me know. The paramedian pontine reticular formation. Reticular formation. Very close, Adna. Yeah, very close. The reticular formation. Yes, definitely. But without a doubt, that area there, this is also engaging in consensual eye movements. Your eyes have to move properly. If you're moving your eyes to look towards the left, you're operating with 2 different types of muscles. You have your lateral rectus, which is going to displace the eyeball towards the left. And then you have your medial rectus, which is cranial nerve 3, moving your eye towards your nasal area. Does that make sense? So INO. So what is INO? INO is related with what type of disease? Does anybody know? What type of disease is related to INO? Can anybody tell me? MS. So what is the pathophysiology of MS? What causes MS? I mean, what is happening in MS? What can I say there? If I'm going to explain MS to somebody and I have to tell them what the actual problem is, what can I say? MS is oligodendrocyte. So you have you have an actual problem with your oligodendrocytes, right? Your oligodendrocytes. And what's crazy is if I were to put this in a hypersensitivity type of problem, I would have to say, what kind of hypersensitivity is it? Because it is some kind of immune issue, right? No myelin to central nervous fibers. Two, mm, not two. Not three. No. At the end of it all, I know it's weird, but it'll classify itself as four. Yes. Right? If it's not that, four. I mean, if it wasn't four, it'll be one. So let me just tell you guys. I'm gonna explain this to you. Yeah, it is kind of weird. Let me explain to you guys. If you have damage, so typically, yes, I remember I was talking to Mona about this. She asked a question about this before. I mean, a long time ago, a very long time ago. She asked a question about some kind of type 4 reaction, and I remember this. Yeah, so I read about this. If you have damage of a specific type of tissue, let's say you have a type 2 type of hypersensitivity, which is causing, remember, type 2 hypersensitivity causes 3 different types of reactions. What are the 3 reactions for type 2? You have either destruction of the cell, destruction, right? Is going out there to destroy. Or you have agonist effect, which binds a receptor and then acts like an agonist. It stimulates that receptor, like a second messenger system will stimulate it. Or you have antagonistic effect, right? This is for type 2. Type 2 will have these type of reactions. Okay, so yeah, let's just remember. Agonist effect, I can give you an example like Graves' disease. We remember Graves, right? Graves' disease. Antagonistic, something like myasthenia gravis, right? It's going to bind the receptor and it's going to act as an antagonist. Okay, now the main one that we're looking at here is destruction. GBM is there, right? I'll tell you the thing with GBM. GBM is actually causing destruction. So yeah, it causes destruction, but it causes destruction of the cells responsible for myelination at the peripheral level, which is Schwann cells. Schwann cells are responsible for myelination at the peripheral level. It's not agonizing or antagonizing. It's just destroying, straight up destruction. So typical type of destruction that we could run into is the idea of the autoantibody binding to any type of structure, let's say, but then complement system activating itself. Remember, we complement women on their legs. The leg right here, the leg is where a complement will be activated. Remember, down here is the FC portion where you actually activate macrophages. Good pasture. Good pasture is also targeting the glomerular basement membrane. Well, the type 4 collagen. It's targeting the type 4 collagen. Yes, the type 4 collagen. The basement, the floor. Remember 4 under the floor? Yes. So, yes, base membrane, definitely. That's for a good pasture. Remember, good pastures has a linear IgG. Linear IgG you can find in this area. That's what you have for that type of activation. Remember, outports is more of a deficiency of your type 4 collagen. If it's deficient, it starts to rip apart. So it starts to rip. That's the difference. Thinning, yes, you have thinning. It starts to rip apart. Lens, kidney, cochlea in outport. Yes, can't pee, can't see, can't hear the B. That's what you have with that one. Unlike riders, which can't see, can't pee, and can't bend the knee. Remember that. But here we're looking at this activity here with this type 2 hypersensitivity. You have complement that activates itself, complement. And let's try to remember something, ladies and gentlemen, something very important is that complement has different types of activation. Remember, you have the classical pathway. This is going to be classic. This is the classical pathway. Classical pathway is the pathway that activates when you have immunoglobulin and antigen forming this type of complement. Right? That's what you have there in that sense. Now, alternative pathway is the pathway where complement is acting like an antigen presenting cell. It's acting like a soldier. It's straight up going to a microorganism and trying to attack it. That's when you have your alternative pathway. This one is a lot more random. This doesn't have this type of affinity for all this, but it does do this. And it's very important that it must do this. Why? Because we have encapsulated type of organisms that aren't really presenting their LPS. Remember, you have LPS. These are your PAMP, your pathogen-associated molecular protein. LPS is usually demonstrated to, without the paperwork in between. Yeah, so it doesn't have that immunogenic type of thing that will trigger it, like we do tend to see when we have toll-like receptors that are found on macrophages. They usually like to bind to the PAMP, which is LPS, on gram negatives. Now, just a side note, LPS, LPS, this is lipoprotein, lipopolysaccharide. These are a group of proteins. You have antigen, you have something called lipid A. Lipid A. This is what will trigger a response, lipid A. So toll-like receptors trying to bind lipid A. This is on gram negative. There is one specialized type of PAMP that is different. And you can find this on gonorrhea type of infections. Instead of LPS, they have LOS, lipo-oligosaccharide. That's a different alternative PAMP that you can find on another type of gram negative, which is on the gonorrhea type, the coccus type. Now, also, let me also include, for gram positive, they have teoic acid. Teoic acid, that's what we have to bind the toll-like receptors, teoic acid. That's their PAMP. That's their version of PAMP. We bind this version of PAMP. That's what we bind with the toll-like receptors. But okay, all I'm telling you is that complement, since encapsulated organisms can hide, they can hide a lot better. So encapsulated organisms, the way that we try to destroy them is either complement can step up to the plate and destroy it, complement, or you'll go to the spleen, and the spleen will actually have this very strong filter that will identify encapsulated organisms and destroy them, which is why patients who lack a spleen, for example, a splenic type of patients, let's say you had an autosplenectomy because of sickle cell, we have to give them vaccines. You have to give them those type of pneumococcal types of vaccines. Anything that has encapsulated organisms on it, they have to get vaccinated for it. Remember, even some killers have pretty nice capsules. So things like, let's say, if a vaccine exists for it, we give it. We don't have like vaccination for E. coli, but these are the encapsulated organisms. You have strep pneumo, we do have a vaccine for that. The conjugate and the polysaccharide, right? The 23 and the 13 one. Then you have Klebsiella, H. influenza, Pseudomonas, Neisseria meningitidis, and Cryptococcus. Cryptococcus is the only fungus which has a capsule. You can see it on the India ink. It looks round. It looks like this. And then, of course, with the other S, you have the Salmonella. So yes, Salmonella. We're seeing all this type of encapsulated type of organisms. Complement can step up to the plate and try to destroy them. That's why whenever we have some type of complement deficiency or a complement problem, we tend to see meningitis. We tend to see issues here, right? Our body uses complement to try to avoid the meningitis issues. So whenever complement is gone, you tend to see anything that here in this list that can cause meningitis is now prone to cause more of it. So let's keep that in mind. But going back, we were talking about the alternate pathway and all these different types of pathway. Let's get back to this. We're talking about the idea of it being a type 4 hypersensitivity. I'll tell you what happens. If you have type 2, right, and you're causing destruction of some type of tissue, what tends to happen is our immune system starts to respond. It starts to respond to the activity of immunoglobulin and binding its own type of cell. Like, we don't recognize what this is. And if your immunoglobulin starts to bind to our own cells, it can trigger a type 4 type of hypersensitivity where T cells will be involved in hopes to try to destroy this. T cells then get involved. So whenever you have a Th1 type of activity, whenever you have Th2 type of activity as well, you could then say, okay, well, this is now becoming a type 4 type of hypersensitivity. That's the problem. So if you look it up, you'll see that they might tell you it's type 2, they might tell you it's type 4, or they'll tell you it starts off with type 2 and then ends up with type 4 for MS. So MS hypersensitivity. Usually the correct answer, well, definitely the correct answer is that it is a type 4 because, yes, it triggers T cells. T cells, once you have T cells triggered in a hypersensitivity, we call that type 4, right? That's the delayed type of hypersensitivity. Does that make sense? Yes. Definitely. I'll repeat it. So there is this kind of mechanism that is super weird because it's a mechanism. Yes. Yes, definitely. So let's see. Of hypersensitivity. So yeah, let me put it to you right here. So let's take a look here. So look, you have certain types of autoimmune process that end up being type 4. Well, let's make sure we understand exactly what happens here. How does it become this type of activity? Well, you'll notice that you'll start to attack the cells. Let's say you're attacking oligodendrites. Let's say you're attacking them with your immunoglobulin that's situated in such a situation that it's basically coordinated to attack this. Yeah, sad story. It is attacking it. It's destroying it. What ends up happening in this sense is that T cells start to recognize this destruction. To them, this destruction is kind of weird. They're saying, what is going on? What type of cell is this? What is being attacked here? So they start to activate. They start to activate in hopes to get rid of this attack. The problem is that when they start to activate, and remember that the hallmark of type 4, what is the hallmark of type 4? I always remember poison ivy. That's the best one that I could attach to type 4. Because in poison ivy, you're not really attacking that urushiol. The urushiol, you're not actually attacking that. What's actually going on is that you're attacking the skin that has urushiol. That's the problem. Does that make sense? So in MS, you end up having a stimulation that ends up attacking your oligodendrites. And then that stimulus provokes your T cells. Your T cells then start to attack your, let's say, oligodendrites or whatever is attacking it as well. And then you end up having that type 4 sensitivity. You provoke your T cells into a reaction. That's what ends up happening there in that sense. So when you do have a type 4 hypersensitivity, it's more of a Th1 type of reaction. Th1 type of reaction, which will stimulate an attack there. You're going to see that it starts to attack this in that sense. You're thinking MHC1. You're thinking MHC1. Both Th1 and Th2 are CD4. Both of them are CD4. You see what I'm trying to say? CD4 activity. So let's take a look at that. Let's take a look at that. Let's drive this in. So let's do a little recap of immuno really fast. Let's say I have a threat. Let's say, for example, there is macrophage and then there is a gram negative. Okay. Let's say we react here. There's a reaction here. So what happens is that you will release NFK beta. NFK beta is an immune modulator. NFK beta increases the release of cytokines. So what type of cytokines are we talking here? IL-1. IL-1 is a very strong acute type of cytokine. It does a lot of different types of activity. We'll get into it. One of the things is that it's very pyrogenic. It causes fever. It does cause fever. It stimulates the hypothalamic type of nucleuses that are involved here with increasing your body temperature. Now you have IL-2. What is IL-2? What does this do? What is the job of IL-2? What is it actually doing? Osteoporosis is involved with inhibition, let's say, the idea of inhibiting NFK beta. But yeah, we can get into that topic as well. Just mentioning that. Yeah. IL-2. So IL-2 stimulates T cells. Yes, it does. T cell proliferation. That is 100% true. T cell proliferation. It goes in and activates more and more T cell release. Okay. That is something super important. Now, there's a lot of drugs that involve inhibiting this reaction. There's a lot of drugs involved in inhibiting the cascade of activity for IL-2. Why? Because T cells, when they tend to respond, they can cause hypersensitive type of reactions, especially when it comes to rejections of implants, right? We want to have our T cells at a low level. That way it does not react. Does that make sense? T cell proliferation is guided by IL-2. I would even dare say that this is the most important one out of all of them. So much so that if you have an IL-2 type of deficiency, you can have those serious type of immunodeficiencies. You remember those immunodeficiencies that are involved, the congenital types? If your IL-2 is not functioning, it can lead to something very severe, let's say. Like a severe combined. Severe combined, I will tell you, like the SCID, for example, in this sense, SCID has two different types of etiology, two different types. We see IL-2 receptor. So the receptor of IL-2 is involved here. If IL-2 receptor is involved, yes, and then you have your ADA, your adenosine deaminase type of enzyme. Remember that we have the de novo pathway. We have the de novo pathway. De novo pathway is very important because here you're making your nucleotides. You're making purines and you're making pyrimidines. Purine and pyrimidine. Remember that your pyrimidines are pi. Well, we'll cut the pi. So CUT, cytosine, uridine, and thymidine. So in the pyrimidine pathway, when you're making these kind of nucleotides, you'll notice one thing, that the pyrimidine pathway is associated with a lot of myelogenous type of derivatives. Myelogenous derivatives. So you're going to notice that a lot of RBC are being made because of the pyrimidine. They're using this cycle more than anything else. If we compare this with, so de novo favorites more purine, therefore, within the cell. So look at this. Purine, for example, is going to be a lot more of white blood cells. Yes, lymphocytes. A lot of lymphocytic activity is happening here with the purines. I'm not saying that it's going to be, yes, white. I'm not going to say that it's going to be exclusively, but I'm going to say that it favors more of purine activity. So what ends up happening at this sense is that you need to have a recycling process here. You have to have a recycling process. You have to be able to use your adenosine over and over again, right? You have to take it up and use it over and over again in this type of purine synthesis. So adenosine deaminase is an enzyme responsible for catalyzing this reaction. It allows you to take your adenosine, which will get broken down. It allows you to reuse it over and over again. That way you don't have to make it from scratch. So the purine pathway does this. The issue is if you cannot make recycling process happen, then you will have a lack of purine synthesis. And this affects lymphocytes more than anything. That's why ADA deficiency can cause SCID. You're having a deficiency in the blocks that you use to make your, okay, so it says chronic cutaneous candida can be also because of IL-2. No, not really. I'll tell you why. Because IL-2 is going to cause as well SCID. There's different types of SCID. The X-linked recessive is the most common type. The X-linked recessive is the most common type. The X-linked recessive one has to do with IL-2 receptor. So you need the IL-2 receptor to work. IL-2 receptor needs to work. Now, I'm going to ask everybody, what is the second messenger system of IL-2? Remember, it is a cytokine. Remember that it is a cytokine. Does anybody remember? Cytokine. IL-2 is coming to the cell and is trying to bind. So somebody says GQ, somebody says JAK, non-tyrosine kinase. We have different answers here. We have different answers. I'm going to tell you straight up. Remember non-tyrosine. Remember this non-tyrosine kinase type of activity. Remember that we talked about the idea of having the mTOR pathway and having that other type of MAP kinase pathway. You guys remember that with insulin? You guys remember that? Okay, yes. This here is very important because this is a cytokine. And I'm going to mention it just to make sure everybody's on board. All the different types of cytokines that you have, all the cytokines that engage in this type of activity have to promote growth, right? Because you have to formulate some kind of cascade, some kind of reaction. So when we look at this type of activity, I'm going to explain. All of the cytokines are binding. Well, hold on. Think about it. I said insulin. Non-receptor tyrosine kinase was, hold on. So yeah, I think I'm right here. I am right because you have interleukins like IL. Yeah, I'm right. Good. I am right. The idea of non-receptor tyrosine kinase. Yes. I shouldn't doubt it. Let me just pull up here. I'm going to give you that guys a list just so it can make sense. Let's see. Interleukins, interferons. Okay, no. Hold on. Is yes, tyrosine kinase. So no, let's fix this up. Definitely. And look, we could all get confused. I'll tell you one thing that gets super confusing here. Let's iron it out. The idea of non-tyrosine kinase and tyrosine kinase. I hate the fact that that's the name that they gave this type of reaction. That is the name that they gave these type of reactions, right? It sucks that they kind of gave it that name. But IL-2, like let's say IL-2, what type of pathway does it actually use? It does have the mTOR type of pathway, the same thing as insulin, right? So remember we said insulin has the MAP kinase and the other one. So if we're looking at that in that sense, IL-2 as an interleukin is stimulating that. I do remember that. I do remember that. So yeah, let's confirm that. Let's look at that in the first aid, for example. They have this graph right here. I'll show you this graph. Let's take a look at this right here. Take a look at this. This is the actual stimulus of IL-2 receptor. IL-2 receptor is the down. Well, they didn't get into all the specifics, of course. They're not going to get into everything specifically, but they did mention here mTOR, the mTOR type of reaction that's associated of. Yeah, that is true, Mona, but this is the problem. There's also another one. There's that JAK stat. You remember JAK stat? JAK stat has also that whole idea of growth, right? Polycythemia. So okay, yes. We have to let's get this ironed out once and for all. In the section of the first aid when they talk about second messenger system, let's take a look at that. And I'll post it here and we'll look at the actual image because we have to get this ironed out 100%. Because you'll see that, for example, insulin is one of these things that have that dual functions. Yes, when I think of JAK stat, I do think of polycythemia. Of course, yes, because JAK stat, remember, polycythemia has a problem with JAK. It's a non-receptor tyrosine kinase. That is JAK stat. JAK stat is a non-receptor tyrosine kinase. That is true. Okay, that is true. So let's understand this completely. I know it's crazy, but let's look at it like this. Let me post this up. Let me put this actually on the screen. I'm going to put this on the screen so we can take a proper look at this. Give me 1 second. Let me see where they have this on the first aid. I know they have this as a second messenger type of system, but do they actually make a list? I doubt it. Yeah, they do. They do. Good. So let's iron this out once and for all. No discussion here. Let's be on the same page. Receptor tyrosine kinase has insulin and everything that has GF on it. Yes, that's what I said before. That is what I said before. Insulin and everything with a GF on it. That has receptor tyrosine kinase. Non-receptor is a JAK stat pathway. Okay. So this here. So yes, this is IL-2. So why are they implementing mTOR here? You see what I'm trying to say? Why is mTOR being implemented here? I'm curious in that sense. Doesn't really make sense. Doesn't match. It doesn't match because IL-2 should be actually stimulating JAK. Do you guys see what I mean? Does it make sense to you? JAK is a different type of stimulus. JAK is a completely different type of stimulus. So cytokines all go to the JAK pathway, JAK stat pathway. So here you're seeing mTOR involved in this somehow. So I could see how, yeah, sirolimus inhibits, definitely inhibits mTOR, but IL-2 is not tyrosine kinase. That's the issue here. Yeah, it's a non-receptor tyrosine kinase. That's the problem. Yes, I never thought of it, but in question, renal transplant meds. Yeah, definitely renal transplant meds. Why? Because you want to turn off your T cells. Let's tell first aid about this. No, I think I know what's going on. I think I do know what's going on. I'll tell you. I think I do know what's going on here. The idea of JAK stat, if we remember the story of JAK stat, is the IL-2 receptor. Yes, it is. It is the IL-2 receptor, but I'll tell you one thing that's very important. When we look at the activity of JAK stat, there's a gap in the story that they're not telling you, let's say. The gap in the story is this. Let's say you have non-receptor tyrosine kinase. What ends up happening is that you have a piece of a receptor and another piece of a receptor. The cytokine comes into the middle. Say this is IL-2, for example. What ends up happening is that now you end up snapping them together. They unite. They become a multimer. That's the first step of everything. It becomes a multimer as soon as they end up binding together. They snap together. You see that? They're now becoming a proper receptor. This proximity of JAK causes them to autophosphorylate each other. They autophosphorylate each other. That's the next step there. Transphosphorylation, they call it. Once you have transphosphorylation, they can now drop the phosphate to the bottom. They drop the phosphate to the bottom. This is an important reaction because they have to try to approximate. Well, not yet. So the RAS activity that you see with the GTP and all that, uh, not yet. I'll show you the first aid drawing. But having that phosphate down here actually causes more of. So yeah, let me just tell you. So yeah, why do they call this tyrosine kinase? Let me just explain to you. Where is this phosphate actually situated? This phosphate here, it's attached to tyrosine. It's attached to tyrosine. Notice how we manipulate tyrosine so much. Wow, we do so many things to tyrosine. We add iodine on it, we grab it, we phosphorylate it, right? We do so many things to tyrosine. In this case, we are basically putting the phosphate here on this tyrosine residue. And this is what calls over stat, JAK stat. Yes, yes. Synthesized from phenylalanine. Phenylalanine comes from the liver. Remember that. It synthesizes to tyrosine in the liver. That's where it actually happens, in the liver. So let's take a look at this. This here, this actual SH2. Yes, yeah, perfect, Amna. That's what it's doing. It becomes bait. It calls it over. It says, oh, okay, well, you guys have a phosphate for me. I'll bind to that. So it's very important for that tyrosine to get phosphorylated because this will attract the stat on the docking site. It attracts it. Now, stat is able to bind to the docking site, right, using its own domain. And now it basically binds that phosphate at this point, let's say. Now you have a phosphorylated SH2. It's phosphorylated. That's what we call the stat protein. This basic stat joins in with another phosphorylated stat. They have to join together. Once they join together, you'll now start to see that. Well, hold on. Let me include something else to the story. Let me include it completely. We might as well, because it has to bind here first, right, to pick it up. Once it binds there, you're able to get this phosphorylated. You're able to get phosphorylation of it going down here. So it gets double phosphorylated. First, it has to bind here, though. I'm giving you the whole story. And what phosphorylates this second one? It's going to be a phosphorylation that happens by JAK. JAK itself starts to phosphorylate in that sense. Now, once you have that double phosphorylation, it's going to find another SH2 and join. It's going to form a dimer. So these two SH2s join together and they form a dimer. Okay, this is the dimer that they have. This dimer here can regulate transcription. It can go inside the nucleus and cause transcription. So now I'll tell you where the story has a little bit of gray space. The idea of this dimer causing transcription, how does it do this exactly? You see, normally when we have single signaling type of proteins, mTOR, no, you see, the idea that they have is that they're very vague with the story. They just tell you that it just enters. So that's why I'm trying to connect it to the actual first aid. How you see the first aid has this mTOR. So that means this IL-2 type of receptor here, this problem here, it must be a JAK stat kind of stimulus. But then this is where it gets weird when they mention the mTOR type of reaction there. That's what I'm trying to say. Like, this is worth investigating exactly why. If IL-2 is a JAK stat type of activity, why is it that mTOR is implicated? So this is where it gets a little weird. So I would have to say that mTOR, the only way that I can see that I can activate this is if JAK stat does some kind of phosphorylation or something there. You see what I mean? The story is very limited. So I'll look into it. I'll definitely look into it. That looks like a rabbit hole that I would want to jump into, but it's just the idea that they have mTOR. And this is a JAK stat. So yes, going back to this idea, going back to this actual action. Okay. Let's see. Okay, UWorld. Okay, Mona posted up a UWorld. Let's see. Let's take a look at it. Let's take a look at this. So here we're seeing IL-2 bind and stimulate mTOR. It's the same thing. You see what I'm trying to say? Same idea. IL-2 is an interleukin, therefore it should have JAK-STAT activity, but here we're seeing mTOR activity. So yeah, I would have to look into that. That is UWorld. That is UWorld. And it's showing this activity. So yeah, we'll take a look at that further down the line. Definitely that's a rabbit hole I would like to jump into because that
Can I
is
just
kind of,
can I say something?
yeah.
The mTOR is like a growth. It's like its own weird growth factor. Like people take medications that induce mTOR for anti-aging, or sorry, so they don't age as much. But this one is like a weird thing because the sirolimus doesn't block directly IL-2, it blocks it from having cell growth. Because there's like two things with tacrolimus and sirolimus. This one, I'm pointing at the screen. You can't see
Yeah.
me. But the tacrolimus increases the calcis, the C word, the CAL, and that causes renal. It can cause nephrotoxicity, where
Calcineurin.
sirolimus doesn't increase that, and so it doesn't cause the nephrotoxicity. That's why sirolimus is better. Those are just the questions I've had for this. I haven't like gone that deep into it.
Yeah, I'll tell you one thing. Yes, definitely here. Yes, Pablo, that is true. That is true, but that's in the other system. That's in the other system. That's in the system of mTOR. That happens with insulin. That happens with growth factors. Here we're looking at interleukins. So yeah, Mona, you see that there's always drugs that are going to target the idea of second messenger systems or things that like stimulate activity. So yes, here definitely yes. Here, so let's be very clear. This mTOR is specifically something. So I'll show you guys an image here where we can have mTOR. mTOR reaction is completely different than this one, and it has to do with the whole idea of the non-receptor type of activity or the receptor. Let's see. I hate calling it receptor non-receptor because it doesn't really distinguish it that well for me in my brain. But I'm going to show you guys an image. And with this image, you're going to see this is the insulin one. This is the receptor tyrosine kinase. So if we were to look at this image here, um, let's look at it like this. You guys see this? This is the entire reaction. The entire reaction. This is a very extensive. I don't recommend anybody go that deep into it, but I'm going to show it to you right here. So IL-2 is the two paths, though JAK-STAT and this one. Okay, look at this. On this type of activity, you are going to have PIP2 turning into PIP3 and then this stimulation going on. Look at P protein kinase B, basically AKT. You see that? That's what we understand to be the tyrosine kinase type. This is the tyrosine kinase activity that goes on. This is the normal type. This is the RAS one, the RAS and MAP kinase. This is the one that we understand. But in this one, they have mTOR. They have mTOR causing protein synthesis. Yeah, let's see. In this one, they have mTOR causing protein synthesis. Definitely. So let's see this one. Okay, Mona has sent a picture. Okay, nice. Hold on. Let's see this one. So IL-2 stimulating JAK. Okay, that's perfect. Stimulation of JAK. So okay, you see how JAK here is actually activating mTOR. That was the other type of. So I told you there's a kind of gray area because we don't know if JAK-STAT once it gets together, it says it causes transcription, but they don't really tell you how. They don't really tell you how. Now you're seeing what they're trying to say is that you can actually have activity of mTOR in these type of cells as well. Wow. Wow. I mean, that is good. That is good. I like it because now I do understand it was finally clarity. I wanted clarity. I got clarity. Does this make sense, everyone? Does this make sense? I understand it now. That is awesome. Finally, that is awesome. We don't have to write a letter to first aid. So you can delete that email. Whoever was making that email, delete it. They don't have a mistake. They're actually correct, right? JAK-STAT. So yeah, there's a lot of crazy things in medicine. Yeah. Delete that. Yeah. So listen to this, guys. Listen to this. It's crazy, but Jack stats, yes, is activates mTOR as well. That's what we just learned. Definitely, definitely. We just finished learning this. Okay. I love it. I love it because that's something that I seen before, but I you just don't know why really. All right. Okay. Good, good. Now get ready. I'm going to tell you something even crazier. I'm going to tell you a couple of crazy stuff. There's a couple of crazy things. So yeah, let's talk about some crazy facts that just throws off everybody. Tacrolimus. Tacrolimus. What's the mechanism of action of tacrolimus? Well, we can see it right here. Tacrolimus. It binds cyclophilin or FKB, right? Leading to the inhibition of calcineurin, right? Does this make sense? Does this make sense? Okay, now here's the crazy stuff. Tacrolimus, if you look for what type of family it is, what type of family is it actually found in? It's actually a macrolide. This here is a macrolide. It's just a macrolide that has a different mechanism of action. Yes. Yes. So I've gone through rabbit holes. I'm telling you guys, I've been through a lot of rabbit holes. So that mTOR, these are just small things for me. I'm telling you, like my head has gone you to a point where you think you know something so much. Tacrolimus. So yeah, let me show you. Macrolides inhibit the 23 portion of the 50S. That's the type of thing that it does. But in this type of macrolide specifically works differently. This type of macrolide has this mechanism of action. So it's a macrolide with a different type of mechanism of action. How crazy is that? That is a crazy type of thing. I remember looking for that, falling into that rabbit hole. So keep that in mind. Let me just show you guys straight off of Google. Let me see, because yeah, you won't find this information in many places. But um, let's see when they mention what type of drug is it. What type of drug basically? So yes, yes, definitely the mechanism of action definitely makes sense. It does make sense. Tacrolimus, but just know that tacrolimus, it comes from the family of macrolide. But yeah, it's having calcineurin activity, so don't get confused. I'm just giving you this information just to blow your mind a little. Yes, it's one of those things. It is one of those things. Definitely, definitely, it is one of those things. It is a macrolide, but yes, it's having this mechanism of action. It is having this mechanism of action. So keep that in mind. Keep that in mind. Here you're seeing it right here. Let me just post the Google. This is just Google. I typed it. Tacrolimus is a macrolide antibiotic produced by fermentation of streptomycin and succubiasis. But point is, it is a macrolide. So that kind of blew my mind once. I know that completely blew my mind actually when it came to medicine. What else? I have a whole bunch of those. I have a whole list of like in my mind of rabbit holes that I've been down to and tried to explore what in the world is happening and then learned so much. For example, erythromycin. Do you guys know that Motulin can cause peristalsis in the GI tract? Motulin causes peristalsis at the GI tract. And the way that it does this is by binding M type of receptors. Those are Motulin type of receptors. Erythromycin has affinity for these same type of receptors. So erythromycin can bind to, yeah. But this is the thing, Mona, the rabbit hole section that we do. No, it's not a muscarinic type of receptor. It's not a muscarinic, but it has an M on it. It's not a muscarinic, but it's like a Motulin type of receptor. So it's not muscarinic, but it has that M. Definitely. Rabbit holes, I wouldn't want to do say a session on that just because it'll confuse everybody. It'll make everybody feel like, what in the world did I get into? What's going on with medicine? What's happening? Because there's so we're not yeah, definitely. This will discourage people because these rabbit holes are crazy. I'm telling you, there's things that you sit down and think about and think to yourself, what in the world happened here? Like, how did this happen? Like, so for example, we just saw right now mTOR is stimulated by JAK-STAT. that was not something that's not generalized information that everybody knows. Definitely. So yes, keep that in mind. There's many crazy different things. Let's stick to the things that are normal. Let's not go crazy because if we do, we fall into the dark side. So let's stay in the light side, definitely, and let's continue. Okay. So we talked about encapsulated organisms and how they work. Now, let's just say, what was the idea we were talking about? Complement system. We got into the idea of talking about INO got abandoned completely. Uh, so let's see. Um, definitely, let's see. IL-2. Okay, yeah, IL-2. IL-2. We were talking about the activity of IL-2. Oh yes, we were talking about with IL-2. We asked. Definitely, hold on. Blarino, what question? What question? Ask it again. Definitely. So blocks transcription of IL-2 and cytokine. Okay, let's see. Neural. What about neural? What about questions? No, yeah, yeah. So just type it in. You are going to show us a question. Yes, that is true. I was going to show you guys a question about the pyramidal tracks. That is true. That is true. So okay, we'll make that to go back to neural. We'll attach that. We'll attach that into going back to neural. But really quick, we were mentioning the activity of okay, oligodendrocytes. Okay, now I'm getting it back. Now I'm back. Guys, I'm back. I'm back now. I'm back. Okay, we were talking about MS, and in MS we said it was type 4, and then we were talking about these type of reactions. We said that having IL-2 get released is part of this type of reaction here, where you're having microlides and gram negatives. And then we were able to mention basically what else? IL, let's say IL-12. We have IL-6, which will release acute phase reactants. Remember that acute phase IL-6 reacts in the liver in order to release acute phase reactants like hepcidin and all these different types of all these different types of proteins. But remember, there's also a protein called serum amyloid A. Amyloid A. This serum amyloid A is a tertiary type of protein, so it has problems getting broken down, so it can linger for longer periods of time in your body. And these type of proteins can easily become stagnant and stay and deposit itself. So they become deposits, they infiltrates. Yeah, this is amyloid. So this can cause a primary type of amyloidosis in the sense where you're making more and more amyloid, this AA amyloid. So, okay, yes, let me just put it like this. This is AA. AA, this is the acute phase reactant amyloid. It starts to stick to a lot of different places. One of the major places where it goes is the kidneys. So this will have an amyloid type of problem. When you have amyloid problems in the kidneys, we can call this a nephrotic type of problem, right? This is a nephrotic type of issue, chronic inflammatory conditions. Uh, can you tell me the topic? Uh, well, we're jumping topics everywhere. Right now, we're just talking about the idea of acute phase reactants causing amyloid problems. Acute phase reactant causing amyloid issues. Yes, acute phase reactants can cause acute amyloid. The amyloid increases. The amyloid increases, it starts to cause deposits, and it includes the kidneys as well. So the kidneys can also have amyloid deposition because of multiple myeloma. These are called light chains. Light chains, Benz-Jones proteins. So what's the problem with multiple myeloma? In multiple myeloma, you have a gamma spike. So remember when we're looking at different types of proteins, we have albumin, which is the most abundant type of protein, albumin. Remember, albumin is a negative large protein, so it's very high. Then you have your alpha proteins, which are not that high in comparison to to albumin. You have beta proteins, and then you have your gamma. So in multiple myeloma, you have a gamma spike. So they call this the M spike because it shows you like an M. It looks like an M. It doesn't really look like an M. To me, it does not look. It looks more like somebody doing this. But nevertheless, they would say that this looks like an M. So they call this M spike. M spike just because of the manifestation of gamma proteins. So these gamma proteins tend to have a light chain. You see this? Heavy chain on this side. Let's put it like this. And light chain on the other side. So this light chain that's being shown here, light chain, will start to break off. And if it starts to M spike from IgG, yes, M spike, macroglobulinemia, M spike from IgM. So you do have in majority, let's say Waldenstorm, yes. So we can favor IgM type of spike. Remember, both of them are made up of the same type of protein derivative, which is gamma proteins. Gamma proteins are used to make immunoglobulins. Here we're seeing gamma proteins make up this light chain. This light chain breaks off. If it snaps off, basically it can cause, it's a tertiary type of protein, which then can accumulate and cause amyloid deposition. This amyloid deposition can cause kidney damage. So if I see an old man with a back pain, old man, back pain, comes into your office, and now you're looking for, there's two different diagnoses. I'm super biased. Right away, my mind is already thinking he has multiple myeloma. All I have to do is rule out. I have to rule out either lytic lesions, or I have to look for hypercalcemia, or I can look at the creatinine in order to try to see if he fits the pattern, if he fits the mold of a patient who has multiple myeloma. Now, if he doesn't fit this pattern, if he doesn't have this problem, a good secondary type of differential you can think of is metastasis, Mets from the prostate. Mets from the prostate also has an old man with back pain, but instead of it being osteoclastic, you'll have more of an osteoblastic type of reaction there. Osteoblastic, yes, osteoblastic. Perfect. That's what we see in that sense. So yes, amyloid, you'll see many different types of amyloid that can manifest themselves. There's also one that has to do with dialysis. Patient who undergo dialysis frequently can have a specific type of protein that starts to lodge off and then cause amyloid deposition. You remember what type of protein this is? Microglobulin, yes. And that is seen with which type of major histocompatibility complex? Which one has that? 2. You're saying MHC2. My memory, the way it's formed, I see it as MHC1 because I remember it on the left side of the page. Yeah. So yes. MHC1, I remember it on the left side of the page. So I would say MHC1 definitely. So remember that when that starts to deposit this way, that's what ends up happening. Yes. MHC1, that's located on all our nucleated cells that are not the antigen presenting cells. Remember, antigen presenting cells have MHC2. MHC1 is very important because when you have some kind of viral threat, let's say, that enters a cell, let's say there's a virus, and it's actually entering a normal cell. Remember, we were talking about the integrity of the normal cells. That's how we started off this class. We talked about something called proteasome. So let's say you have proteasome here, and some kind of viral material enters the cell. Remember, viruses have 3 different types of compositions. Virus is going to be made up of the envelope. Well, let's see. Envelope gives it its tropism. What is tropism? Tropism is just a fancy word for affinity in virology. So whenever I say that it has high tropism towards the epithelial layers of the lungs, that means it likes to bind to that area. Yeah. Yes, definitely. So it just has high affinity, or it likes to bind to it. Like COVID likes to ACE. They like that ACE type of protein. So they have tropism towards the lungs because ACE is located in the lungs. There's also some kind of ACE located in the testicles, which I found very weird. But yes, there is. And so yeah, it tends to bind to these type of areas. So for example, if you're looking at rabies has binding to what protein specifically? Who remembers? So anybody who's very close to taking the exam, classes like this is what benefits you the most because you're just getting right now a heavy dosage of everything that's in the first aid, everything that's everywhere. We're just going to go through everything. Just keep on going. Let's stay on a roll. Stay on a roll. So I'm asking you right now, the question is, what type of protein is targeted by rabies? Who knows? You see, there's so many different kind of questions. It goes crazy. Rabies likes the nicotinic type of receptors. Remember that. Remember, acetylcholine can stimulate all sorts of receptors. Remember when you have your presynaptic? Remember the idea of you making acetylcholine packaging itself into a vesicle. It travels. And so you're saying like myasthenia gravis? Well, kind of like that, but it's not. It's using this to travel up. So it's basically moving. It's consistently on the move. In that sense, and it's making its way up, utilizing the activity, well, binding towards the nicotinic type of receptors. That's what's happening in that sense. So let's remember one thing: the presynaptic cell wants to release acetylcholine. Remember, it needs the activity of calcium in order to activate these proteins called snares. Once snares are active, they cause a lytic reaction towards the terminal membrane, increasing the permeability, allowing for the release of acetylcholine. Acetylcholine then binds the nicotinic type of receptors. Nicotinic receptors are found on the surface of your muscles. Muscles have the electronegativity of negative 90, and they can depolarize at negative 55. It was. That's the actual threshold that they have set. That's the threshold that they have set in that sense. So you'll have depolarization going on in this realm with nicotinic type of receptors. This is happening in the neuromuscular type of junction. Now, neuromuscular junction also has acetylcholinesterase, which is an enzyme responsible for breaking down your acetylcholine. That way, your acetylcholine breaks down to acetate, and also to choline. And then it can get reabsorbed, and this can happen over and over and over again. So, yes, just letting you know that the nicotinic type of receptors have your rabies have affinity towards this. Remember, rabies is RNA type of virus. Keep this all into your mind. Let's get back into this. So MHC, all I'm telling you with MHC is that if you have some kind of viral activity, we have proteosomes, which are our saviors. Remember, they're there to fix up anything that's in the cell. So when they see an irregular type of protein, so what type of protein do they react to? When I was mentioning virus, I mentioned something. I said envelope gives it its tropism, and we gave one example of tropism. My other example I'm going to give you now is an example of immunogenic type of reactions. So when we talk about immunogenic activities, let's be very clear. I'm talking to you about an activity that will trigger our immune system, right? And this is basically done with capsid. Capsid are proteins that are found within the viron, basically like the virus itself. It has capsid. So we are able to react to this capsid. So capsid is one thing. And then what else? We also have the inside, which is just genetic material. The genetic material can be found in a circular form, right? You have circular DNA, you have the single strand, double strand, you have all different types of genetic material. The point is that these three things will make up the virus. So let's say the virus is able to enter the cell. Let's say the virus is trying to replicate itself. Let's say we were lucky enough to attack the virus with our proteasome. Our proteasome was able to find it and attack it. So what ends up happening is that we're lucky enough because now we created fragmentation of this virus. We have fragmented this virus. These viruses, the story doesn't end here. These fragments that were created must make their way inside the endoplasmic reticulum. You have something called TAP proteins. TAP proteins are able to express themselves at higher levels. This TAP protein is able to allow the entry of these fragments inside the endoplasmic reticulum. Now, at this point, you end up having, of course, you have your MHC1, which will form a complex with all of these types of fragments. This complex will now redirect itself to Golgi apparatus. Golgi apparatus is able to tag this MHC1, tagging of the MHC1. So that way the MHC1 can then go to the surface. It now has affinity for the surface. Just to let you know, there's a process called farnellation. That's when you take a protein and you prime it to the actual membrane. Farnellation, prenylation. But point is this. This here, you're going to now express it here. You now have this. MHC1 that's loaded with the fragments. The same fragments that were here are now present here. Now, this MHC1 has affinity for what type of T cell? Can anybody tell me what type of T cell? Yes. CD8 positive has affinity for MHC1. Yeah, I saw you typed 1 in my brain. It was the same as you typing 8. CD8 positive. So CD8 positive is able to cause an extrinsic type of apoptosis, a different type of apoptosis that we didn't mention. This apoptosis will actually have binding, of course, And you'll have something called perforin, which is able to perforate this side and then enter these granzymes. Granzymes are able to enter and then cause apoptosis. So you're having apoptosis of this cell. That's what happens with this MHC1 type of reaction. Remember this. That's MHC1. Good, good, good. Going back though, going back. We talked all about amyloid, all because we mentioned IL-6, but in the end of it all, we were talking about the cascade that we were creating. We were talking about the idea of a macrophage binding a gram negative. Let's get back to that. Now let's get a little more organized. Let me stop detouring so much. The gram negative and the macrophage, they bind together. You have a lot of cytokine release, right? The point is this: IL-1 tends to stimulate. Remember, we said that there's going to be IL-2. Remember this, IL-2, we said. You guys remember that? IL-2 basically filled up its promise. It was able to call over a lot of T cells. A lot of T cells came in. A lot of T cells are there. They're saying, hey, you guys called, right? What's going on? IL-1 is able to promote the differentiation of naive T cell to Th17. Th17 is able to stimulate IL-17. I remember it was, who else remembers this? IL-17, it was 21. Yes. Was it 22? I know it was 21. Was 22 involved? I think it was 22. Yes, these types of interleukins will stimulate acute inflammation. And how do they do this? By stimulating neutrophils. Acute inflammation by stimulating neutrophils. Neutrophils, yes. And luckily, we also have the release of IL-8 by our NFK beta, promoting IL-8. These are chemotactic factors. Chemotactic factors. Neutrophils, yes, neutrophil release. That's what you have with these type of Th17, neutrophil release. So neutrophils will be released at a high level. You have a whole bunch of neutrophils now getting stimulated, causing a leukocytosis, right? Increase in the white blood cells. That's what we definitely have in that sense. So these are all the chemotactic type of factors. Let me put them on the screen. This here are all the chemotactic factors. This will call over the neutrophils. Remember that. Neutrophils have to make a proper inflammatory response. So the neutrophils itself are getting stimulated. These neutrophils have to make their way in. They're very fast. Remember, you have a fever, so the blood is flowing rapidly. Whenever you have a fever that increases about 1 Celsius, your body temperature goes up about 10 degrees, right? We measure our body temperature here in the US with like Fahrenheit. Oh, hold on. No. Hold on. I got that fact wrong. Listen to this. IL. So IL-1 stimulates fever. Anytime you go up 1 Celsius, your heartbeat goes up. Yeah, let me simulate this right. Your heartbeat goes up. You should expect heart rate about 10 when you go up 1 Celsius. 1 Celsius. There's only one importance of knowing this. There's only one thing that's important of knowing this. If your temperature goes up 1 Celsius, remember your heart rate should go up about 10, roughly. What is important about knowing this? If you have a patient, for example, who has a fever, let's say he has a 41 Celsius, a high fever, and his heart rate is at 90, for example. This will definitely let me know that this patient has a heart block. He's experiencing here a heart block pattern. He's experiencing here a problem with his heart rate. His heart rate should be well above 90. He should have a higher heart rate. There's different types of bugs that can cause heart block, which will have a very high fever and decreased in its heart rate. Salmonella is one of them. Lyme disease is another one. What's the other one? It's the let's stop doing long contractions. Legionella is another one. Lyme. Why is my brain saying that Legionella no and Listeria? It is. I don't know. Let me. My brain is still loading. Hold on. Listeria doesn't cause this, does it? Listeria causes. It has Listeria lysine O. Let's see. Hold on. Salmonella, diphtheria. Remember, guys, diphtheria. Listeria. So you're saying Listeria as well. Let's confirm this. I'm going to tell you right now. We're going to confirm this 100%. We have to confirm this. So I'm going to use this to confirm. We're going to look at in Instagram. I always make these mnemonics and I try to post them up in order to have a good record of mnemonics, just so whenever anybody needs to look up, it's Legionella. It's actually Legionella. It's Legionella. Yeah, yeah, yeah. Legionella. Legionella, Chagas. Let's start doing long contraction is a better mnemonic. Let's start doing long contractions. That's that basically. Let's start doing long contractions. That's what you'll see in that sense. That's heart block. These are the heart block bugs that are involved here. Okay. Keep this in mind. This is what you'll find here. Okay. So what kind of pattern do they have? They can demonstrate a pattern where your patient will have an increase in temperature and the heart rate is still within the normal range. It's going to be 60 to 100. That is not good because every degree Celsius that increases, I should be expecting an increase like about 10 heart rate. That's just a rough idea. That's just the only way it can help me here for this diagnostic kind of tool that I can use. But yes, going back to this chemotactic function, C5A, you're seeing that's part of complement. 5H PEAT should have a P on it. 5H PEAT is part of the system of phosphatidylinositol. Remember when you're breaking down your cyclooxygenase and lipooxygenase. Remember when you're making your leukotrienes. When you're making your leukotrienes, you have something called 5H PEAT. This is a derivative of leukotrienes. You'll have your leukotrienes B4, which is also chemotactic. So look at this. Both of these are chemotactic factors. Both of those are chemotactic factors. That's part of your leukotriene pathway. So remember, there's drugs that can inhibit leukotrienes. You have your whole idea of Montelukast, Cyphir-Lucas. You guys remember that? Definitely. Good, good, good. So, okay, going down the line, kallikrein, platelet activating factor. Also, you have your N4-methionine peptides. Good, good, good. These are basically chemotactic factors. Okay, but point of me mentioning all this is just the idea that neutrophils, they start to circulate very fast around your cells, very, very fast. So the problem is that they have to slow down. So the first part of them slowing down is margination. As they're going very rapidly, they have to marginate. They have to line up properly. And this is basically done by L-selectin to the actual, let's say, leukocyte. The leukocyte has L-selectin, and our epithelium has E-selectin. We also have P-selectin. So remember, epithelial layer is E-selectin, but we also have P. How can I remember P? Easy. Remember, we have Weibel-Palade bodies that are found inside the endothelial cells, Weibel-Palade bodies. Weibel-Palade bodies are these cells, these protein structures that they could actually release two things. They release von Willebrand factor, and they also release, well, not yet. We're not on the CD18 yet. That's when we talk about the integrins. That's when they actually bind. This is just the initial step of margination. The margination step has to do with selectins. So here you're seeing Weibel-Palade bodies. The W here is for von Willebrand factor. The P is for P-selectin. P-selectin. This is the initial process. So P and E, both of these selectins are going to cause proper margination. L-selectin on the leukocyte and P and E. E is for epithelium. P is for Weibel-Palade, the P for Pilates. Okay, Weibel-Palade body, von Willebrand, P-selectin. So here you start to see an expression of P and E. Then it starts to roll. So rolling, same activity. Your P-selectin and your E-selectin is enough for that. That's good enough. So now these things start to roll. When they start to roll, the leukocyte has to have something called Seil-Lewis. Seil-Lewis. This is the idea of rolling. This stimulates that rolling effect. Then after that, you have binding. This is where now we look at the CD11/18. Don't know too much about the 28, CD11/18. This is the ICAM. So on the epithelial surface, you're now going to have ICAM, which is adhesive. And you're going to have on the leukocyte, you have 11 and 18 integrins. This is going to allow now for this leukocyte to actually bind to this area. Stop moving. Now, the next step is diapedesis. Diapedesis is basically it moving inside. PCAM. Both of them will have PCAM. Well, not with the E in the end, but PCAM without the E. This allows for movement. This is the actual movement. Them coming in the inside. They have to move it towards the inside. Now, once they get to the inside, they have now finally invaded the tissue, but they don't know where the threat is happening. They're blind. So, what do they need in order to reach these areas? They need to have those kind of chemokines, basically for the migration. They're going to need those chemotactic type of drugs that we were not drugs, molecules that we were talking about, C5A, all of these. This is what they need at this point in order to be able to have affinity to it, right? They're able to finally find it. So that's the whole process of leukocytes. But now what happens? Our immune system is very calm. Our immune system is saying, okay, this is an acute reaction. This is great. This is functioning at this level. We have IL-1 stimulating this differentiation, and this is great. IL-6 is also stimulating this differentiation, and this is great. This is happening at this point. After a while, remember that your first, let's say, 3 days, it's all about this activity. It's all about the activity of a neutrophil type of reaction whenever you have an inflammatory result. Everything in the body is favoring this kind of acute type of inflammatory response. After a while, we start to change up. We start to say, hey, you haven't managed the problem yet. Yes, you haven't managed the problem yet. And now we get concerned. Now we start to think to ourselves, what is going on? Neutrophils did not do their job. We still have macrophages binding to toll-like, well, using the toll-like receptors to bind to PAMP. Now we're getting worried. 3 days have gone by. All we had is neutrophil reactions, and we still haven't stopped the problem. How do we know the problem has not stopped? Because macrophages keep binding. They keep binding. They keep doing this whole NFK beta stuff. And part of the NFK beta release, we said it was IL-1, IL-2, we said IL-6. We also say IL-12. This starts to now get released a lot more. Now we start to take this more into consideration. Now we start to see this cellular type of immunity where you have TH, the naive type of T cells, now changing into TH1. And this is done via IL-12. Now you start to have this type of change. So another thing that NFK beta releases is tumor necrosis factor alpha. Tumor necrosis factor alpha is able to amplify the activity of TH1. It's able to allow the TH1 to be able to release interferon gamma. Interferon gamma, not only does it stimulate itself, but it also recruits more macrophages. Now the job has come from being a neutrophil type of job, to now becoming macrophage. This happens at the 3rd day. Now we're talking about 3rd day. This TH1 now starts to take control of the situation. But the problem is that you have a lot of different activities going on. We're just mentioning the macrophage, the toll-like receptor action, but there's a lot more different reactions going on here. There's oxidative burst reactions. There's MHC2s manifesting themselves on their surface here with these type of proteins, antigen presenting cell action. But through this all, what this promotes is more macrophages. So more macrophages now make it to the scene. So let's be very clear. More macrophages make it to the scene. When more macrophages make it to the scene, what ends up happening? Macrophages start to bind this up as well. They start to say, oh, what is this? Let's bind this. The toll-like receptor. More macrophages come in. More macrophages enter. They start to surround this. Yes, they start to surround this. And as they surround this, they start to push each other. They start to smush each other's. And their cell wall is so common, so similar, their membrane, that they start to form one membrane. They now start calling themselves giant cells. Giant cells is what we call that. Giant cells, because they start to stick in this way. And now you're having a granuloma completely closing in on this type of organism. Let's say it was a TB. If it was a TB, TB has the power to replicate in the inside. So TB will be replicating. It will be casating. Yes, it will be casating because this is due to an inflammatory reaction. This is an actual threat. We actually have a culprit. If it was autoimmune, if this was something like sarcoidosis, then it will be non-casating because this is fake. This is just an overreaction of the immune system without having an actual threat, right? Impair of phagolysosome and lysosome fusion in TB, typically happening because of problems with cord factor. Cord factor likes to impair this type of reaction. Asbestos does have a lot of deposition. Asbestos is a bit different. Asbestos, you'll see a lot of different types of depositions, different types of cells that start to form as well. Like they have certain specific type of cells that are causing formations. But with this type of granuloma that you have here, notice that there's different types of reaction. For example, listeria. Listeria is very slick. Listeria has listeriolysin O. Listeriolysin O. It can use this to escape. It breaks off and it leaves. So there's many different things that happen inside this type of macrophage. In Shiriak Hagashi, you have a problem with your microtubules. So you will have a specific type of issue when it comes to reactions. Like for example, let's say you have your oxidative burst. Remember, you have to move your phagolysosomes. You have to form phagolysosomes. The idea of phagolysosomes are different because we didn't really mention MHC2 defense against organisms. We only mentioned the defense of MHC1 with the proteasomes. It's completely different with MHC2s. Antigen presenting cells are different. Antigen presenting cells, whenever the threat comes in, we actually have a lysosome system. And this lysosome can basically, well, you can consume. Let's just say you can't actually consume the threat and have some kind of phagolysosome. When you actually destroy the threat, remember you destroy the threat, you'll then end up having these proteins. And these proteins, you can put them in the endoplasmic reticulum, and you can actually have, finally, you can create a complex with MHC2 where it's going to have an actual affinity for the proteins that it has acquired. The breakdown of the proteins caused fragmentation. Phagolysosomes were responsible. Phagolysosome was responsible in MHC2. Antigen presenting cells, MHC2. Phagolysosomes were responsible for priming your MHC2. And then, yes, you have binding, you have reaction with Golgi apparatus, which tags it to the membrane. Yeah. For one, you have proteasome. Yes, proteasome is what's happening on MHC1. Here, MHC2 is a phagolysosome reaction. That's the difference. But okay, typically speaking, this is the action of macrophage. Macrophage is trying to do its thing here, and they're not letting it. So what ends up happening here? After a long period of time of this type of reaction, you're trying to make this work. It's not working. You'll start to notice that some kind of macrophage were able to consume this threat. Some kind of macrophages were able to have MHC2 on its surface. Some of them were, and some of them were able to consume it. So after a while, you'll find that a CD4 positive starts to bind. CD4 positive cells start to bind. Now they have to have dual binding. It's not just one. They also have to bind co-stimulatory receptors. You have CD28 and B7. B7 and CD28. These are the second type of bindings that you have there. Definitely. So this second type of binding activity that goes on activates the T cell. This is called T cell activation, CD28 and B7. If you do not have the second co-stimulatory binding, so let's be clear, nobody's lost so far, right? If you guys are lost, let me know. So far, I'm just telling you that the MHC2, some of them was able to actually consume the threat. They displaced it on their receptor, their MHC2 receptor. CD4 positive cells have bind. They need to bind in two areas, not just the CD4. They also have to bind the other area, which is B7 CD28. Yes. Yes. You guys understand that? So what is it called if your CD28 and your B7 do not bind? What is the name of that? What is the name of that? That has a particular name. Do you guys remember? Anergy. Yes, Miriam, 100% correct. That is anergy. Yes, that's the idea of having initial binding of your CD4 positive T cell, right? And then of course your MHC2 also binding, but not having the secondary stimulus, which is CD28 and B7. If this is not happening, of course you're going to have this huge problem where there's pure anergy, meaning that you're not triggering an immune response. Yes, you are binding, but you're not triggering an immune response. Now I'm going to tell you something. There are drugs. I remember it has a bat on it. The name has a bat on it. A cytobat something. I'm going to get the name of the drug. Abatacept. Was it abatacept? This has to do with the idea of anergy. This is a drug that's going to block the secondary type of effect. Remember, the co-stimulatory type of effect. You're able to block this, then you won't have the stimulus of the second reaction. So let me show you guys an image. This is straight up a U-rolled image. It is a Batacept. Yes, Amna, you are right. Again, basically you're seeing a Batacept is blocking this. CD8086 is definitely B7. It's just another name for it. CD8086 is just B7. It's just another name for it. So a Batacept can cause anergy. You don't have activation. T cell is inactive, yet it is binding. You see that? Yet it is binding. Look, this is microglobulin. You see that? This is that what's causing that type of amyloid problem. It's crazy that we know this much, right? It's crazy that we know this much. We're looking at images and we're able to then describe amyloid right here, just looking at this image right here, right? Good job for abatacept, because that is 100% true. Abatacept. So yes, that is something very important. Now, definitely know this. So let's look at it like this. In this activation, so right now I'm just telling you guys a nice little story. I'm just talking to you about how this TH stimulus, remember this activity is happening, and we are basically forming destruction. We're trying to grab the cell, but we can't. So guess what happens? Now we start to have activation of T cells. T cells start to get activated. Why? Well, it's only because macrophage now starts to bind the T cells with the MHC2 in its surface. And the CD4 positive cells start to have co-stimulatory. They start to bind as well. Now you can start to release different types of IL, like let's say IL-4, for example, starts to increase. Now IL-4 is going to stimulate a different type of reaction. This property here, this TH0, you're going to see that this will now have the ability to become TH2, but it has to release in a higher level. It has to release in a higher level because this activity is being actively inhibited by interferon gamma and by IL 12, right? Does that make sense? You're inhibiting that. You're inhibiting that type of reaction. But now what I'm telling you is that you start to release IL-10 as well. IL-10 starts to inhibit this. It's like, oh, really? You want to activate this? Let me turn you off. So now you start to make more TH2s, more TH2s. And this is what will then happen, because you will then have to have activity of TH2, which will be releasing more IG. Well, not IG, hold on. IL-4, let's say, IL-5. These type of interleukins are now released with TH2. So let's take a look at what ends up happening in this situation. These T cells, they can tend to bind B cells. You have a B cell receptor, and you also have a CD40. So let's say you have a T cell. This T cell will be able to bind a B cell. B cell is actually also antigen presenting cell, and it can present itself with this type of antigen that it has consumed. And this B cell uses an MHC2. Remember, it is also antigen presenting cell. So it's going to use this MHC2 to actually bind this T cell and have an interaction here. And now you're going to start to see that a CD40 ligand and receptor reaction can happen. And here you'll have so hold on, no. Hold on. B cell. Yeah, yes. B cell will have a CD40. So I put APC, I forgot. This is a B cell we're talking about here. B cell. B cell reaction will be CD40 ligand, CD40 receptor. This will cause the activity of release, basically, differentiation of B cell into plasma cell. Differentiation of B cell into plasma cell. Does this make sense? You're having activation of B cell. B cell receptor on the surface is going to basically present this type of antigen in this sense, and you're going to have MHC2 showing you this binding with basically T cells in this sense, and this is where you have your activation. One thing that's very important is, so does that make sense, everyone? Does that make sense so far? Let me know if that makes sense or if I have confused you. If not, I could explain it again. If I confused you, I could explain it again. I'm just letting you know that there's an antigen presenting process that happens with an MHC2 type of complex. And then you have the B cell surface. So yeah, let me show you guys an image. I'm gonna show you guys an image just to make sure. Yeah, so basically what you now have is the T cell. Yes, the T cell now starts to have this binding. You're now seeing this reaction where you're seeing here CD4 reaction with MHC2 from the B cell. You see that? T cell receptors, CD40 ligand. Now this changes. This is CD40 ligand now because this is a B cell. This is a B cell. This is not some kind of macrophage in this sense. This is a B cell and it's reacting like this. It reacts like this to activated T cells. Okay, it likes to react to this to activated T cells. It likes to do this in order to then understand what am I going to make. So this B cell can now differentiate. This B cell now starts to differentiate. It turns into a plasma cell. Plasma cell. Plasma cell knows how to release specific types of antibodies because now it has gotten the information. This T cell has the information of what needs to be made exactly. So it sends this information off to the B cell. B cell now differentiates to plasma cell. Plasma cell is responsible for making immunoglobulins. This is going to make this IgM, and then you'll have differentiation of IgM into either IgG, either IgA, or IgE, right? In this sense. This is what will happen here. Now, what cytokine is responsible for stimulating the conversion of IgM into IgG? IL-4 for IgE, IL-5 for eosinophils. IL-4 is correct. Now, Pablo, think about this. Isn't that kind of crazy? Because you are right as well. So how could Blarina be right and you can be right at the same time? Because yes, IL-4 will do this. IL-4 does this. But guess what? IL-4 also does this. So which one wins the battle? Okay, it depends. It depends on what? Faith. No, a little more than that. I'll tell you. I'll tell you what happens here. So remember one thing. If this was coming from the original reaction of inflammation, if this was coming from the original reaction of inflammation, if this actually came from neutrophils and macrophages, and then from macrophages, you had another problem, right? Remember, you had this other problem with, macrophages. Yeah, let's not exaggerate. You had neutrophils and macrophages. That's it, right? That makes sense. You had those type of reactions going down, right? So guess what? IL-4 in the presence of IL-17, in the presence of, was it interferon gamma or IL-10? Let me see. In the presence, because they have to have evidence that acute happened. They have to have evidence that you tried with macrophages. And then you'll be able to make your IgG. So yeah, let me show you this. Let me show you this type of reaction here. That's how it happens. IL-10, I believe it's 10. No. It can't be 10. 10 is inhibitory. 10 is inhibitory of everything. 10 just turns everything off. So let's see. So the evidence macrophages being used cause more. I think it's 12. Blarina, I think it's 12. Let me pull up the notes. I believe it's 12. I think that this type of reaction here is going to be a 12 because IL-12 was getting released before. So I would have to say, so let's see who's right. Let's see who's right. I'll pull up the notes. But there has to be evidence. There has to be evidence. So yes, they also have this. Let's see. Yeah, I think Blarina is right as well. My initial thought, my initial thought as well was this. My initial thought was that it is 12. It is 12. That's why I naturally thought. But let's take a look. Because we have to be 100%. If I'm going to preach, I have to preach from the scroll directly. So yes, let's see what I'm using here to take this type of situation is amboss. I'm looking at amboss right now, and yeah, I'm going to pull this up. So yeah, have to preach the right words. Definitely have to from this end. So let's take a look here. So yeah, okay, yes. Well, look, I think we were all wrong. Look what happens. IL-21 is the evidence that TH17 was happening, right? TH17, this is the evidence of that. IL-21. That makes sense right here, right? IL-21. Interferon gamma was the evidence that the other reaction was happening, that the TH1 type of reaction. So you have TH to TH1, that reaction, the evidence was interferon gamma. And now you have your newly made IL-4 stimulating class switching to IgG. Yeah. Yes, definitely. So yes, this is how we are having IgG. Notice here, IL-4 without all those other types of interferon and interleukin will make IgE. That's a whole other conversation. That's the type 1's hypersensitivity. That's how you stimulate it in the first place. So if you have an inflammatory type of reaction, it's different. Remember, when you come into contact with an allergen, at first it doesn't really cause a reaction, which is why we make IL-4s. Well, we make IL-4s react and then turn into IgE. IgE will then express itself on the surface of mast cells. Mast cells. That's how they roll. They go on the surface of mast cells. They're primed. They're ready to go. That's how IgE works. So definitely we have it here. Interferon gamma, IL-4, and IL-21. Let's be very specific. When these things are in the presence of your IL-4, basically, they will differentiate. They will allow your IgM to turn into IgM will turn into IgG. Perfect. This is how we create this type of immunity. This is how we create this type of immunity. That's perfect. That is perfect. We now understand this. We have this under our belt. We understand this properly. So, okay, how can I use this? How can I use this? I'll show everybody. This is how we use this. Now that we understand this, let's look at it like this. You guys know histology, right? I think that's everybody's favorite subject here. Histology, right? Histology. Histology. You're more of a biostats guy, right? Oh man, that is funny. That is funny. You are more of a biostats guy. Yeah, makes sense, right? Um, let's show you guys something really quick. Oh man, yeah. All right, so let's check this out. So yeah, they have questions like, let's say, where you have these kind of questions where, oh, a patient died and you're checking out the biopsy and you want to know exactly what time did this happen on, like what was the time frame that this happened, right? And they're describing to you the histological features, or they're showing you an image. So let's look at this, for example. If you have this is Dr. House. I think Dr. House's favorite is just getting diagnosis in general. But let's look at this. After a myocardial infarction, 0 to 4 hours, we don't see anything. 4 to 12, wavy, narrow, elongated myocytes. Okay, let's say swelling. Look at this though, 1 to 3 days. This is where I want to emphasize. 1 to 3 days. Prominent neutrophilic infiltrate. Prominent neutrophilic infiltrate. This goes hand in hand with our story. We said this turns into TH17. So there's a point of why I tell you all this. There's a point of all I tell you all this. It's not just so we can know more information of medicine. We have to apply this to answering questions correctly. So now we're seeing the application of it. If you have some kind of pathology that's causing some kind of necrosis, and they're asking you, well, 1 to 3 days, what will you find? The answer is some kind of neutrophilic infiltrate. And if they have another neighboring kind of description, the neighboring description will describe the type of necrosis that it is. If it's here in the heart, we're talking about a coagulative type of necrosis, which has necrosis in general will have loss of nuclei and striations. If they're talking about a liquefactive type of necrosis, they'll use different type of terminology and so forth. If they're talking about Some other type of necrosis could be any type. They'll try to use the description that has to do with that. So the description will be two different things. It will be something that will tell you the time, plus something that tells you the tissue, because every different tissue will have a specific type of necrosis. So look at this one, 3 to 7 days. This is when the macrophages were available. Look at what it says: macrophage infiltration at border areas. Disintegration of dead neutrophils. Neutrophils are dead by this time. Does this make sense, everyone? We're now applying everything that we have been learning. Look at that. It's now able to match. 7 to 10 days, robust phagocytosis, dead cells by macrophages, beginning formation of granulation tissue. So, yes, scarring will happen in about 10 days. 10 days, you will have the fibroblast formation, fibroblastic formation, extracellular matrix. You will have protein like fibronectin, all these different types of metalloprotease. Well, metalloprotease is later on, remodeling of the scars, metalloprotease. But for now, we're just talking about scarring activity. When there is scarring, you're turning everything off. TGF will be active. TGF, IL-10. These are things that turn things off. TGF, IL-10. This turns off your inflammatory reaction because now at this point, we just need scarring. Scarring tissue has to be formed. Scarring tissue must be formed here because this is the end of it all, right? This is actual scar deposition. It says well-developed granulation tissue and neovascularization. That's part of it all. That's part of remodeling. You remodel whatever you can. You try to fix whatever you can. And it says progressive collagen deposition and scar formation. That's towards the end, 2 to 3 weeks. In reality, it can take months. 3 to 7 days, definitely. This is the time of the macrophages. In this point, macrophages are actually causing a Th1 type of reaction. So you're going to see that macrophage infiltration at border areas. Macrophages are actually active here. They're causing reactions. Remember, macrophages can do many different types of things. So we can't really get too specific because macrophages, they can consume the threat. Remember that they have the action of presenting in their surface MHC2 with specific type of protein. You have that idea, right? You have that presentation. That's the consumption of it. That's when you are now working as an antigen presenting cell in that sense. But macrophages also have oxidative burst. They can have an oxidative burst reaction where they actually engulf the threat with these pseudopods. They extend their pseudopods, they close this up, and they attract the microorganism, and then they cause the oxidative burst, leading to oxygen turning into superoxide. Remember, superoxide now turning into hydrogen peroxide. This can be neutralized by catalase. Hydrogen peroxide can become water and oxygen, in that sense. But nevertheless, if it continues breaking down, it could finally become bleach. And then this will have noxious effect towards anything that you bring in contact with it. So here we bring these microorganisms to make contact with the bleach, you'll destroy it. The destruction of these microorganisms will be evident in an oxidative burst. That's another reaction that macrophages can also do in this sense. So what else? Macrophage also have other types of reaction I remember as well. What was the other one? Well, it likes to clean up surfaces. It's big on cleaning up. It's big on cleaning up as well. But can we have a break for 10 minutes after this? It's 12:15. I'll tell you what, everybody. It's 12:15. I want to keep on eating. I'm not sleepy at all, but I am hungry. I am willing to stay another 30 minutes. Let's say we take a break for 30 minutes, but then we'll do questions. What did I drink today? I'll tell you what happened today. Today, I did not have my student earlier. So I usually give this student so much class. I give him a lot of class towards the morning, especially now that he's about to take his exam. So I spent a lot of time early in the morning giving him class. I did not do that this day. Today, I basically slept. I slept for a long period of time. So I have to get a new student. I will get a new student to replenish this student. He's going to take an exam. I know he's going to take a little break like everybody does. But yes. Definitely that's what happened to me today. I didn't have my early student that I always have. I've been giving him like 3 to 4 hours of classes. So those 3 or 4 hours got transferred over here. But yes, yes. So far we got like 6 hours, but I am starving. I am starving. I am hungry. So I think I should do this actually. So yeah, let's have a little talk before we go off. Before we go off, let's have a little talk. I want to ask everybody. I was thinking of an idea. I think it's a good idea to have like a marathon like this, where we talk about every single subject. You guys can make a list of questions. I believe I'm at the point where I can just sit down and just talk medicine for longer periods of time. Of course, there's things that I might not just know from the top of my head 100%. We look them up. We get the information in there and we put it in on the screen. We can do this, and we should actually have this type of material available for people who are about to take the exam. That way, they can go through so much information on the first aid, so much information on the first aid that they can just basically benefit from having this power review where you can just integrate everything. But there has to be questions done as well. We didn't really do questions. That's why I want to continue. I actually want to continue and do questions as well. So yes, I want to do some questions. That's what we got coming up next. We okay, good, good, good. If you guys want to continue with me, definitely let's continue. Let's continue. I just don't want it to die because I'll be honest. Well, the reason why I've been so energetic is because there's a lot of energy coming back at me. We are reciprocating. So yes, definitely, definitely. Yes, Barina, you see, I'm doing a camp right now. I have certain people signed up to a camp where I am giving a lot of hours of class. I'm giving class 12 to 1 to 5 p.m. So people in the camp, I am suggesting that they take an MBME before the month is over. I suggest everyone who is studying hard as well, set yourself some milestones so you can progress. So yes, Blarina, and also Dr. Francis. They're signed up for the month for the camp. So what we will do at the end, we'll do some kind of power drill, and we'll go through so much material, and then definitely go take your MBME and see how your score has changed. So yes, definitely, definitely, definitely. I'll include you in that as well, Mona. Let's see, we include a couple people. Let's get this. Let's get this active. We can do it. We can do it publicly too. I don't mind. I actually don't mind, but we have to be super active. Just because lately I have been doing questions and studying a lot as well. So there's a lot of information in my mind. Let's take a break then. Let's take a nice break though. I want to actually eat something and come back. Um, should we come back? I feel like everybody's gonna leave me if I say 1 a.m. If I say 1 a.m., will everybody leave me? I don't have my student tomorrow, so I'm sleeping in late. I don't mind. Or we can leave this for another day. We can leave this for another. You know what? Yeah, let's not disrupt this. Would me for me would have to be 12. It's already 12:16 over here. It's 12:16 over here. It's 12:16 over here. Yeah, so Marion wants to have a coffee break. You know what? All right, let's cut it here. Actually, let's cut it here and let's continue to do this again in another time. I have to tell you because I want to eat. Like I want to just stop for a while and actually have some kind of like meal. Like I want to go out and eat like a chicken sandwich. Like I'm already thinking of a full blown meal on this side. So definitely, definitely, yes, definitely. I want to do questions. I do, but I also want to eat. That's the only problem. Uh, it's 7 a.m. Okay, Amna is 7 a.m. So you're up. I want to do questions, but I also want to eat. So let's see. I mean, I can come back. I don't mind. I don't mind. I could come back. I just had to go to the. Yeah, I'm getting some food real quick. I'll go and I'll come back. If you guys will wait for me, that's perfect. So the latest will be for me. It's 12:17 right now. The latest will be 1 a.m. If I finish earlier, we start earlier. Okay, I'm just gonna go get the sandwich, eat the sandwich, and come right back. All right, that's how I'll do it. The sandwich is like 2 blocks away. I'll walk over there. I'll go get the sandwich. I'll order it right now on phone, and I'll come back. We went through Immuno though, guys. We did go through Immuno. That's a perfect plan. That's a perfect plan, guys. Wait for me. I will be right back. Yeah. Let me pause the recording. Let's get these questions now. Let's get these questions into the system. Um, yeah. So we talked about a lot of subjects, a lot of subjects. We included so many different types of subjects. Let's target these subjects with actual questions. Let's look for strategies of how to answer the question as well. Let's implement everything. Let's use all the tools now that we have in order to do this properly. Good. Awesome. Yes. Miriam, here's part of my secret weapons. Gas station coffee. Yes, gas station coffee. Don't underestimate the power of those gas station coffees. Here in Maryland, they have Royal Farms. Their coffee is super strong. I don't know what they put in it, but they have this option like vanilla extract or something, and I don't know what it is, but it tastes really strong. Yes. Keeping it legal, yes, yes. Although in the gas station, there was like a guy who just I don't know. It's crazy out here in Maryland. It's like there was like a farm access to a pharmacy. I have access to a 24-hour pharmacy out in the gas station as well. It is insane. Yeah, at this time, the gas station was actually a lot of people there. It was crazy. This is Baltimore. This is the top 10 most dangerous cities here in America. Definitely, definitely. This is deep into these neighborhoods. Yeah, definitely, definitely. No, I'm from New York. Out here in New York, you're definitely street smart. If you're just from New York, 5 boroughs, you're automatically just installed. Like they installed a update of street smarts. Um, yeah, that's just it. So let's take a look. Let's jump into this. Definitely. Um, the MBMEs. I did mention a question. If I find this question right away, right off the bat, we find this one. This will be perfect. Um, let's see. Yeah, let's do some really strong questions. Let's see. I'm excited. I'm excited. Run these questions in there. Okay, okay, okay. I see some good questions. Let's jump into it. So I'm going to post the first one. Raise your hand if you want to participate as someone who's answer the first question. If not, I can read off the questions and we can just answer them on the answer choice. I wish I had a way like a poll that we can make that I can just implement that. That'll be perfect. I have to get into that. I have to learn how to make a poll because that way we can just poll the questions. That way everybody can answer in that sense. That's what I'm going to work on for next class. I want to create like a poll system where we can all vote for the answer. And that's the best way to go about it. Okay. So here in this MBME specifically, this is I won't tell you the number because I don't want to spoil it for everybody, but I'll give you this question here and let's see how we can answer it. Because yes, we did all these type of questions basically. So take a look at this. Everybody can see my screen, right? Are we recording? We are. Good. Paulo, you want to read this? You can unmute yourself and give this a read.
Hello, thank you. So let's see about this. Seems to be immuno, what we just saw. 4-year-old boy has had a very upper respiratory tract infection for the past 3 days. Clearance of the virus is most depending on which of the following. So clearance of the virus. So virus is going to be attacked by cytotoxic cells. So it's going to be more dependent on cell immunity rather than antibodies. So let's see, activation of macrophage. No, I don't think so. What on which of the four? Most dependent. Okay, so all right. So it's not gonna be G, proliferation of plasma cell. It's not gonna be T. It's not gonna be F. It's not gonna be B. Phagocytosis of. It's not gonna be C. It's not gonna be A. It's not. I choose D.
You're
Just
choosing.
just because of the CD8.
Okay.
The
So you will use phagocytosis of viral. Okay. So let's explain this. Let's look at this. Yes, this here you have to understand. Here for this question, the answer will be B. But let's understand. You are right in saying that CD8 positive T cells are actually causing the reaction, but let's see why the answer is not D. Let's understand this. So first off, how would I approach this question? It's a very short question. I won't get too deep. I would just read to myself. 4-year-old boy has a viral upper respiratory tract infection for 3 days. The key here was viral. The key was viral. We do understand CD8, and they know that you know that it's CD8, and I know that you know that it's CD8, and you know that it's CD8. But the problem is this: they will try to confuse you. Yes, they will. Try to remember the process. We talked all about the idea of proteosomes. Remember, the proteosomes are going to make contact. Let's say proteosomes are going to make contact with these viral type of cell. This viral cell, you'll have the destruction of these types of viral proteins, creating fragments. Now, remember, we talked about something called TAP, TAP. TAP is this protein that allows them to enter the endoplasmic reticulum. The reason why I mentioned TAP, let me be very clear, is because TAP itself can be expressed at lower levels. You could decrease the expression of TAP in order to not have a viral type of reaction. Let's be clear. You can decrease TAP so that way you will not have MHC1 expressing itself on the membrane. That's why I include TAP into this system when I explain it. Saw a question on this, MBME, yes. So looking at the situation, yes, you have chromosomal activity, and you understand, it's just the idea of phagocytosis. The idea of phagocytosis, this is basically when you consume the cell. This process, you'll see, will be a reaction that provokes apoptosis. Remember that it provokes an apoptotic, kind of extrinsic type of apoptotic that happens here. So yes, Pablo, yes, MHC1 proteosomes are provoking this. So it's asking what starts the process? No, it's definitely asking which one of these are involved in the process. Phagocytosis in specific is the process where you're cleaning up, where you're basically consuming, you're eating. This definitely happens. This is not like a apoptosis. Those are two different things, the phagocytosis and the apoptosis. Antigen presenting cells, like B cells, macrophages, they cause phagocytosis. They can cause phagocytosis. This one here is specifically asking you about the process of clearance, basically apoptosis, with class 1 MHC viral peptide complex, which will present itself here. And yes, they were very tricky because yes, CD8 positive T cells are exactly reacting with this. But this alerts natural killer cells if MHC is not expressed in the surface, right? Yes, you are right, Mariam. When I was explaining the TAP protein, remember that? Yes, if you don't have expression of MHC1 on the surface of the cell, then you can have natural killer cells reacting. Remember that. Remember that. Yes. That's how they like to mess around with you with questions, because they know that it's CD8 positive, so they'll put that CD8 positive there shining, as a really good distractor. So be careful with that. But yes, I am aware that you do know the pathway, you do know the reaction. Typically, I'll tell you a strategy. Just read the question, get the concept in your mind, and then try to match the concept, right? Instead of like the keywords, try to match the concept. The concept was the MHC1 expressing itself. So yeah, but they did mess with you there with that word. That was a dirty question. They did mess with you there with that word. Okay? Yes. All right. Who wants to step up next? Let's look at next what we have here. What do we have here for the next one? So yes. So viral infection reduce expression of TAP. Mariam, what I'm saying is that some type of viral infections, they can try to avoid apoptosis by actually decreasing the expression of TAP. They have this power, let's say, right? Like these are different things that would occur in this sense. Like virus can tend to use our proteins, and in this sense, they try to decrease the expression of TAP. So yeah, you realize that some viruses are very tricky. Some viral infections are very tricky. They're very dangerous. They try to shut off our immune system reaction. What type of viruses? I can tell you, for example, I'll tell you some trickiness of viruses. They have a lot of tricks on the book. Look at hepatitis C. It has on purpose it makes a lot of mistakes with its own replication. So it gets to the point where it starts to replicate itself and it starts to look different. So our immune cells can't recognize it until it starts to cause a whole nother type of infection. So yes, they use this as a tap out. No point intended, but they use this tap protein as a power to try to avoid it. So whenever you have decreased expression of tap, notice that the virus cell is trying to maintain itself, trying to avoid this problem. Right? Does that make sense? Okay. Good, 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 good. Now, let's look at another one-liner. What do you guys say? Another one-liner. Let's look at this one. The patient's worst, hold on, what the patient whose cardiac function is illustrated most likely has which of the following? So again, we're seeing cardiac output here, and then we're seeing left ventricular and diastolic volume. We usually see this, but towards the line, like it would measure like venous return or preload. Well, they're trying to use the same type of terminology here, try to mess with us. But I see increase in cardiac output. Well, no. Actually, I see normal. The cardiac output will look like this. And then the patient has a decrease. So I have a decreasing in cardiac output. That's what I have. So for this, I would have to say there's decrease in cardiac output. I would have to match this. And not only that, the end diastolic volume. Look at the end diastolic volume here. I'm seeing that this is also high at this point. So it's like, what in the world is going on in this sense? Same, yes, good. So we have to think about this. We have to think about this. We're having a cardiac output that is decreased, but we're also having the idea of the same type of volume. The left ventricular and diastolic volume is definitely shown here in this sense. Now, what can I say in this sense? What can I say? So it can't be E, restrictive cardiomyopathy. Yeah, I agree with you. It can be E, but why, Mona? Why can it not be E? Can you tell me why? I do agree with you though.
So restrictive cardiomyopathy, they would have decreased end diastolic volume because it can't expand. So that's why I was thinking it can't be E. Like the other
Oh
one.
yeah, good one. Yes, that is why. That is actually why. Yes, definitely right. But they have that lack of expansion, right?
Mhm. Then the same would be for maybe tamponade because they also cannot expand because there's fluid.
So for tamponade, yeah, you have the lack of expansion, but you have equalization of the chamber. You remember that?
Yeah,
All the
that's
chambers
true.
start
Yeah,
to
yeah.
like match in that sense. Okay. So okay, let's do the process of elimination. If we're doing that process, we already have eliminated restrictive, and I agree with you. Tamponade is also out of the picture. Or pulmonal is the left, only the left. Because of congestive accumulates end. Okay, I like so what is the thought here? Where is this leading to if you think about it? In pulmonal, you have a right ventricular type of failure, right? Because basically it's going to affect everything like before that area. So core pulmonal, you have the pulmonary system. Remember, we have your right heart this way, left heart this way. If the pulmonary system is here, everything backwards will be affected, right? So core pulmonal will have everything affected in that sense. Like a right heart type of failure. That would make sense, right? These one-liners are pretty tough. Yes. Yes, that is true. AVM will have an increase in cardiac output. AVM has an increase in cardiac output. So we could easily eliminate this. Now we're left with these two answers. So if we were to pick, what would we go with at this sense? Core high pressure in the lungs. Core does have high pressure in the lungs, definitely. It's causing such a high pressure that the right heart starts to accumulate fluid and it starts to basically back it up. So, in a question like this, the patient's curve looks kind of blunted, right? Even with the increase in preload, it's still kind of blunted. It doesn't have that activity that we'd expect it to have, right? Because remember, Frank Sterling mechanism tells me that if there's a lot of fluid inside the heart, it will expand. And that expansion should cause a stronger type of contraction. So, yes, I like, for example, the answer congestive heart failure. This would make sense because here we're seeing that although I am having this type of fluid, this much fluid, let's say, I'm not getting the Frank Sterling reaction that I would expect. In a congestive heart failure, usually remember you underwent type of um, cardio hypertrophy to the point where it has led you to it's going to be like a long-term type of hypertrophic effect where you first have the constrictive, then it becomes more eccentric, and with time you have accumulation. You have basically you're based on you're using your preload. You're using your preload in that sense, and you see here that this effect is blunted. You lack Frank Sterling effect. The tissue of the heart is very much limited. So it is basically we're looking at a heart that has lost a lot of systolic function, right? It's a systolic problem there in that sense. Does that make sense to everyone? Where you have the same fluid, but you don't have the same pressure. What in the world is going on? Why is the Frank Sterling mechanism not working? Well, I'll tell you, it's basically having a problem. Yeah, it's having issues when it comes to the expansion. That demonstrates everything there. There is still forward movement. Yes, there is still forward movement, of course, but you're seeing that the increase in the level of volume that used to be adequate. This is like the heart without Frank Sterling. The heart without that ability to snap back and cause that effect, right? That's what we're having here in this problem. So let's look into this. Let's actually explain this like this. For example, if we take a look at this type of tissue, right, the sacromere, we can notice that the recoil property is basically gone in this sense. You're not having that anymore. So your tissue becomes very dilated. As you have hypertrophy, remember, concentric, yes, you start to have thicker type of cells. You start to demonstrate a very thick appearance. But once it turns eccentric, once it starts to pull away, the actin and myosin activity are very limited. Here you're having actin and myosin activity. As they start to move further apart, you'll start to realize that this activity is now limited. Now they're not really reacting as much as they used to. They're pulled farther apart and they're not causing a proper contraction. So the idea of you expanding that ventricle in order to have Frank Sterling is gone. So just for this question, yes, keep this in your mind. Frank Sterling is very limited in a congestive type of heart failure. Things like this can start to happen. Does that make sense? This was a tough question just because this question here will not give you enough information. Very limited amount of information. Right? Very, very limited. So in a cor pulmonale, definitely the left contractility and the left afterload, it shouldn't be affected. Frank Sterling mechanism should still work. It should still work in that sense. Like it shouldn't have this problem where you have the same amount of fluid, but you don't have that snap. This is showing us the blunted cardiac output due to the lack of snapping. Because you do have the fluid here that's present, but this fluid doesn't really matter as much, right? Does that make sense? So this curve, how can I increase this curve here? How can I increase this curve here? Let's understand this. Yeah, let's manipulate. Yeah, good, perfect. Inotropic effects. Yes, definitely. Inotropic effect will increase my cardiac output. So let's play around with this graph a little bit. So if I want to increase this, if I want to shoot this up higher, basically, it will make sense that I increase my inotropic effect. Remember that cardiac output is basically heart rate times stroke volume. So contractility, basically with calcium, intracellular calcium, should manipulate this. It should increase my cardiac output. It should have a stronger type of cardiac output in that sense. Another thing that I can also do to try to um, increase this, let's say, if, for example, what else? Yeah, inotropic is the best one I can think of. It said low sodium, high heart rate. Well, yeah, heart rate would also stimulate this like a sympathetic type of effect here. It has to have a sympathetic effect in order to increase your cardiac output here. So you have to try to manipulate the other things. So preload here is not really a good manipulator. That's what I'm just trying to get at. I'm just trying to get to the point where you look at cap, contractility, you look at afterload. If I decrease my afterload, I would have less threshold, for example. In a patient like this, we're basically seeing that the amount of preload, for example, is equal to the same amount as before. So we're seeing this, it's matching, but the cardiac output is very much limited. I believe this patient at this sense has a decrease in contractility. Remember, contractility is measured like this, through this plane here. With this chart, with this kind of cardiac loop, I'm just going to tell you one thing, cardiac loop, CAP. This will measure preload. This up here measures afterload. And this measures contractility. Contractility is on an angle because as you increase your afterload, you will need a higher amount of contractility in order to overcome that threshold. Does that make sense? Contractility you'll find on a plane like this. So here, basically, we have a decrease in contractility, definitely, but the preload is the same. So I would have to draw something like this if I'm trying to draw the same kind of reaction where the cardiac output is decreased, demonstrating a lower stroke volume. Am I confusing everybody, or does this make sense? I'm trying to draw the dotted line there. Does that make sense? Okay. Okay. Yeah. Let's jump into another type of question here. Let's jump into another one. One that demonstrates, well, here we have another immuno type of question. Let's see. Going down the list. Answer was yes, congestive heart failure. Definitely. Definitely. What they just wanted you to know there was the limited type of Frank Sterling effect. Frank Sterling effect was not too active there. Okay. We have a question here, everybody. Let me also paste the answers right next to it. Let's put these answers right here. Uninvestigator. So let's go. Uninvestigator is studying the adverse effect of proteasome inhibitor, bortezomib, on immune responses. Bortezomib is administered to a group of patients with relapsed multiple myeloma, and immune responses are observed. Which of the following immunogenic processes is primarily affected by the drug? Okay, Pavel says presentation of antigens. All right, what else? What else? Does anybody remember the mechanism of this drug? Does anybody remember the mechanism here of this drug? If you don't know the mechanism, I'll explain it. Joy, should I explain the mechanism? Should I go off and explain the mechanism of bortezomib? I'm going to explain it, basically. So let's look at it, Joyce. Let's take a look. It has to do with proteasome. Yes, it does. So look at this. I'll tell you the mechanism, guys. This is very interesting. I love this drug. This is one of the drugs that are actually so awesome. So remember when we were talking about the accumulation of proteins? So yeah, Blurina, remember this. When you accumulate a lot of proteins, yeah, I did a million times. You're right. Definitely. It's like I'm basically like like I have a deal with bortezomib. Basically, I'm like promoting them at this point. I'm mentioning them so many times. It's like they're paying me. It's like they are giving me a proportion of their money, basically. Bortezomib. I'm sponsored. Yeah, that's the word I was looking for. It's like I'm sponsored by bortezomib at this point. I've mentioned them so many times. They might as well start paying me. So check this out. Bortezomib. When you have an accumulation of proteins, like I mentioned before, you have an accumulation of proteins. You end up stimulating, right? P53. You guys remember that? P53 gets stimulated when you have an accumulation of proteins. Who remembers that? Type yes. Type yes. Let me just make sure that everybody remembers. Let's make sure that everybody remembers. We talked about that. We said that when you start to accumulate old proteins, like these senile kind of proteins, they should get eliminated. When they do not get eliminated, they trigger P53, right? We all remember this. We all remember this. This is what typically happens. The accumulation. Perfect, perfect. So when the accumulation happens, when they start to increase in numbers, when you end up having more and more proteins, the direct stimulus of P53 can happen. P53 is responsible for intrinsic apoptosis. Remember that it stimulates BAX? Yes. It tells it, hey, it's time to die. Let's stimulate BAX and BAC. BAX and BAC actually cause damage to the mitochondria. Damage to the mitochondria. If you start to damage the wall of the mitochondria, you end up actually increasing the permeability. And then you increase the release of cytochrome C. Cytochrome C starts to accumulate. Cytochrome C triggers caspases. BAX and BAC. Now, you do also have something called BCL2. BCL2 is supposed to protect the mitochondria. So to make sure that this works, P53 has to also inhibit BCL2, inhibition of BCL2. We did mention that there's a follicular lymphoma, the 1418 type, that causes a perpetual type of activation of BCL2. That way, BCL2 cannot be inhibited. That way, your cell becomes immortal. That was for follicular lymphoma. Follicular lymphoma. You guys remember that? That was like in the daytime. The sun was out when we were talking about that. Yes, the overexpression of BCL2 leads to the immortality. The inhibition of apoptosis is anti-apoptotic. So yes, the overexpression of BCL2 doesn't allow you to cause apoptosis. Okay, good. We talked about that. That was 1418, for example. I remember 1418 because I say follicular, between follicular lymphoma. Okay. So looking at this, I am telling you that P53 activates this system and causes intrinsic apoptosis. So guess what? Luckily, we have a whole system with something called ubiquitin. Ubiquitin actually uses ATP to tag these proteins. So you can tag the proteins if you want them to get destroyed and turned into peptide fragments. You tag them first. You're able to tag them with ATP with different types of enzymes that can cause ubiquination. They're ubiquitin types of proteins. So what we actually do with bortezomib is that we inhibit the proteasomes. Remember that proteasomes have to destroy the tagged proteins. So here, instead, we inhibit proteasome. We turn it off. Bortezomib will turn it off. So you turn off proteasome. Take a look at how interesting this mechanism of action is. We're turning it off. Everything is getting ubiquinated. Everything's ready to go get destroyed, but you turned off your proteasome. So proteasome is now inhibited. Proteasome. So what happens when you inhibit your proteasome? You'll have an increase of a lot of these proteins. They're getting ubiquinated. They're not activated. All these other types of proteins are also lingering inside. That will activate P53. And it will activate P53 on the cells that are having the highest level of proteins accumulated, the highest level of mess, basically, of this organization. And those most likely must be the cells that are creating those gamma proteins. Those should be the cells that are creating the gamma protein. So think about that. In multiple myeloma, you have a proliferation, right, of all these type of gamma proteins. Remember that those plasma cells, all these types of release of gamma proteins. So think about it. The cells responsible for this are the ones having the accumulation of proteins. And if you inhibit proteasome, chances are that the first cells that would have a problem, yes, yeah. Well, I'll tell you that gamma proteins are the proteins that make up immunoglobulins. Okay, alpha and beta proteins make up hemoglobin. Albumin is just straight up albumin. But yeah, yeah, yeah. I'll tell you one thing, Blarina. Any kind of protein that we give a patient, any kind of protein, could always have serum sickness. We could always have serum sickness if we give a protein to the patient, and we're giving a protein here. All those MAB type of drugs, like monoclonal antibodies, those are proteins. They can have serum sickness. You can have reaction with this. Whenever you're giving proteins that aren't basically their own protein, you'll have a reaction. So remember the activation, bortezomib. Now, there was another drug as well. I can't remember from the top of my head, but it does the opposite. And it's also given in multiple myeloma. I don't mean to confuse you, but there is also another type of drug that the way that this drug actually behaves is that it actually stimulates um, more apoptosis. Basically, I'm sorry, it stimulates degradation. Another drug for another time. But yes, there is another one as well. So keep your mind open on that sense. Okay, next one. Let's jump on to the next one. Let me see. Do we have any show of hands? No? Okay, then now basically post this one here and we'll see how we jump onto it. We should be able to answer this. I think we should. We have the power to answer it. So I'm going to put this one here and I'll read it. We can pick the answer and we can see what the best answer is here. This is a little lengthy. I do tell you it's a little lengthy, but worth it. It's worth it. Let me fix this up a little. Yeah, let me fix this up. Let me drop the coffee. So yes, let's type on it a little. Perfect. Nice. Perfect. Okay. So let's take a look at this. Karyotype is not 4S. So let me try to fix anything. Karyotype is actually 46 XY. Okay. Let's take a look at this. Let's analyze it. Which of the following is the most likely cause in this patient's finding? Let me drop the answer choices as well. Let's include those as well. So naturally, what I do is that after I read that little stem in the bottom, I then glance at the answer choice. Right away, Paulo says AIS. AIS. Let's see. Okay, now he says no. Let's see, because okay, we'll find out. Yeah, you're good. You're good. Don't worry. I understand. You saw XY and then you saw it said a 3-month-old girl. I don't blame you. I don't blame you. A 3-month-old girl is brought to the physician 2 days after the mother felt masses in the infant's groin while bathing. While bathing. Okay, she found it while bathing. Her physical examination shows bilateral inguinal hernias and a shallow vagina that ends blindly. So she has a blind pouch. She has a blind pouch. Serum studies show increased concentration of LH, follicle stimulating hormone, testosterone, and dihydrotestosterone. During repair of the hernias, gonads are found. A biopsy specimen of the gonads shows bilateral testes, a karyotype of 46XY. Ultrasound shows no uterus or fallopian tubes. Which of the following is most likely the cause of this patient's finding? What do you guys think? What do you guys think here? Could be C. Pablo says failure of the testes. Failure of the testes. So let's think about this. Let's think about this. What do I do? So this is the technique to get your answer pretty easily. What you do, you start off from the beginning. If they are able to give you all these types of features, then you are good. And they were. They gave us XY. That's the powerful feature there. They said XY. So right away, I know it's a male. All right, all right, all right. Yeah, no political correctness. Let's just say it's a male. Testosterone DHT is good. That is very important here in this question. But definitely, if it's XY, we understand that it will have testes differentiating factor. So it should have testes. Now, the evidence that they have given me that proves that it does have testes are two things. So it was able to prove two things to me. It was able to prove that there is no internal female genitalia. That proves to me that Sertoli cells were functioning because Sertoli cells were able to release MIF. So the fact that the patient has, let's say, it says here, where was it? Okay, ultrasonography shows no uterus, no fallopian tubes. FUP was inhibited. Remember, FUP is the internal genitalia formed by the Mullerian duct that forms the FUP. So MIF was able to inhibit this. So anti-Mullerian was secreted, meaning that the Sertoli cells are functional. Now, when it comes to the Leydig cells, they also tell me it was functional because I have testosterone, increased testosterone actually. They're hyperfunctional, we can say. It's actually working great. So what was lacking here is the actual, let's say here you have your Wolferian duct. Wolferian. And the Wolferian, remember, makes seed. So you have the lack of this. So there was no seed functioning here. Testosterone was supposed to work here. So I can easily say testosterone did not do its job. I don't have primary, let's say, internal male genitalia. So it's supposed to activate. It's supposed to activate the Wolferian. Remember, being a guy is difficult, I say, because of two things. Yes, that's when talking about testes fail to stimulate wolf. They actually were able to release the testosterone. The problem here is that you are insensitive to that testosterone. That testosterone is not able to stimulate. You're having the testosterone release. You're having dihydrotestosterone, but you're not having the expression of primary male genitalia, internal male genitalia, and also the external type of male genitalia is not being expressed here. PSP, yes. Prostate, scrotum, penis. There is none of that there. So that talks to me about a complete failure of androgens. There's different reasons why androgens can fail. If, for example, let's go step by step. If B was the answer, the patient should have internal male genitalia. He should have seminal vesicles, ejaculatory duct. He should have ductus deferens. He should have all of these features. The only feature he should lack would be a proper development of the penis, scrotum, and prostate, because that is the external type of genitalia. Remember, for that, you need the highest level of androgen, the superior androgen, DHT. So if it was B, he would have male genitalia. He wouldn't have female. You'll be able to inhibit that. But you wouldn't have the external type of genitalia. PSP would be lacking. That would be if it was B. C is what we have here in this scenario. Definitely. AIS. I'll never forget there was an episode of Oprah Winfrey. I'll send you guys a link. I looked at it. It's amazing because you see what looks like a female, but it's really a male. This is when the first time I ever heard of AIS. And she's describing how she has AIS. Yeah, go with the gut. Yeah, definitely. You got it in seconds. Testosterone is important for descending the testes, its migration down to the pelvis. Yeah, down the gubernaculum area. I remember it has to descend, it has to go down. Yeah, it is in that sense. Because remember, when you have more and more testosterone activity, the testes themselves, they grow to a certain size. Remember the rule of the glands. When you're stimulating your glands, they tend to grow to a certain level. More stimulus, the more growth you have. And they don't grow like muscles, like hypertrophy. They actually grow like in cells, like a hyperplasia, let's say. So these kind of glands, they're a certain size because they are active. When you don't have activity of that gland, it tends to atrophy. Does that make sense? So it's migration. Yes, migration is also in that sense because it starts to grow properly because it keeps getting used. Good, good, good. Perfect. That makes sense. Now, 21 hydroxylase activity. What would the patient have had in this sense? What would have been the features involved here? 21. Masculinization. Yes. Low BP. Yes. Hypotension. Everybody knows the trick, right? Everybody knows this trick. 11, 17, 21. Once that trick got discovered, med students just, yeah, everyone is able to win with this trick. Everybody knows this trick, right? If you don't know it, got to jump on the bandwagon for this one. You have to learn it if you don't know it. The first column is BP. The second column is sex hormone. They have to try something else. And you know what? Non-classical will manifest later in life. Yeah, that is true. The non-classical type, the 21 type. Yeah, that's the other type of 21. They had to go reaching out for other types of 21 because yes, everybody knows this. Everybody understands that. Right? Everybody understands that. Good, good, good. So let's if non-classical would manifest later in life, not BP affected in that one. Yeah, that is true. That is true. The non-classical one does not have such a big effect with the BP. Good. Let's look at this next question. This next question has to do with arrows. And this is a very good question. This has to do with growth hormone. We didn't mention much of growth hormone. We really didn't. But we have to understand the idea of how whole growth hormone operates. Definitely. Just to get the gist of it, just to have the idea. Remember that growth hormone. What releases growth hormone? Who remembers? What can release growth hormone? Growth hormone is released from where? Stimulated by what? Remember that it does have a lot of metabolic type of features. Adeno hypothesis, meaning the anterior pituitary. Yes. So Mona says, what was E? Mutation of the sex determining region Y gene. This is the ovotesticular problem. For example, in these kind of conditions, you'll realize that you have a issue, let's say, with your SRY gene. The expression of this gene is decreased. So it didn't increase enough to actually differentiate those type of testes. So then it has like an issue where there's like in between kind of problems where it didn't manifest itself enough to cause a complete type of differentiation. Therefore, you have somewhat a tissue that looks like ovaries, somewhat something that looks like testes, and then it causes a different type of manifestation there. It can cause this type of complication. That's the closest to a hermaphrodite that a person can be. That's the pseudo-hermaphroditism. That's what it will lead to. But okay, looking at this, the previous question, it was C. Definitely C. It was AIS. Androgen insensitivity syndrome. They were insensitive to androgen, looking just like a female. So in the Oprah episode that I'm talking to you guys about, in this Oprah episode, the girl was explaining her scenario. She was talking about the problem that she has with her androgen issue, where she's looking like a female, but she's really a male, and she explains her problem. And to our surprise, do you know what devastated her when they gave her the news? She's telling the story of how she found out, and then she's talking about how devastated she was. For me, I naturally try to put myself in a position like that, and I think to myself, I would be shocked, thinking, "Oh wow, I'm really a guy," like what in the world is going on? Like that would be something huge in that sense. But what really shocked this female was the idea that she would not be able to have kids. That was the day that she found that out, basically. So notice how different it is. Like for me, I would be shocked just the idea of finding out that you're really the opposite sex. But for her, it was the idea that she cannot have kids. So definitely, that's what shocked her in that sense. So okay, let me try to complete this question here. Put this bottom part in here. Okay, the question is ready. 35-year-old man comes to the physician because of a three-year history of an enlarging nose. Wow, enlarging nose. Coarsening of his facial features, muscle weakness, an increase in hand and foot size. Physical examination shows large, fleshy nose and prognathism. I know micronactism is when you have a very small type of chin area where it kind of retracts backwards. So prognathism should be the idea of a big jaw. Yeah, kind of like Andre the Giant, the wrestler. That's typical in acromegaly. They also have like Grand Khali, another type of wrestler. They all become wrestlers for some reason. The big jaw, yes, definitely. They are huge. So remember that the difference. What's the difference between acromegaly and gigantism? What's the difference between that? Does anybody know? What is the difference there? Kid and adult. Acromegaly, the cartridge is already there. You go. Perfect. Yes. Remember, you have that physes type of area that's kind of a gelatinous material that's located in the proximal region of your long bones. This is what allows our bones to grow. That growth plate, basically, it's still gelatinous and soft at this point. Yeah, they call it the physes. Epiphyses is above it, and then you have the physes is the actual like gelatinous material. So that area there, it's still soft and gelatinous while you're growing up, but it comes to a point where it ossifies and it basically gets really, really hard. That's when you have no more growth of your long bones at that point. So if you have increase of GH while you still have that gelatinous type of physes plate, then yes, that's what causes the issue. You can have gigantism. You grow to be very tall. So let me show you an example of both. This is Andre the Giant. I believe he's has passed away for now, I think. I mean, yeah, he died a long time ago. They don't live to be this long, let's say, if they become this huge. This is a guy who is 7'4" in height and weighed 520 pounds. 7'4" in height and weighed 520 pounds. So yeah, this is basically Andre. This guy, for example, if you have such a high level of growth hormone, what would end up happening is that you also have problems with your heart. So the most common cause of death will be because of the heart, right? Cardiomegaly. Definitely. This is what is causing these kind of problems with these patients. Now, let's show you gigantism, completely different. So and notice that the difference here, for example, you'll see this is a female from Brazil who she was really, really, let's see. So I want to show you this. She's the tallest girl from South America, and you'll see that her gigantism will express itself. The way you see it is that she'll look like she won't have that appearance. That acromegaly appearance is not present with these type of patients. These type of patients, when you actually see them, you'll notice that they're really tall in that sense, but they are having this normal type of appearance. That's gigantism, right? This could be corrected. Yeah, it kind of looks like Marfan's in that sense because of their long bones getting that long. It does. Remember, Marfan's tends to have that pes cavitis where their chest kind of caves in towards the middle, right? They also have problems with fibrillin that are affecting their eyes as well. And you also see issues with their heart as well. You can also see that problem occurring. So let's look at this question here. Let's finish reading it. But here are just two examples of gigantism versus acromegaly. Acromegaly is usually what you'll find in these kind of clinical vignettes, though. Definitely that's what you'll find. So here we're basically seeing that it says here, fasting serum studies show insulin increase like growth factor 1 glucose. Okay, is that right? That sounds like too many words put together, but yes, it is right. Oh, comma. Okay, comma. Glucose and triglyceride concentrations um, are showing anti-triglyceride concentrations. Okay, they're saying, okay, so what they're saying is that what you have here is basically fasting serum studies show increased in insulin-like growth factor, increase in glucose, and increase in triglyceride. You have increase of all those type of elements. Now it says increased serum growth hormone concentrations do not decrease after administration of oral glucose. Okay, so you have increased serum growth hormone concentration, and they do not decrease after administration of oral glucose. So compared to a healthy patient, which of the following best describes the metabolic changes in this patient? So let's demonstrate this by showing you this graph right here. What will you guys pick in this sense? Yes, the diagnosis is acromegaly. They expected you to know that. They expected you to know that, but now they want you to know and understand the dynamics behind this. They want you to know the dynamics behind this. So what would you guys say that the answer is? If you had to pick one, which one would you pick? Think about it. Muscle glucose uptake. Okay, Paulo says D. Let's see. Which one will be the easiest? So first off, let me ask you this question, guys. What is the easiest for us to say, yes, we understand 100%, this is that direction? You know, what would be the number one thing where we can say, we're going with this one 100%, this is following what I believe? Muscle glucose is definitely down, says Joyce. Muscle glucose uptake is going to be down. Okay. Mona says hepatic increase. Hepatic gluconeogenesis increase. All right. You have another D. Adipose lipolysis. What do you guys think for adipose lipolysis? High. High. Okay. So first off, what is the second messenger of growth hormone? Well, we should better yet said, what is the second messenger of the actual physiologically active? You're saying non-tyrosine kinase, and somebody says tyrosine kinase. So let's make sure we are talking about the same thing here. So we're saying the activity of, let me open this up and show you guys. Everything that is tyrosine kinase. Tyrosine is G, growth factor is, okay, so let's see. Let's iron this out. And insulin. So if we look at this, the non-receptor tyrosine kinase type, this is the one that has the activity of Jack the pig. Get Jack the pig. This is the JAK-STAT one. JAK-STAT one has growth hormone activity. You see that? Growth hormone activity. Let's remember that. So if we're, so keep that in mind. 100%, that is true. So which one is the, so that one definitely. Growth hormone releasing. So let's be clear. Let me show you guys. I want to show you guys one thing real quick, just so you guys could get this pattern into your head. So before we start going crazy, let's just keep this pattern into our head. A classic type of pathway that I love the most because it definitely shows you second messenger at work. This is the idea of TRH, TSH, and then T3, T4. Let's take a quick look at this. TRH, we can say, is GQ, second messenger system. TSH is GS. And then T3, T4, this is intracellular. So I love it how all these types of second messenger systems are so different intracellular. They're so different, yet they're stimulating the same type of pathway. Awesome. That's amazing. Love it. Now let's do a growth hormone one. Let's do a growth hormone one. Yeah. Let's look at this. GH, so growth hormone, releasing hormone. This is going to operate from GS system, right? GS. We could agree here, right? Growth hormone, releasing hormone. GS. Now, growth hormone itself operates from something else. So yeah, let me put this here so we can see this. The idea of cyclic AMP. Cyclic AMP, we have glucagon, we have growth hormone, releasing hormone as well. That's also part of this system. Okay, we understand that. That is GS. We all agree, right? The next one is growth hormone. What is the second messenger system of growth hormone? We just saw it. Jack the pig, right? JAK-STAT. JAK-STAT, yes. So JAK-STAT is a non-receptor tyrosine kinase. I hate the fact that they call it that, but just remember, non-receptor tyrosine kinase. All right, good. Now, the insulin-like growth factor 1. Remember, I told you anything that has growth factor on it, anything that has a factor, anything with a factor will be what exactly? Do you guys remember? Non-tyrosine? Tyrosine, right? Tyrosine. Yes. So let's keep this very clear in our minds. JAK-STAT is non-receptor. Put this here. JAK-STAT is the non-receptor type. Growth hormone is JAK-STAT. It's the non-receptor tyrosine kinase activity. Growth hormone, right? But when we look at receptor tyrosine kinase type, receptor tyrosine kinase, this is a factor. This is a factor. The rule is all factors will be that MAP kinase pathway. It's different. Remember MAP kinase? That was the activity of, try to remember. We have protein kinase B, mTOR on one side, and then you had on this side RAS, MAPK. Does that make sense? It's the same as insulin. Does that make sense? Did I confuse everybody, or does this pathway make sense? Perfect. Good. Everybody who's on board, this is good. Perfect. So look at this one. This one is not so beautiful. TRH was a lot easier, right? TRH, CSH was a lot easier. Yes, definitely. Definitely. Except granulocyte colony stimulating. Oh, that's the only one, yes, that has a factor on it. That is the only one, only because it's stimulating like those kind of myelogenous cells. That there on its own is part of the whole EPO, the thrombo type of stimulation. All that, yeah. So that's the only one. That is a good conclusion there. That one has the word factor in it, but it doesn't have growth factor in it. That's the one thing though. It has to have growth factor. Yeah, Paulo, that's the rule. It has to have GF in it. Yeah, it has to have GF in it. So anything with GF is a receptor tyrosine kinase. Definitely. So this pathway was not so beautiful. It wasn't so beautiful. It did have kind of hiccups in it. GS, non-receptor, and then receptor. It did have, you had to give it some thought and patience. But with some practice, it will become a lot easier. All right? With some practice, it will become a lot easier. So definitely this is growth hormone in the pathway. So let's understand what happens here. Let's understand what happens. So here, basically, if you're having this scenario occurring with these patients, we are basically in agreement. We're agreeing that muscle glucose uptake will be decreased. Why would the muscle glucose uptake be decreased? Can somebody tell me why? What would make sense here? Why is it decreased? You're saying no glucose. Well, insulin resistance is the answer I was looking for. Yes, insulin resistance. Yeah, okay, no glute, you're saying. Okay, yes. Yeah, no. Well, it's, yeah, because it's resistant to insulin, you stop expressing that type of glute. So, yes, that does make perfect sense in that sense. Yes, you have a resistance of insulin. So, that is happening there. So, yeah, what you end up having here is that your homeostasis when it comes to glucose is hindered completely. So you have increase in resistance. You cannot take up this type of tissue. And here you're having adipose lipolysis. So those who think the answer was D are correct. And let's explain this properly. These type of features that you're seeing. Let me be very, very clear. The number one stimulus for lipolysis, and this is kind of weird, is a decrease in insulin, let's say. Decrease in insulin tends to stimulate lipolysis in this sense. So there are also things like glucagon and other stuff, but let me show you guys. Let me show you guys what we're talking about. Remember, you have hormone sensitive lipase, which will start to break down your triglycerides on the adipose tissue. So hormone sensitive lipase is regulated by negative effect of insulin. So if you have a decrease in insulin, then you'll activate HSL, hormone sensitive lipase. So you'll be able to break down your adipose tissue into, so you have triglycerides. You start to take these triglycerides and break them apart into pieces. Your end product should be 3 pieces of fatty acids and 1 huge glycerol. That should be your end product. Hormone sensitive lipase should be snipping this down to smaller and smaller units until you then finally have 3 fatty acids and 1 glycerol. This glycerol will travel to the liver, where you will have gluconeogenesis, and then the fatty acids will undergo beta oxidation. Right? You'll break down your fatty acids. So you could have breakdown of these fatty acids, and these fatty acids can then turn into ketone bodies. Right? Then you can have ketosis. Try to remember this. This is the action that's going on. And remember, in order for your fatty acids to go inside the mitochondria, it needs a car. It needs a car. Whenever you want to mobilize things into the mitochondria and a lot of these pathways, you need to have a car. That's why you have a carnitine shuttle. Carnitine shuttle is able to allow your fatty acids inside. Fatty acids have long chains. There's a whole bunch of chains that it has. But one thing I do remember is that acetyl-CoA, acetyl or acetyl, however you want to say it, CoA is a 2-carbon molecule. It has 2 carbons. So as you break down this very long fatty acid chain, well, not very long, because if it's very long, it has to be broken down by peroxisomes. But if we're talking about the mitochondrial breakdown, remember that you start shedding this piece by piece, 2-carbon molecules called acetyl-CoA. Start to create more and more of acetyl-CoA. These acetyl-CoAs have the choice of either going through the TCA cycle or becoming ketone bodies. Once they become ketone bodies, they can travel through the periphery in the blood. And these ketone bodies, they can undergo a reaction where they start to produce this acetone. And that's what gives it the fruity smell in the blood. So why does this patient have insulin resistance? It's actually insulin growth-like factor that provokes this type of insulin resistance. It increases the peripheral insulin resistance. Yeah. It impairs the muscle and the adipose uptake of glucose. In that sense, the uptake is diminished. And by not having uptake, you start to then count on your lipolysis in order to have energy. So you increase your lipolysis. You start having gluconeogenesis. So half of the patients to actually have acromegaly actually end up developing diabetes. So that's what ends up happening in that sense. So remember that. Remember the idea of glucose and how this works. 0 to 4 hours, you're dependent on your dietary glucose, the glucose that you have consumed, dietary glucose. And now when we look at, let's say, 4 to 24, was it 4 to 24? Remember, it was a 48, I believe. I remember you have your glycogen. You now rely on your glycogen. That's the next one. And then afterwards, you have gluconeogenesis. Gluconeogenesis. You have to make your own type of glucose. Dietary glucose is your first 0 to 4. I think it was 4 to 12, something like that. Who remembers? It was when we took at the different types of sources. I do remember that the gluconeogenesis, this one here happens when you are fully depleted from your glycogen. 24, Marianne, right? 4 to 24. 4 to 24. And then 24 to 72. Perfect. Well, proteolysis is occurring during everything. But I just mentioned here the primary source. Primary source. So yeah, we have different sources of energy in that sense. We do have proteolysis occurring during the glycogenolysis when you're breaking down your glycogen. You're also utilizing your proteins as well. It's also being used. Yeah. Yeah, definitely. This is just the primary. So primarily you use these kind of things. Okay. So that was a really great answer. Yeah, whoever answered that was awesome. That was really good. Definitely you understand the dynamics behind that growth factor. So what do we treat? How do we treat the patients for this issue? What is our priority here? What do we do? What's the idea? Octreotide. Paulo says resection. Okay. So yes, you can resect this. You can remove this. You can resect this. You can remove it from a sphenoid type of surgery, but it has to fit a certain type of criteria, right? You have to have a certain criteria that fits. If it's having some type of symptoms, if when you give medication, it does not regress, if it does not get smaller after a pharmacological management, then yes, you can resect, right? That's the typical idea of any kind of pituitary type of tumors. That's the same idea with prolactinomas, right? We want to treat, instead of giving somatostatin analog like octreotide for prolactinomas, what do we actually give in prolactinomas instead of giving? Yeah, well, not antagonist. Not the antagonist, right? We want to give an agonist, yes. So bromocriptine, what else? Yeah, basically, right? You want to give something that will actually work. Oh, carbagalene, yes, I've seen this one. Yes, definitely. Carbagalene. I think you guys are spelling it wrong. It just looks weird. But yes, I do agree with you. Yes. Agonist, remember? Because those receptors that are found there in the tuberoinfundibular system, the receptors that are found there are what type of dopamine receptors? Who remembers? What type of dopamine receptors are actually found there? D2 is correct. D2 uses what as second messenger system? Can anybody tell me? D2 uses what? GI. It is inhibitory. So try to remember this, all the Spanish speaking people. Just remember the word C. C means yes. So yes to dopamine. D1 is GS. D2 is GI. Definitely. C. Say yes to dopamine, basically. All right. That makes sense. That makes sense. That's a dopaminergic type of pathway, the tuberoinfundibular system. That one is inhibiting at all times prolactin. If you give antipsychotic drugs, remember, antipsychotic drugs can actually inhibit D2. If you inhibit D2, you have increase in prolactin. There's one, so I want everyone to know one drug that can cause side effects, just in case. Put this into your arsenal. The drug is called risperidone. Yes, they call it risperidone, but I like to call it risperidone because, yes, it has an increase in all the different types of side effects. You name it, it's there. Extrapyramidal side effects? Yes. Weight gain, metabolic syndrome? Yes. Prolonged QT? Yes. Does it also cause prolactin release? Yes. Quetiapine has been seen to cause weight gain. Quetiapine can cause the weight gain issues. So keep that one in mind, the metabolic type of syndrome. Olanzapine as well. Both of them can cause that. Also, clozapine. They all cause QT prolongation. That's the thing. Others are more prone to cause it than others. Like there's like a level to it. Like for example, ziprasidone is one that has been seen that's highly associated with prolongation of QT interval. So is risperidone. Ziprasidone, yes. QT prolongation will actually cause a polymorphic type of ventricular arrhythmia. Polymorphism, not mono. Monomorphism is just straight. It has its amplitudes, which do not fall out of margin. They stay within the margin. That's the difference between those. So how do we treat torsols to point? How do we treat torsols? Stabilize membrane with magnesium. Magnesium, yes. Perfect. That makes a lot of sense. What if the patient is hemodynamically unstable? What do we do? Hemodynamically unstable? What do we do? Cardioversion is correct. Cardioversion. Perfect, perfect, perfect. You guys are ready. You guys should be taking the test already. What's going on? You guys are good already. That's good. Perfect. So that makes a lot of sense. Now let's look at this scenario. Yeah, we're going to do more questions as well, but let's look at this scenario right here. Let me just show you one thing. If we look at the midbrain, remember that the midbrain has a very important part right here called the substantia nigra. Those little pins that you have here, those are substantia nigra. This Fragile X syndrome also have similar mechanism like insulin growth like factor. No, it doesn't. It doesn't. It's pathophys. Everything about it is completely different. Yeah, they're having like a, I believe it was an increase in testosterone. They're having like a hyper gonadism. Like they look huge. So yes, source of dopamine, the substantia nigra. Also, you have the ventral tegmental area, ventral tegmental as well. Ventral tegmental area and the substantia nigra, these two areas. The ventral tegmental area, we can nickname this meso or meso, so midbrain. So we say mesolimbic, we're saying ventral tegmental area going to the limbic system. If we say mesocortical, ventral tegmental area going to the frontal lobe, cortical. This is the cortex, so frontal cortex. So dopaminergic pathways, there's 4 you should know. Mesolimbic is coming from the ventral tegmental area. Yeah, mesolimbic and mesocortical. What part of the limbic system? This is called the nucleus accumbens. Nucleus accumbens, that's the actual name of that. And then, of course, your prefrontal cortex, that will be the mesocortical pathway. So yes, dopamine is being released at that sense and it's binding into this system. Then, of course, you have the nigrostriatal, the striatum. So the striatum is the caudate nucleus, and the putamen, however you want to say it. That is the striatum. Okay. So nigrostriatal, the substantia nigra to the striatum. Then, of course, you have the tuberoinfundibular system. This one is different. This is the median eminence going to the pituitary stalk. This is the actual area where a lot of release happens from the hypothalamic area to the anterior pituitary area. They have that little these vessels that are located around there, the medium eminence. So these are the pathways right here. So I'm going to put this in the chat as well. You guys can get this, download this, look at it, do what you have to do. This is the dopaminergic pathways, more specific type of occurrence here. So is mesolimbic and mesocortical D1 are present? Yes, they are. They are. D1 is the majority of times you'll see the presentation of D1. D2 is not really involved in too many things, but I can tell you that it's involved in the indirect pathway of the basal ganglia. Remember that the basal ganglia has a direct pathway and it has an indirect pathway. The indirect will inhibit movement while the direct stimulates. Okay? For basal ganglion, it's super easy, guys. The key is this. Anything that has the word thalamus in it is a stimulator. Okay? Subthalamic nucleus is stimulating. Anything that has the word thalamus in it is a stimulator. And then all those globus internus, globus externus are inhibitors. So I can show you an image that we can break it down, but don't have to go too deep into it. But just know that that makes things a lot easier in that sense. So yeah, if you guys got any questions, let me know. Let me show you this pathway real quick. This is the idea of indirect pathway. Direct pathway. Look, it has thalamus, is stimulating. This one here has subthalamic nucleus, is stimulating. Everything else is inhibitory. But notice that globus pallidus is inhibiting an activator, which is good because this activator was going to activate an inhibitor. So this is kind of confusing if you don't understand it. Yeah, Paulo, we got to break this down. We got to make this easier. Definitely, that's my goal here, making this exam a lot easier. There's a lot of different things that you can look at and make sense of it. And that's one of them. The thalamus, anything that has thalamus in it is a stimulator, having excitatory effect. The ventral anterior nucleus, this is located in the thalamus. The thalamus has a lot of different nucleus. Hopefully we can understand there's many different nucleus that make up the thalamus. The ventral anterior is one that connects the thalamus. It receives the idea of globus pallidus of the basic basal ganglion system. Ventral anterior sends it off to the motor cortex. That way, whenever you coordinate your movements are done properly. Right? You have your voluntary movements, but you also have this type of stimulus, making sure that your muscles are coordinated properly. Okay? So understand that type of activity of the basal ganglion. What type of symptoms do I have if I damage the subthalamic nucleus? Who can tell me? What type of symptoms do I get when I damage the subthalamic nucleus? Hemibolismus. That's what we have. Yes, hemibolismus. Flailing. But remember that it's contralateral. Remember that bit of information. It is contralateral. Definitely contralateral. So, yes. Let's get back to the questions. That was a nice little detour towards neurology and the idea of dopaminergic type of pathways. Going back to these type of questions, yes, the answer was D. We basically explained lipolysis and how it works. But the key feature, the tuberoinfundibular pathway, just to close it off with this, I'm just going to show you this. Remember this one thing. The arcuate nucleus is responsible. Here, this is where the inhibition is going on. This is where you are inhibiting this system. Remember the hypothalamo-hypophyseal portal system? This is creating an access from the hypothalamus to the pituitary. So remember that a lot of hormones that are releasing hormones, like thyroid releasing hormone, for example, they like to travel into the system to then activate your anterior pituitary cells. So here, lactotrophic cells are responsible for releasing prolactin. Okay, here's a question for everybody now. Prolactin stimulates. It's stimulated by what type of second messenger system? Who remembers this? Prolactin. Jack. Wow. Lorena, that's good. That's awesome. Stat. Okay. That's good. Yeah, you guys got that. Definitely. No argument from me. That is 100% correct. Jack stats. Yeah. Prolactin. Okay. Perfect. Perfect. Yes. Okay. This is a good question. The next one is a really good question. I love this type of question. This one is involved with the dynamics, physiology. We love physiology. In this part of the world, physiology is something that allows you to understand pharmacology, allows you to easily understand pathological features of any type of disease. If we understand how it works, we can understand the lack of function. So let's look at this. This is the idea of kidney physiology. Yes, especially Marian. Marian is a physiological pro. She understands all the dynamics about this. Definitely. For example, I know you can get this question correct, Miriam. You know the answer for this one. You know the answer for this. Go ahead. You might as well unmute yourself. Go ahead and try to answer. I believe you can get this right 100%. We talked about the idea of the dynamics of renal blood flow.
As a matter of fact, right now I'm looking for how to unmute.
Yes.
Now let's try to do this question. Which of the following best explains the maintenance of a constant GFR in this experiment? Okay, a study is conducted in which the right renal artery of an experimental animal is constricted. A study is conducted in which the right renal artery of an experimental animal is constricted to decrease artery pressure by 20 millimeters mercury. Measurement of I believe this is inulin clearance. Shows that the renal artery constriction has no effect on glomerular filtration rate. Okay. Measurement of inulin, okay, shows that the renal artery constriction has no effect on the GFR. Which of the following list? Okay.
So yeah, definitely. Let me fix this up. The measurement, yes, it was of inulin. I don't know why it came out with an F, but inulin is measured. You remember what inulin can do?
Well, inulin is like creatine. It just gets excreted right away, right? It doesn't get reabsorbed. It doesn't get secreted, right?
So yes, there's no reabsorption. There's no secretion. It just can only go in through Bowman's capsule.
Yes, right? Just one way out.
Yeah, the only way out is excretion.
Yes, right.
One way in, one way out.
That's right. So it mimics the GFR. So measurement shows that the renal artery constriction has no effect on the GFR. Renal artery constriction has no effect. Which this explains. Why is there explains the maintenance of, because the efferent, it's probably the efferent is constricted at this point. Let's see. Yeah, I think increased efferent arteriolar resistance would maintain the GFR. So if I constrict the efferent, I will keep the GFR going, right?
If you constrict the efferent, you will keep the GFR going. I agree with you here.
I guess right? Yeah,
So
that's
what would
right.
be the answer here if you had to pick a letter?
So
Just
that would be E.
good,
E is
perfect.
increased efferent arterial resistance.
That is correct. That is correct. You see how you broke that down very easily?
Yeah.
Did that make
Mm.
sense to you? That made perfect sense. Increase efferent arteriolar type of resistance. Good job, Marianne.
Thank
Definitely. Definitely.
you.
That was awesome. That was perfect. Because yes, you're seeing it saying here that measurement of inulin clearance shows that the renal artery constriction has no effect on glomerular filtration rates, GFR, which of the following explains the maintenance of the constant GFR in this patient. So this animal is constricted to decrease RQ8. Is that the actual word? Yeah, RQ8 artery pressure by 20. So measurement of inulin is used. So in order, yes, you're seeing that basically no matter the animal, as long as it has kidneys, yes, as long as it has kidneys, we understand the physiology of it and we're seeing how we can actually manipulate GFR. GFR function is manipulated in this sense. So there's also this type of protein that we can release that also has an effect on the efferent type of arteriolar resistance. Do you remember what protein can cause this type of increased resistance in the efferent? You guys remember this? What can cause an increased resistance in the efferent type of vessels, but at the same time causes a dilation of the afferents?
That's the AMB.
Yes, the AMP, that's the atrial natriuretic peptide.
That's right.
Now, there is a protein that breaks this down. What's the protein name? What is it called?
Caprolizin.
Yes. Now, what's the drug that inhibits that protein? You're almost there.
Sacubitril. Yeah.
Yeah, the sacubitril type of. Yeah,
Yes.
it has a weird name, but yes,
Yes.
sacubitril.
That guy.
Yes,
Starts
this
with
one
an
is
S.
definitely this one is given hand in hand with ARBs like losartan. So let's keep that in mind. Before, back in the day when I took the exam, it was just easier to remember the type of drugs that stop cardiac stops the remodeling of the heart. Post MI, post any kind of MI, you have certain types of drugs that decrease the remodeling of the drugs of the cardial cells. What do I mean? Remember when we were talking about the fibrotic effect? Remember when we were mentioning, oh, neutrophils, day 1 to 3, and then 3 to 7, we have macrophage activity, then 7 to 10, macrophage activity, and then also we mentioned the idea of fibrotic cells, like things that are going to stimulate scarring. Then we mentioned the idea of 8 weeks. I think they said 2 to 8 weeks is where you have your scar deposition. That's not really true. It continuous happens down the line because you eventually have remodeling of the tissue. And in order to decrease the remodeling effect, because if you have increased remodeling effect of the heart, you end up having a higher risk of mortality. So to decrease the remodeling, we have to decrease as much our angiotensin 2 as we can. So the idea here is different types of drugs. I remember the drug list was ABS, like abs, like you have abs. It was ACE inhibitors, you have ARBs, you have beta blockers. Remember beta blockers? You have a B1 type of receptor located at the level of the kidney that will stimulate renin. So you can block this from actually stimulating. So beta blockers also, and then spironolactone as well. Spironolactone. Well, spironolactone is a weird one because spironolactone, remember, it's just blocking the aldosterone types of receptors. But these were the normal drugs. This was all I had to remember. That's what made me happy. That was it. That was good. It was definitely very high yield, something you can just pick immediately when you see it on the answer choices. Now things are taking a turn. Now they're also adding the sacubitril accompanied with the losartan. So it's a combination of losartan and sacubitril. Losartan is just the ARB. Okay. So add this onto the list of those kind of drugs that you can give for the decrease in remodeling of the heart, right? Does that make sense, everyone? Good. Perfect. 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 Yeah, you guys got this. This is completely easy for everyone here from what I see. Everyone here is dominating this. Why ARBs with sacubitril? They give this combination. They give this combination to the point where you don't want to have more stimulus of aldosterone. So it's like, remember that aldosterone itself is what is provoking the increase in reabsorption of sodium and the increase in volume. So you don't only want to just stop the natriuretic peptide from being destroyed. You don't only want to stop that. You want to have the AMP. You want to have this, but you also don't want to go against it. So what is going on? Remember that if you have aldosterone present, aldosterone will increase your preload, will increase the volume. So if we are having something that is basically constricting your efferents and dilating your afferents, like AMP, then we do not need aldosterone effect to also be stimulated, right? Because here, what we're seeing is an increase in GFR. You're basically filtering more and more fluid. Eventually, if this keeps on happening, you'll stimulate aldosterone. So we have to make sure that we could also have something protective that will not allow aldosterone to be released. Does that make sense? Yes, yes. Everyone is answering. Everyone is doing pretty good. I'm telling you guys got this. This is not too crazy. Definitely everybody here keeps getting this right. This is not a problem. I'm looking for something difficult, but all I see is easy kind of questions just because we went through so many things. We talked about so many different types of problems here. I feel like everybody here will get all these things right. But regardless, let's put it here anyways. This is the question. Then this is MBME. We're all exploring an MBME. None of these questions are supposed to be easy. This is supposed to be tough MBME questions, and everybody is dominating. So let's see. Again, let's put this here. This is not a 5G. This is a 56-year-old woman. So let's fix this up. Let me just fix up any kind of typos here. You guys can read and to yourself definitely know what the answer is, but I would put this here 56, but I will include the answer choices as well. This is answer choices that you will see here have to do with neural. Definitely has to do with neurals. Let's take a look here. Let me minimize this. Let's try to fit everything in one screen. Everything fits good here. Let me just make this wide. There you go. Let me put this back here. All right, now we're done. Sorry for the inconvenience, but here we go. This right here. All right, so I'll read, guys. Impairment of which of the following is the most likely cause of this finding? Most likely the cause of this finding. So they want me to identify the impairment, and then they want me to connect it to a finding. Okay. See, Paulo says direct depolarization of calcium. Let's see. A 56-year-old woman comes to the physician because of a 3-week history of increasing weakness of her arms and legs. She has smoked 1 pack of cigarettes daily for the last 30 years. Physical examination shows pronounced weakness of the hip girdle muscles and lesser weakness of her shoulder girdle muscles. Both of which improve with repetitive testing. Oof. That is a huge clue right there, right? Huge clue right there. That was intense. A chest x-ray shows hilar lung mass. Yes. Electromyography is compatible with a malfunction of the neuromuscular junction, impairment of which of the following is most likely the cause of this patient's finding. Oof. Okay, Blarina says gravis. Let's take a look. Let's see what's going on. Let's take a look. Let's see what's going on. Analyze this. Let's see. The one thing that they hinted off towards, postsynaptic acetylcholine receptors, Blarina says a thymoma is related with that. Let's see. Yes, that's the difference there. So yes, Pablo, that's the difference. So Blarina, one of the biggest clues here that they try to give you for Lambert-Eaton is that when you have Lambert-Eaton, you actually start to activate and more, get more movement going, and then the symptoms, the manifestation becomes it demonstrates itself at a lesser degree. When you have more movement, it will start to manifest itself at a lesser degree. Unlike myasthenia gravis, that when you
Yeah, I
yeah, when
was
you
just
start
gonna say, isn't that myasthenia gravis? They always tell you by the end of the day they get more exhausted. So Lambert-Eaton is gonna be the opposite.
yes,
Oh,
Lambert-Eaton is opposite. The more movement you have, the more activity, the more you're engaging these type of receptors, the more you're having channels active. While myasthenia gravis, you'll realize that your immunoglobulin, let's say, it's like at the level where you wake up, you're having more wakefulness, you're moving around, you're having activity. It's like a competitive type of action. Towards the end of the day, you're now having like less activity there. So what ends up happening is that these immunoglobulins are now more dominant in that sense. You run out. Yes, basically, that's good. Mona, yes, it's like you run out. The morning you're loaded with a whole bunch of acetylcholine. Towards the end, you're running out. Yeah, that's the problem there. You can't overcome. Can't overcome. It's like a competitive action that you have. So let's explain something and let's put some terminology into this as well. We're going to talk about each kind of answer choice, but here the answer here definitely is C. The answer here is C. As squamous is related with PTH. Squamous is related with PTH, right? With that fake PTH, the parathyroid related hormone, with that fake one. That fake one starts to stimulate, just like we look at PTH, it starts to do the same thing, but it has something at a lesser degree. So let me include this fact here. The PTHRP, I think is called. This one here has a less activity when it comes to stimulating the kidney to promote 25 dihydroxycholecalciferol, the 25 vitamin D, in order to have 125 vitamin D. This PTHRP does this at a lesser degree when we compare this to PTH. This does not do this at the same level. It does it at a very, very minimal level. That's one clue, one thing that you guys should know. Everything else with the dynamics of PTH, it causes that. Yes, definitely. So, okay, in this, yes, this is Lambert-Eaton. That was a big clue that they gave us, but we now should understand one thing. Let's try to digest these clues. Let's digest these clues properly. Anytime they mention to you proximal muscle weakness, you should start to think myositis. Proximal muscle weakness is myositis. Now, we don't know why exactly. There's different types of things that can cause a myositis. Even parasites can cause myositis. Parasitic type of infections. But myositis, the typical type of clinical vignette should be a person who has a problem going upstairs, standing up from a chair, combing their hair, taking something from a jar. If that's the case, they have weakness here and weakness in their quad areas. People who eat polar bears. What type of problem was this? Toxocara canis? Was that the one? I remember the people who eat bears. You definitely have a problem. There is myositis. I do remember there was myositis, but there's also a problem with the eye. For some reason, I do remember that you have periocular issues with that one. It causes muscle weakness. And then vitamin A. So vitamin A. Okay, so what vitamin A? Hold on. Those who are intoxicated with vitamin A. So what are we talking about here for vitamin A? We're talking about. Okay, you're talking about proximal eating the liver of the game. Okay, I'll tell you one thing here. Keep this in mind. Proximal muscle weakness goes hand in hand with myositis. Now, they gave us a differential here. They started to talk about the idea of hip girdle muscles, but then they said that there is no weakness of the shoulder, lesser weakness of the shoulder muscles. Now, that's not something you should see with myositis. Myositis, it should be equally distributed. The weakness should be equally distributed in that sense. Okay. Myositis has a lot of different differential diagnoses. You definitely make the diagnosis not only through patient history, but also with labs. You look at ESR, you look at CK, right? Your creatine kinase, definitely. There is polymyositis rheumatica. There is hypothyroidism. There is glucocorticoid types of intoxications when you're using it for too long. You're thinking statins, but yes, you can see fibrates can cause a lot of hepatic type of issues there, but statins is basically more of the type, right? Statins is the problem there. So that's for myositis, but they eliminated that right away when they told me that there was not an equal distribution of weakness in the proximal muscles. There wasn't an equal distribution, so they eliminated that off the bat right away. Now they said that it was lower, so I would expect if it's lower, something like Guillain-Barré. That would kind of make me think of that. But then once I keep reading, I'm seeing that they said that it was located in the hip girdle. They didn't really mention much of some kind of infection that the patient had in prior areas. Instead they related this to smoking. They related this to a history of smoking, which is the only limited type of information that they gave. Then they talked about a hilar lung mass. So just giving this type of information, I'm already understanding that this must be some kind of neurological problem. And we're definitely having an issue with neuromuscular problems. So it says here, electromyography shows is compatible with the malfunction of neuromuscular junction. The junction has a problem. Okay. Impairment of which of the following? So yes, here the answer was C, direct depolarization of muscle fibers by calcium. Does that make sense? Impaired liberation of acetylcholine. So let's talk about this. Let's make sure that we understand all of this stuff. We're going to get into each one and describe it properly. Yeah. We're going to get into each one and describe it properly. But one thing I will tell you is this. Remember this. So we have neurological cells. We have presynaptic and postsynaptic. There is a conversation that likes to go on. There's the conversation that goes on between these two different neurons, the presynaptic and postsynaptic. You have to actually stimulate the next one. So usually inside the cell, well, inside our body, we have conversations between neuron to neuron. We have conversation between neuron to muscarinic type of receptors. And we also have combinations that go on with neurons and muscles. So let's get this straight. Neuron to neuron. These are connections that are happening, basically one presynaptic to a postsynaptic. Many times this is due to a relationship with two different types of channels, right? You have the AMPA, and you also have NMDA. Now here they're going to utilize the main neurotransmitter here, which is glutamate. Right? This is going to be the glutamate type of activity. You are releasing this, and this is going to actually be binding to this AMPA type of channel. It binds to this AMPA. This will allow influx of sodium. Sodium enters. Now the cell usually is going to be found at a negative resting membrane potential of -70, but you have to take it up to a -50 in order to have depolarization. Well, 55, I believe it was, 55. And once you trigger this depolarization, it can go up to +35 about. And then it goes all the way back down, right, to repolarize. This is the typical type of depolarization, repolarization cycle that we find. This is what typically will happen. So here in this situation, this scenario, you're seeing that the main type of neurotransmitter is the glutamate or glutamine. I think it's glutamine. So yeah, glutamate, you're saying. Let me make sure. 100%. Definitely, this is going to be, I'll tell you, glutamate. Yeah, you're right. Glutamate. So glutamate is going to go and stimulate this type of activity. Now, why does NMDA not work? Because it has inside of it a magnesium blocking. There is a magnesium that's blocking this activity. Magnesium is blocking. So what we have here is that we have to then get a lot of sodium inside the cell. So then this can approximate the threshold. Once the threshold is achieved, once you have this cell becoming more positive, now you'll have displacement of the magnesium. You're able to kick the magnesium out. When you kick the magnesium out, now it could actually be stimulated by glutamate. And this causes an influx of sodium, but also an influx of calcium. So you have a very powerful type of excitatory action. You have a very powerful type of excitatory reaction. This is what is actually going on here at this point. This is neuron to neuron activity. This is how they're talking. They are communicating to one another. They're talking. Presynaptic, postsynaptic. This is what we have. Let's just connect one concept to this really quick. Remember the idea of an excess of ammonia. Ammonia is like this. When you have hepatic encephalopathy, you fail to actually make ammonia go into the urea cycle. Remember that your liver is responsible for running the urea cycle. In the urea cycle, you should be able to take that ammonia, and put it inside the mitochondria, right? Definitely. Put this inside the mitochondria. When it goes towards the mitochondria, remember, this is one of those pathways that's very interesting because it operates both inside and outside of the mitochondria. So really quick, I'm just going to mention this one mnemonic, and I remember this mnemonic. It makes me remember everything in the sense of urea cycle. I don't know if you guys remember. Anybody who took class with me before remembers when I gave the urea pathway or the Krebs cycle. It's all about old criminals, right? Old criminals are Argentinian in the urea cycle. And Krebs cycle is, remember, old criminals in Kansas sell sex for money. That was the TCA cycle. When it comes to urea cycle, is a lot more simple. Old criminals are Argentinian. That was the urea. So, okay, let's understand. Old is for ornithine. So ornithine has to become citrulline. So this reaction here that you have, this ornithine to citrulline reaction, this is the one that's going on inside the actual mitochondria. And in order to have this happen, you have to have carbonyl phosphate. You have to have this present already, carbonyl phosphate. I'm only going to mention this real quick. We're not going to go through the whole entire cycle. I'm just going to mention one thing. Carbonyl phosphate goes into ornithine and becomes citrulline. So okay, yeah, also for this, I don't know if you guys remember the other mnemonic, which was AFU. Like you're saying AFU. You say A past the criminal. AFU. So why do I include this AFU? Well, because A is going to be very important. Here for A, you have aspartate. Aspartate does not get broken down like all these other types of, it takes itself and it presents its own ammonia in order to become part of urea. So let's be very clear. One thing I want to tell you guys is that urea, how much ammonia does urea have? Who remembers? How many ammonias are found in urea? How many? How many are inside of here? Remember, this is a process to throw away your ammonia. Ammonia is toxic. So Mona says 1. I'll tell you what, Mona, you do have one original that comes from an amino acid. There's one amino acid, let's say, whenever you're breaking this down, it's going to dissociate its ammonia. But then you have aspartate, which comes along and joins this. It cuts the line. It comes along in this step and it joins this. And it basically gives its own type of ammonia. So there's 2. You'll find 2, right? You're having these 2 types of ammonia. One is coming from aspartate. The other one is coming from whatever you're throwing away. So that makes sense. So here in urea, what we're seeing is this. Let's make sense of this. Yeah, it's okay. It's okay, Mona. The main one is this. When we take a look at it, we'll notice it like this. So I'm going to take a little screenshot here and just show you guys. This one here would make a lot of sense. Yeah. Paul, if you want to speak, definitely unmute yourself and we can talk, because definitely don't have any issues here. You can talk, definitely. But what we're seeing is this. This is the pathway that I'm talking to you guys about. Look at this AFU. After the criminal comes AFU. A F U. Oh, it's okay. Don't worry about it. Yes. Yes, that is true. Okay, you see that? AFU. Old criminals are Argentinian. AFU after the criminal. Aspartate is joining the metabolism. Fumarate is escaping in order to have TCA cycle activity. And then you have urea release here. So this is just what I'm mentioning here. Now, the point in me mentioning this, the whole point of me mentioning this is that if you have damage of the liver, if you have liver damage, like in chronic alcoholism, you won't be able to use this urea pathway. You won't have the power to put ammonia into your mitochondria to actually initiate this process. If you cannot initiate this process, then you cannot make your urea. So let's be very clear. Ammonia itself is going to become, well, you're going to make urea in the process of getting rid of it, right? Urea has another type of ammonia as well from aspartate. It took it from aspartate. But what you'll notice is that this happens via liver, hepatic system. Now the urea excretion happens kidneys, right? So this makes sense. This makes perfect sense. The kidneys are what are going to excrete the urea. All right, so if we have a problem here with the hepatic system, we end up having something called hepatic encephalopathy. If the patient has hepatic encephalopathy, what will happen in this sense? What will end up happening is that NH3 starts to increase. Well, urea is also toxic. That's the problem. So who's less toxic? I would definitely say urea is less toxic. If I had to choose one, I'd rather have a urea problem. But yeah, well, I don't know, because the treatment differs, right? With hepatic encephalopathy, what's the treatment? What is the treatment of hepatic encephalopathy? Yeah, flapping tremor, that's called asterixis. You'll see the flapping of the hand. That occurs because of an increase in excitotoxicity, which is occurring. You have way too much excitation. Okay, perfect. Amna, rifaximin, and lactulose. That is the actual treatment. Lactulose. Yes, lactulose and rifampin. Rifampin, they have more proclivity to give you this type of rifampin type of treatment. That's like first line in that sense when we're talking about antibiotic type of effects. Who remembers the mechanism of rifaximin? Sorry, I keep on saying rifampin. Rifaximin. How does rifaximin work here? The thing about neomycin is that you have to have a drug that has less absorption power. You don't want something that you can actually absorb into your bloodstream. Like rifaximin is perfect because it's really, really low in the level of absorption. So rifaximin will manifest itself on the GI tract. So a lot of ammonia, basically, a lot of the pickup of ammonia happens via the GI tract. That's where you have a large amount of ammonia. So what ends up happening is that with rifaximin, you're able to cause, so Amna said DNA polymerase inhibitor. Yes, that is true. DNA polymerase type of inhibitor. So that is true. You have a DNA dependent RNA polymerase inhibitor, to be exact. That's what you have in that sense. Remember that, let's say, for example, prokaryotic cells, when you're doing replication, when you're going through the process of replication, you guys do remember that you do need proper types of enzymes in order to make this function. When you're going through the process of replication, there is going to be, yes, less ammonia gets produced, Ballerina, because these bacteria that are effective in breaking down the proteins, they start to die off. You start to kill them off. That makes a lot of sense. You start to kill them off. Let's remember one thing. Eukaryotic cells and prokaryotic cells. Prokaryotic cells, the prokaryotes, remember, they have different types of DNA polymerase, right? You have the DNA polymerase 1, 2, and 3 for prokaryotic cells. I don't know if you guys remember this. This is way back. This is molecular type of biology, but we have the sense to remember this. DNA's polymerase 1. This one has the activity. So which, first off, DNA polymerase 1. Let's say we have a strand here like this. I know I'm going a little crazy with it. I know I am, but definitely worth understanding this properly. Let's say we have this type is called the leading strand, right? Does that make sense? Leading. And then, of course, we have the lagging type, which is basically going this direction, lagging. Right? So what is going on here? We are synthesizing DNA here at this point. This is the process of replication. Prokaryotic cells use the DNA polymerase, right? The RNA-dependent DNA polymerase. So yeah, I said RNA polymerase. No, sorry. Amna, you were right. DNA polymerase. DNA polymerase. Let's be very clear. Very clear. Whenever you need to replicate, the idea of replication, remember you have the origin, the point where you will start your replication, right? This point has to happen first. You have to actually have an idea of where you will want to replicate. That's how all these things are starting. Wherever you start, you have to lay down first a primer. Primers have to get laid out in order for you to have activity of DNA polymerase. Let's keep this very clear. You have to have primer activity first. This primer is telling the DNA polymerase where to bind. We don't see that with transcription. This is different. Transcription is different. This is one of the major things that I'm going to tell you when it comes to the differences between the idea of having transcription for protein synthesis and replication. They're going to have one major difference. One major difference. Yes, the startup. It's the startup. The idea of where you're starting. So this type of startup, for this activity to occur, you have to have laid out a primer. Primer. It needs to be laid out first. It needs to actually be there. That way, you can synthesize this direction. You can synthesize here. But you need to have your DNA polymerase bind to the primer. So let me make this very clear. Very clear. We have a target here that we want to copy, let's say. Let's say we want to copy some kind of nucleotide activity. In order for us to know what type of nucleotide activity we want to copy, what do we have to do? We have to lay down a primer. Primer is exactly what DNA polymerase can bind to. They can bind to these primers, right? That way they know where to go, what to do. When we look at, that's DNA replication. When we look at DNA transcription, instead of a primer, we have transcription factor. Transcription factor, which is going to basically manifest itself once the promoter is enhanced, once the silencers are removed, once this activity goes on, you can now have transcription factor. Transcription factor allows for the binding of RNA polymerase. RNA polymerase. Polymerase. They would bind transcription factor. We're going to simplify this 100%. This is how everything initiates. Okay? Here's primer. So yes, you have these type of cells that are active. Now, what is the problem? The problem is that this does not have exonuclease activity. What do I mean? What do I mean? So whenever I create a strand, I have to check to see if the strand was properly created. We have to check to see if the strand was properly created. That's what happens in this sense. That is the problem that we have for this point. So DNA polymerase 3 is the major type of enzyme that's utilized, let's say, in this sense, for your prokaryotic cells. Notice that you'll have DNA replication. A lot of that goes on here with that sense. RNA polymerase. Let me put this here. I'm going to show you guys an image here when it comes to prokaryotic cells. Prokaryotic cells are going to utilize these different types of enzymes. I know this is a crazy topic. I'm just going to give you this image here. You guys can use this down the line. Okay, use this down the line. This is basically the 3 different types of enzymes that you'll find. When we talk about 5-3 action, I was talking to you just basically about the leading here and then the lagging. 5-3. 5-3 activity can be found. Both of these represent 5-3. Both of them. One is able to repair. The other one, basically, you don't have the 5-3 activity that repairs. Okay, one is. So, okay, I'm not gonna go too deep into it, but all I'm trying to tell you is that with this type of drug, you can stop transcription. You can stop this idea of having replication. You can stop it. You can end that process. What's another thing that stops replication? Remember that here you have to relieve these coils. You have to relieve these coils because this is circular type of DNA. I remember these needs relieving of coils. So you have topoisomerase 2 and topoisomerase 4, right? DNA gyrase. Yes, perfect. So what drug inhibits topoisomerase? Who remembers? That's another type of reaction there. Ciprofloxacin. Yes, quinolones. Perfect. Fluoroquinolone, ciprofloxacin, definitely. So I'll put it to you like this, guys. Whenever it comes to antibiotics, I can easily break them down. It becomes very easy to me. Why? Because I break them down by mechanism. I break it down like this. Antibiotics, you think what creates mRNA? You do have 3 different processes here that are very important in creating mRNA for bacteria. Number 1 is going to be the DNA polymerase, right? The DNA polymerase. That's very important when it comes to that. DNA-dependent RNA polymerase. RNA polymerase, let's say. That's what you see when it comes to mRNA creation for bacteria. What else? You also have here in the second part. So yeah, I just mentioned bacterial type of DNA replication, but we can also get into the idea of transcription of proteins. So remember, protein transcription is RNA polymerase. It's different. Remember, transcription of proteins, transcription factors. Replication, primers. Okay, let's not get too into it though. So let's just tell you this. Now the second one is topoisomerase. We just mentioned it. Topoisomerase. Definitely. Fluoroquinolones, ciprofloxacin. Then the last one I'm going to tell you is de novo. The de novo pathway is building up the blocks. The blocks are basically the cytosine, uridine, thymidine, all these different blocks. So you could inhibit this pathway by inhibiting enzymes involved with this pathway, like 2 of them. The 2 of them, dihydrofolate reductase, and also the other one, which is dihydroteroic synthase. Dihydroteroate synthase. Teroate synthase. Those are the 2. Those are the 2. Woo. Yes, dihydrofolate reductase. What inhibits this, guys? What inhibits this? Can you guys tell me? What will inhibit this? Dihydrofolate reductase. TMP is correct. Methotrexate in humans. Yes, methotrexate in humans. Let's continue the flow. How about in toxoplasma? What inhibits this? Dihydrofolate reductase inhibition in pyrimethamine. Pyrimethamine. Yes, pyrimethamine, definitely. And remember, in malaria, you could inhibit this with proguanil. Proguanil. Perfect, perfect. Yeah, you guys are pretty much good. Now, dihydroteroate synthase. This is PABA. PABA forming with dihydroteroic acid. Well, it makes dihydroteroic acid with pteridine. PABA and pteridine make dihydroteroic acid. Dapsone and sulfas. Yes. Dapsone and sulfas are correct. They are correct. Remember dapsone and sulfas. Dapsone gets used for, you guys know the drill already, right? You guys know this? People who take classes with me all the time. It gets used for what? What could we use dapsone for, guys? Oh man, I love it. I love the repetition. Yeah, hepatic. It's called dermatitis herpetiformis. Dermatitis herpetiformis. It's basically looking just like herpes, but it's actually part of the skin manifestation in celiac disease. Skin manifestation in celiac disease. Definitely. That's what you use dapsone for. You also use dapsone as one of the drugs for what else? Leprosy. Leprosy, perfect. Leprosy, yes. Remember, we can use rifampin and dapsone. And if it's the tuberculoid type, you use those two. If it's the lethal type, if it's the lepromatous type, the lethal type, what do we use? We add clofazimine. We add clofazimine to that one. Okay? We use those 3 drugs if it's a lepromatous type. And remember, you can get leprosy from armadillos. I know it's kind of random, but yes, armadillos. There was a question on that. Okay? Keep that in mind. Keep that fresh into your mind. Good. That was a really, really good, nice review. We swam in there. We navigated our way out of there. That has to do with transcription. All those things that we just mentioned have to do with transcription. So yeah, you're giving this kind of rifaximin drug to inhibit transcription. Yeah, clofazimine and dapsone for the lepromatous type, but you also have to have dapsone for lethal. Yeah, the lepromatous type is lethal. So the tuberculoid type. Can you tell me what type of T cell is activated here for the tuberculoid type of lepromatous disorder? Lepra disorder? Th1 is correct. Th1. So I would ask you then, what interleukin is active here? What interleukin is causing this? What interleukin is involved in this reaction? IL-2 has to be involved, technically speaking, because you have to have a higher level of T cells in order to have this. But the main one, yeah, IL-12, interferon gamma, macrophages, tumor necrosis factor alpha, right? This is the war that gets fought in the tuberculoid type of reaction. Now, the lepromatous is a bit different. Here for the lepromatous, you're using a Th2 type of reaction, right? The war has elevated itself to this level. So you guys remember this. It's awesome that we went through so much immuno as well, because we got that all out of the system. Now we understand all these different types of flues. So let's take a look at this. Here is saying acetylcholinesterase. Impairment of acetylcholinesterase. What situation will have this? When do we have impairment of acetylcholinesterase? Who remembers what type of disorder? Pisson. Oh, okay, you're saying organopoisoning. Okay. Organopoisoning. Yeah, organophosphate poisoning. Definitely. Organophosphate poisoning. You remember that? What's the treatment for this? Now I'm going to ask you, what is the treatment for this? Organophosphate poisoning can inhibit acetylcholinesterase, leading to a higher level of acetylcholine in the synaptic cleft of both nicotinic and also muscarinic. Atropine and pradadoxine is correct. So guys, I'm going to now crack this little code for something that's super hard for a lot of people to understand. Because I remember for me, it was kind of like contra. It was hard to understand because I thought to myself, how is it that I'm stimulating something yet I am inhibiting it? It was so hard for me because I thought to myself, it just didn't make sense. So let's take a look at this. You have a presynaptic cell and you have a postsynaptic. Yeah, pradadoxine definitely. Pradadoxine will displace the organophosphate from the acetylcholinesterase, while atropine will actually bind to the muscarinic type of receptor. Right? Good. So let's get back. Let's take a look at this. So what ends up happening here? This is something that was super hard for me to understand. It was the neuromuscular type of junction. I thought to myself, so we're done talking about the glutamine and the AMPA and all that. If we look at this in this sense, look at the nicotinic. In nicotinic, you'll have acetylcholine release. And I always ask myself, why don't we have an atropine for nicotinic receptors? Why don't we have an atropine for nicotinic type of receptors? What blocks this type of cell? Neuromuscular. What blocks the muscular? I always thought to myself, there was a group of drugs that I started to learn about a while back, a long time ago. Succinylcholine. Things like succinylcholine. There was also one that starts with a T on the top of my mind. It was a tubro. Yeah, weird names they do have. But these type of drugs, so look at this mechanism here. They have an actual activity here. And this is very, very intelligent, the way that whoever thought about this. They said, hey, I am going to be able to inhibit nicotinic type of receptors. And we do need this for surgery. You don't not want nicotinic, these kind of muscular cells, to actually be active during a surgical procedure, right? You want to shut them down. So there's a way of shutting down these muscle type of activities that you have. So how do we do this? We can give things like succinylcholine. And this was super weird to me because I thought to myself, isn't that an agonist? Why is this having an agonistic effect? How is this actually agonist on the nicotinic type of receptors? Yes, let's understand this. If I stimulate this at a very weak level, very, very, very type of weak activity, remember one thing, you cannot depolarize something that is undergoing depolarization. That is the rule. Remember, we have that in cardio, they call that the refractory period, right? Remember, you have a refractory type of period where the cell cannot be depolarized no matter what happens. You have that action potential, which is the entire period. But then again, you have the absolute refractory type of period where you cannot depolarize the cell that's already undergoing depolarization. It has to go over its whole cycle, it has to depolarize and come back to repolarization. So with these type of cells, the succinylcholine, there's a couple more. What they actually do is that they are a very weak type of agonist, and they're stimulating depolarization inside these cells. They're stimulating a depolarization inside the cell. But what's happening here at the level of depolarization is that it's so weak that you're not seeing any activity. You're not seeing any type of activity. Therefore, it is basically inhibiting by activating. I know it's a weird phenomenon if you guys think about it. They have questions on tests on MBME that I saw, and everybody has a different reaction to these type of drugs. So they test them before giving it to the patient. I've seen questions where they show you that, oh, like the induction of this cell. I don't know if you guys remember this. All the veterans will. People who have been studying and taking these MBMEs, you gotta remember. There's this one question that's like this that shows you like the rapid response versus a delayed response of these type of cells, demonstrating insensitivity, delayed recovery from succinylcholine. Yes. Okay. Hopefully you guys understand what I'm saying. I know it's kind of confusing, but what I mean to tell you is that there is a special type of activity that goes on here. This activity has to do with a weak type of stimulus. And they do this during surgery to make sure that the patient does not move. There's no actual stimulus there. These are called neuromuscular blocking drugs. Let me pull this up in the first aid because they're probably more eloquent in describing it than I am. Is this drugs that what causes the malignant type of hyperthermia in that case? It can cause it can. Definitely it's messing around with that system. But I remember that anesthetics like to cause these type of problems. Yes. Remember that, the malignant hyperthermia. But yeah, these can as well. These can because you're messing with that system. You're messing with the neuromuscular type of system. The more neuromuscular type of depolarization is a lot more difficult to understand when we're mentioning all these different types of problems. It's a lot more difficult because it has a different type of activity. You have T tubules. You have to get into the idea of T tubules. Normally with these kind of cells, we just talk about depolarization, repolarization. Here we're talking about the stimulus of T tubules and how it can then start to stimulate its neighbor, right? And this stimulates. You also have another type of organelle, basically. You have to have release of calcium from that sarcoplasmic type of reticulum where you're now releasing that calcium in order to have a proper contraction. So we'll get into that another day when we talk about depolarization in general, because there's a lot more questions to do. But definitely remember that the muscles are a bit more complex in that sense. It has more complexity. Let's take a look at this list here. They can explain it a lot more eloquently than I can. They're talking about the idea of muscle paralysis. In surgery, you want to have this. And you're doing this selectively. Neuromuscular, nicotinic type of receptors in the neuromuscular junction. Not the autonomic, meaning not the muscarinic. Okay. So it says here, succinylcholine is a strong neuromuscular nicotinic receptor agonist. It produces sustained depolarization and prevents muscle contraction. Once you are depolarizing, you won't be able to depolarize again. So it does this sustained depolarization. I hate the fact that they said that it produces a sustained. Okay, they didn't say anything about strong, right? Good. It says here, strong. Yeah, that's what I don't like. Strong, because it kind of makes you think that it has a powerful contraction. It doesn't, right? So reversible reversal of blockade. Phase 1, prolonged depolarization. No antidote. Yeah, you can't really do much. It is actually it's actually depolarizing. Okay, depolarizing here in that sense. Now, phase 2, repolarization but blocked. So in phase 2, this is when you are now repolarizing. So it says nicotinic receptors are available but desensitized, may be reversed with cholinesterase type of inhibitors. So yes, during repolarization, you'll realize the cell is no longer undergoing depolarization. So you'll notice that you can stimulate the cell now, but it takes a lot more. It's a lot harder to stimulate that cell. But technically speaking, you can stimulate it. That's when it reaches phase 2. So understand there's 2 different types of phases. Phase 1 is reaching depolarization. Well, phase 1 is depolarizing, actually. You reached it. So let's be very clear here. Let's give these kind of names. You probably heard of the end plate potential. You guys ever heard of that? You guys ever heard of that? This terminology that likes to get thrown around just to confuse people. End plate potential. So when you are going from -90 to -55, right? Here's that end plate potential. Here we're talking about this end plate potential activity. Okay, this is that phase. That's what they're saying. When it hasn't depolarized, it hasn't reached threshold yet. That's the end plate potential. Hasn't reached threshold yet. Okay, that's what they mean. So don't get confused here. It's that easy. They're talking to you about it's going towards this area. That's end plate potential. Then when you talk about the depolarization, this going to actually being more positive, right? To reaching the level of positivity, like 35, let's say, has to reach this level. Here now, at this point, we're talking about depolarization. And this is what they mean by phase 1. Phase 1 is depolarization. So I'm going to put it right here, phase 1. Phase 1. Now, repolarization, you're going back here. This is phase 2. Technically speaking, this happens in cardiac cells as well. You can you can stimulate the cell as it is repolarizing. I know it sounds crazy, but there is a point where you can stimulate. It takes a lot of work because you have to overcome the acidifying potassium channels, but you can stimulate at a certain point of repolarization. So this repolarization point, let's say like right around here, you can come back to stimulating. It doesn't have to go all the way back to resting memory potential. I know it sounds crazy, but there is this point where you can. Right? The refractory period. So let's see. If you look at the definition of refractory period, you'll see it's in there in cardio. So that's what they're talking about when they say the second phase. They're saying, look, nicotinic receptors are available, but desensitized, may be reversed with cholinesterase inhibitors. In phase 2 is the repolarize. The repolarized but blocked. That is the idea there with phase 2. Phase 2 basically undergoing this kind of situation. Now it says here complications include hypercalcemia, of course, hyperkalemia, malignant hyperthermia. Malignant hyperthermia. What is the treatment for malignant hyperthermia? Who remembers? Well, dantrolene. Dantrolene. Malignant hyperthermia should actually be going on in phase 1 because of that contraction that you have. That sustained contraction is what's going to cause that problem. So you can't really have contraction if you're not really if you're repolarizing. See what I mean? Dantrolene is correct. What type of receptor does that block? What type of receptor does that stimulate in that sense? Because you have to have stimulus. You have to have ryanodine receptors, right? Ryanodine. You have to have that calcium, basically. Yeah, it's okay. It's okay, Mary. So yes, this says here increase.
Question.
Yeah.
I have a question. So if you have that pseudo, like that deficiency where you can't metabolize acetylcholine, or you don't have enough acetylcholinesterase, that would affect phase 1, the pseudo cholinesterase deficiency.
Okay, so hold on. Pseudocholinesterase deficiency. I would have to know more about that one. What's up with that deficiency exactly? How is that behaving? Does it have problems with yeah, so hold on, let me see that. That's a let's see, pseudocholinesterase. Okay, that's more of a okay, it's a rare type of disorder.
They
Okay,
asked
yes.
this in, it's a rare, but they asked this in questions. Yeah,
Oh
it's like
wow.
genetic.
Okay. So it's genetic. So yeah, I would love to see a question on that actually. That sounds really good. Do they manifest this in an early age? My question will be: is this manifest in a very early age, or is this something that you see as adults?
They
Yeah, this is
usually bring it up with like if you give them anesthesia and they don't wake up. Like why?
okay. Yes. Okay. Yes. Yeah. I heard about this. Yes. This is most like yeah. This is when someone basically. This is why they like to test this beforehand before putting the patient under this type of neuromuscular blockage. They like to test them before the anesthesiology. The anesthesiologist will try to test them before. Um, this normally happens because the breakdown basically. So pseudocholinesterase, what you have happening there is that you need to break down this succinylcholine. You have to break it down. So if you're unable to break down succinylcholine at the proper rate, you'll have prolongation of this issue. It prolongs the duration. So your muscles won't be able to mobilize for longer periods of time. This is serious because it can cause respiratory type of depression. Remember, you need to have those type of muscles, the diaphragmatic muscles and also your intercostal muscles in order to expand your chest. So if you have this type of pseudocholinesterase, yes. Yeah, so I thought that you were talking about something that just manifests itself normally. This is something that when you put your cells under this type of reaction with succinylcholine, it has a problem metabolizing the succinylcholine. Yes, it has genetic predisposition. That's what causes this problem. So, what was your question exactly? You were asking if someone with pseudocholinesterase deficiency, what would happen to them? What was the question?
Oh no, I was asking, would it affect then phase one?
Okay,
Because
so it it will affect not phase one because here it's working. This is the idea of it working. Now the idea of it coming back, of you getting rid of it, that's when you have more of a problem. So it would work properly, just like it works on all of us. The issue is that the idea of breaking it down, this is where we're now having a complication. The idea of dismissing it. So you have a problem with the dismissal of this. So you're going to see that in phase two, it is repolarized but blocked. So you have a problem, and it's also desensitized. So the functionality of that type of drug will work. It would work perfectly. But the problem with pseudocholinesterase is the idea of breaking down the succinylcholine. Yeah, prolonged. So I would say it would have a strong effect on phase one. But the issue is when it comes down to removing this, to getting this out of the system, here's where it's having a more prolonged effect. So in phase two, this is where we start to see this effect where you are desensitized, where these type of cells are not reacting. So I would say the functionality of this is working, right? It's working properly. It's actually working. The problem is that once we're done with the actual anesthetic or we're done with the procedure, we have to remove this. We have to get this out the system. Our system normally would metabolize this. You have the metabolism through ester hydrolysis. You're able to hydrolyze these type of succinylcholines. But in this case, you cannot. So in this case, it is prolonged. In this case, we're having now problems. So that's the issue that you have here. It says here may be reversed with cholinesterase inhibitors. So yeah, so it says phase one will be prolonged more than expected. It will work better than expected, yes. But then when it comes to phase two, the idea of removing it out of the system, you usually remove it at phase two. That's when you're having more of a complication there. So yeah, that definitely, that's a good one. Really good example. Thank you, Mona, for that example. That's a good one. Because yeah, that cholinesterase inhibitors like neil stigmine. So yes, but we have to make sure that it's functioning at the muscle junction. So yeah, neostigmine is a good one. Remember, you have to make sure that it wins the competitive type of battle. Definitely. So keep that in mind. That is 100% true. That would work in that sense. And remember one thing, guys, let's make a little connection here. What type of hypoxemia would you have? Who can tell me? What type of hypoxemia would you have if the patient is having a malfunction of these muscles? Hypoventilation, correct. So my question would be, the AA gradient, would it be increased or decreased? AA gradient, would that be increased or decreased? That will be normal. Good. Perfect. It will be normal. Awesome. So we're saying that the PaO2 will be decreased, definitely, less than 60 because you're having hypoxemia. That makes sense. That makes sense, right? That's awesome so far. And we're saying that you would have hypoventilation. This is a problem here at this point. Now, I would ask you then, at this point, tick, yeah, very tricky, right? I mean, that's what MBMEs will do. MBMEs will also trick you with that. Higher, low, normal. So yes, definitely. Here you're having this type of problem. This is in hypoventilation is when you see these kind of issues. Remember that, guys. Now, I would ask definitely, how about the PCO2? How would the PCO2 be in a patient like this? What do we expect to see with these type of patients? It'll be increased. It'll be increased. Increased. Perfect. So yeah, hypoventilation has a lot of different types of patterns. Remember, we mentioned this in the camp. We got into specifics of this. We talked about the dynamics as well. In the camp classes that we do, we talked about how this actually functions. We mentioned that normally you have this type of pontine medullary center, basically in the pons though. That's actually stimulating respiration cycle. Remember that this is stimulated by the decrease in oxygen, because when oxygen is low, you have to then increase your respiratory rate. When you have, for example, the pH, so remember this, your pH is very important as well. When your pH tends to be high or low, what will stimulate an increase in respiratory rate? High pH or low pH? Low. If your pH is low, you want to get rid of PCO2. So therefore, you want to increase your respiratory rate. That's perfect. Okay, that's perfect. Low pH means you are acidotic. So therefore, you want to get rid of excess acid. So you want to have more respiration cycle. That way you are relieving more CO2. That makes sense. This here is the pontine medullary respiration center, and this is happening at this point. Now remember, opioids can decrease respiration rate, right? That can also happen in that sense. That will make perfect sense. Opioids can do this. What else? What other drugs can do this? You guys remember? CNS depression. Barbiturates. Anything, yes. Barbiturates tend to activate GABA. Try to remember GABA channels. GABA channels are functioning through the idea of this weird channels. Remember, I told you there's these channels that have ligand activity, and also they have channel activity. If you have this ligand here stimulated here, this GABA will open up chloride. Chloride will then go through. And remember what happens here. Chloride is negative. If chloride is negative, these cells have negative 70. They try to get to negative 55 in order to depolarize. If I have more chloride here, I will make this more negative. Therefore, I would have, let's say, negative 80. Now it's a longer path to depolarization. That's why hyperpolarization is occurring here at this point. So you're saying aspirin activates, aspirin stimulates and causes hyperventilation, alkalosis respiration, and metabolic acidosis. Okay, yes. So in aspirin type, so let's look at this first. Just remember that GABA, when you have barbiturates, Ben frequents the bar for a long time. Benzos increase the frequency of this channel. Barbiturates increase the duration of this channel. but both of them are making the cell hyperpolarized. That way, it's harder to depolarize your neurological cell. It's a lot harder to depolarize. But yes, aspirin. When we look at aspirin, remember there's 3 phases. Aspirin intoxication. Remember at first, remember that you have a stomach right here. So let me draw this nicely and let's explain this. Let's look at it like this, guys. You're having this stomach. Let's say you ingested a whole bunch of aspirin. The body starts to recognize already. It recognizes that you have a high degree of acid. Right away, you're able to recognize this. Now, the minimal amount of aspirin that enters the bloodstream, right away it goes and it hyperstimulates the brain. Your body starts to recognize this immediately, but you only need a little bit of aspirin to have the stimulus of the brain, of this pontine respiratory medullary center. It will get stimulated immediately. It'll get stimulated immediately. It's hyper responsive as well to the CSF fluid. If there's any change of the CSF fluid when it comes to acid, it responds. So this is the first phase. In this phase, we have, let's look at the measurements. You have pH, you have respiratory rate, you have PCO2, and you have bicarb. So let's understand this. In this phase, your pH will be high or low. Everybody tell me. Let's see if we know. High or low. Let's go through this one fast. How would your pH be in this sense when you first give aspirin? Your pH will be low. Everybody's saying low, but actually is going to be high. Your pH will be high. Let's explain this and let's make sense out of this. So let's see. What you have here is the vessels. When we're measuring the pH, remember this is the blood level of acidity. Blood levels of acidity. You want to make sure that your pH is basically going to be 7.35 or 7.45. You want it in this range, right? In your blood. So what ends up happening here at this point is that the minimal amount of aspirin that has entered into your bloodstream starts to activate your pontine medullary respiratory center immediately. So here you're having an increase in your respiratory rate. The increase in respiratory rate is causing a decrease in PCO2. The decrease in PCO2 will reflect as respiratory alkalosis. Respiratory alkalosis. That's the first thing that would happen. So let me show you guys a little trick here. And this goes for anything in medicine. Whenever you're having a problem, let's say I have a problem. Let me just write like this. Problem with the lab or something. The first thing I want to look at is the first mechanism of compensation. The first mechanism of compensation should show me that it's on my side. I want to make sure that my body is on my team. I'll explain. So yeah, let's keep this in mind. If I have a problem, the first thing I want to look at is the mechanism of compensation that happens first. So I'll tell you why, Amna. If I have, for example, increase in respiratory rate. Why is my respiratory rate increasing? Because the aspirin, it's in the stomach. It hasn't really gotten absorbed yet. Gotten absorbed yet. Little pieces of it has gotten absorbed, let's say. Small, little minor pieces. These little pieces are enough to hyperstimulate the actual brain. It'll hyperstimulate the brain. It'll cross blood-brain barrier with no issues, and it'll hyperstimulate, leading to an increase. Remember, we have the respiratory center, leading to an increase of respiratory rate. So if my blood has not absorbed all the aspirin that's found here, it hasn't absorbed it yet. This was just freshly given. All the aspirin is found here. The minor, let's just say only one little aspirin makes its way through, is causing hyperventilation. It's causing an increase in respiratory rate. So we'll see the manifestation look like a lot like this. The respiratory rate is increasing. When your respiratory rate increases, you start to release PCO2. PCO2 is very acidic. So if you have a decrease of PCO2, it should reflect with an increase in pH. This is called respiratory alkalosis. This is respiratory alkalosis. Does that make sense? Right? Good. Perfect. Good. Okay, so let's speak about this then. In this case, this is awesome. This is what's happening. It's a respiratory alkalosis. Now, time keeps going by. As time keeps passing, you'll notice that you'll start to reabsorb more and more and more of this aspirin. You start to have more absorption. I said reabsorb. Absorption. The absorption starts to be noted. It starts to go into your bloodstream. So what ends up happening, we have a buffer system. We have many different types of buffer systems, but this one in particular, we're having a very specialized buffer system with bicarb, right? Whoa, I wrote the C backwards. Okay, bicarb. This bicarb is able to find something that's acidic and it'll buffer this. It will neutralize it. So there's neutralization going on. It's neutralizing acids. It's neutralizing acids. But as it neutralizes acids, it starts to decrease. It starts to get lower. So let's say it was 24 or 25. Now it's getting lower and lower and lower. It's decreasing. It's decreasing. And the blood itself is becoming acid. There's a lot of acid going in there. It can't keep up. It can't keep up. It cannot keep up. So what ends up happening here? So yeah, you have different mechanisms of survival here. Definitely have different mechanisms of survival. I mentioned one that was very important called it's called amniogenesis. Remember when you have ammonia, you're making ammoniogenesis. That's what it's called. Okay, ammoniogenesis. Sorry. It's just I'm imagining how it's written and then I'm trying to say it, but ammoniogenesis. This is the idea of making ammonia. Why? Because ammonia can also buffer. Ammonia, remember, ammonia can easily become ammonium if it picks up a hydrogen. It's able to pick up a hydrogen in that sense. Also, remember the idea of our cells. Our cells have potassium and proton. It's a specialized pump that can switch your intracellular potassium. It can switch this off for hydrogen. So it takes in the hydrogen and it kicks out the potassium. That's another mechanism as well as compensation. What is another mechanism of compensation? Well, you have phosphorus now becoming phosphoric acid. It starts to pick up more and more types of charge. Also, your amino acids. You have glutamine becoming glutamic acid. Anything that could become acid starts to become acid. You start to see this type of activity. You try to throw off as much ammonia as you can as well, because your ammonia can pick one up, and ammonia can become ammonium. This consistently starts to happen. What else do we have? We also have the alpha intercalating cells. Yes, definitely. That's a kidney type of buffer, definitely. We also have the alpha intercalated cells. Try to remember that the alpha intercalated cells are found in the collecting tubules. These alpha intercalating cells do have carbonic anhydrase inside of them. Let's put this here. Intercalated cells. This does have carbonic anhydrase. So what does carbonic anhydrase do? Carbonic anhydrase is able to find water and CO2 and convert this into carbonic acid. Now, once you have carbonic acid, you're now able to convert this carbonic acid into hydrogen and bicarb. Bicarb will be reabsorbed. Alpha intercalated cells allows reabsorption of bicarb in exchange for fluoride. This is stimulated by aldosterone, ladies and gentlemen. This is stimulated by aldosterone. So you have here fluoride and you have bicarb. And then also you have the release of hydrogen into the urine. At this point, a lot of ammonia picks up this hydrogen. So your ammonia tends to pick up this hydrogen and become ammonium. Remember, alpha intercalated cell, this A is the initial letter of the alphabet, 1. So I could remember this is the pathophysiology of RTA1. Renal tubular acidosis is associated with alpha intercalated cell problems. Remember that. Alpha A for acid. This is the cell that has to do with acid. Don't confuse this with the principal cell. Principal cell has to do with ENaC and potassium. Remember ROMK and ENaC. That's the principal cell. Both are stimulated by aldosterone. Yes. Yes. RTA2 is the tubule. Yes. Perfect. This happens at the level of the PCT. Yes, it does, Amna. It does happen at the level of the PCT as well. But remember the PCT here, this carbonic anhydrase is more available. It's not hidden inside a cell. This is the carbonic anhydrase that we tend to inhibit with what drug? Who remembers? What drug can be used to inhibit this type of carbonic anhydrase? acetosolamide. Acetosolamide is used for what disease? Who remembers? Glaucoma is perfect. Yes, it can be used for glaucoma, definitely. What else? Yes, idiopathic increased hypertension of the brain, basically. That's the pseudotumor cerebri. Altitude sickness as well. Intracranial hypertension. Yeah. Yes. Perfect. That makes sense, right? Good. It's used as a diuretic. Think about that. How in the world is this used as a diuretic? Do you understand how? Does everybody understand how? Does everyone understand how? How in the world is this used as a diuretic? Well, I'll explain. Don't worry, guys. I'm here to explain. This will make perfect sense. So here on the PCT, we have the idea of HGAP. HGAP is the mnemonic that I use just to remember all the channels that are associated with the PCT. PCT channels, remember I have here H. H represents hydrogen activity and also activity of bicarb. That reminds me of acetosolamide. G is for the glucose. Remember you have glucose channels here. Glucose channel. This is called SGLT. SGLT2, right? 2 kidneys, you have SGLT2. In the intestines is SGLT1. And then here you have A for amino acids. Amino acids like tryptophan can actually cross through this barrier. It doesn't have that negative type of property. It's not this huge type of protein. So this amino acid can actually cross over, but it does get reabsorbed. That's for your amino acids. And here, if you have damage of this is causing Hartnupp's disease. Hartnupp's, the manifestation is the same as a niacin deficiency. You have the 4 Ds: dementia, death, dermatitis, diarrhea. Yeah, because tryptophan is used as a precursor for niacin, right? So this makes sense. That's for A. Now, SGLT2, you can inhibit this with what drug? What drug inhibits SGLT2? Who remembers? Who remembers the inhibition of this? Gliflozin, empagliflozin, dapagliflozin. Yes. Good. Okay. And then P. P is the phosphate trashing hormone that works here with phosphorus. Remember, if you activate this activity, you'll have more trashing of phosphorus. Phosphate trashing. Vitamin D does the opposite. Vitamin D does the opposite reaction on this channel right here. Okay. Good. So remember that. That's all this. So what was my question was, how is acetosolamide an actual, let's say, diuretic type of drug? Well, I'll explain. By opposite, what do I mean? Okay, by opposite, how PTH is able to promote the trashing of phosphate, vitamin D is able to promote the reabsorption of phosphate. So you have more phosphate reabsorption to the bloodstream. Does that make sense? Perfect. This is very important. Why is this so important? Try to remember one thing, why this is so important. Because in the physiology of calcium, PTH can tap the bones. It taps the bone in order to release calcium, right? It taps the bone in order to release calcium. And then we have to remember, it also causes this effect where it's in the kidney promoting the wasting of phosphate, let's say phosphorus. It's wasting that, throwing it away. Okay. In order for us to equalize this problem, what PTH does in the kidney is that it also stimulates this 1-alpha hydroxylase. And 1-alpha hydroxylase promotes calcitriol. That's the actual active version of vitamin D. So you'll have active version of vitamin D, calcitriol, activated. This vitamin D will be able to go to the intestines. And at the intestinal level, this will stimulate phosphorus reabsorption. So here it causes reabsorption of phosphate. That way you don't lose your phosphate. That way you can equalize your phosphate levels. And the intestines is causing phosphorus reabsorption, vitamin D. Vitamin D is also reabsorbing calcium. Yes, perfect. I love it. This is so much progress. We're doing so much progress. We're doing so good. So yes, this is the PCT. This is how it works. This makes sense. So how does it work as a diuretic? Let me explain. The channel in the alpha intercalated cells, I did mention specifically, I said that you reabsorb bicarb exchanging chloride. I mentioned that, right? I said that the exchange of chloride happens. Here, it's different. Here, we're using sodium symport channels. Remember, symport channels. What does that mean? That means that sodium is going the same direction as our main metabolite. It's going towards the same direction. So that means that if I am reabsorbing, if there's reabsorbing of this metabolite going on, then guess what is also going to be reabsorbed, right? You have that water, basically, let's say. So typically this tends to happen at this point. But through it all, of course, we have to understand the idea of, so yeah, let's be very clear. Let's be very clear. Okay, yeah, so yeah, let me be very clear here. So I'm going to show you guys the image. Yeah, let's show you guys the image because actually the reabsorption is again happening with chloride. So yeah, let me show you the image. It's happening with chloride, but this is what I mean. The H. So yeah, that's the reason why in H gap I always write the H by itself, is because I have to remember. Yeah, this is very important. So don't make this mistake. H here, you're seeing H. This is the only one going the opposite direction. This is what I meant to say. Definitely H you're seeing is causing, the hydrogen here is going to cause sodium to get reabsorbed. Everything else is symport. You see how everything else has a symport activity. So yeah, I flipped it around. Everything here has symport activity. Notice this. Everything here is going the same direction as sodium. You see that? The one that doesn't is H, is the hydrogen. So this one is different. In carbonic anhydrase, what you have actually happening here with carbonic acid, you do have that bicarb reabsorption. That is happening. That is happening in the exchange of chloride. It is still happening in the exchange of chloride. At the end of it all, you do have bicarb entering the bloodstream, and you have hydrogen being excreted. That's the end result. So the drawing that I have here is reflecting the physiological action of hydrogen and bicarb at the PCT. This is the physiological response that normally happens. Hydrogen, you're seeing secretion of hydrogen here in exchange for sodium. Secretion, I should say, of hydrogen in exchange for sodium. So H is useful just to make the bicarb get reabsorbed. Yes, it has to actually work. Yes, you're seeing that. Definitely. In that sense, this is what you're seeing that's going on here. How in the world do we get bicarb reabsorbed into the bloodstream? In order to get bicarb reabsorbed into the bloodstream, you have to have this carbonic anhydrase activity inside the peritubular cells, inside the peritubular cells. Inside the peritubular cells, you do have carbonic anhydrase, not only in the lumen. So let's be very clear. Let's be very clear with this. Carbonic anhydrase, the enzyme, is located both here in the lumen, and also here in the peritubular cells. Both of them have carbonic anhydrase. So water can enter peritubular cells. CO2 can enter peritubular cells. And they can become hydrogen and bicarb. Hydrogen getting kicked out in exchange for reabsorption of water. Bicarb getting reabsorbed in exchange for chloride. So we kind of have the same activity going on here. Notice that. Notice that. It's a fair interchange. Just saying, hey, here's my acid for the urine. I'll take the bicarb. That's what's happening at this sense. That is what's happening at this sense. When you give carbonic anhydrase, you turn this off. You turn this off. Therefore, your bicarb never does this interchangeable reaction. Therefore, your bicarb just gets urinated, just gets peed off. So this reaction, you're now missing out on this. And this right here is major because now you're not reabsorbing sodium. Lack of reabsorption of sodium equals a decrease in volume. Lack of reabsorption of sodium equals a decrease in volume. Does that make sense, everyone? Does that make sense? Are we flowing here? Does that make sense? Let me know if that makes sense, everyone. Yes, yes. Good, good, good. Perfect. Let's continue. Good, good, perfect. We understand this. This makes perfect sense. This is the dynamics of H-gap. Understand the dynamics of H-gap. Important mnemonic, definitely. If your carbonic anhydrase is not working here, we have renal tubular acidosis type 2. Renal tubular acidosis type 2 is caused because you have an issue with your PCT. You start to pee off bicarb. You start to waste that bicarb into the urine. That definitely happens with RTA type 2. RTA type 4. What is the problem with RTA type 4? Does anybody remember? Fanconi, you just have anything that causes destruction of the PCT completely. And if the H is affected from the H gap, RTA type 2. End of conversation. Anything that damages H from being, so acetosolamide. If I start to have acetosolamide intoxication, guess what? RTA type 2. Aldosterone. Yes, the insensitivity of aldosterone. Old diabetic patients, a man who's 64 years old, who's having acidosis, who's having a non-anion gap acidosis. At this point, I should say right away, I should be thinking this is RTA type 4. Diabetic older man, non-anion gap acidosis, metabolic acidosis. This is type 4. Okay? I should definitely think that I should have my bias activated to the maximum. All right, now going back, we were mentioning right before this, the aspirin intoxication. We talked about the different mechanism of acidosis. We talked about all these different mechanisms that can happen. That's basically super important. So we have driven that idea completely into this. For those wondering, type 3 is a mix of 1 and 2, I think. What I do is I haven't really seen type 3 in any type of question ever, so I just left that alone. I just tend to leave that completely alone. I mean, I'm not sure. Now I am curious, so we'll look it up. But definitely, I left that alone just because I didn't see the appearance of it. But that's a good question there. That's a good, good one, Florina. By the way, you're not, right? Good. All right. Let's continue. So, okay, going back into the aspirin. Where in the world is the aspirin? I don't even. Okay, there you go. So yes, acidosis is now occurring. Now we are having something called mixed. So we have normal pH and mixed because it's a combination of both respiratory alkalosis, because yes, your respiratory system is increased. You do have an increase in respiration that is occurring. Yes, so it says, okay, so hold on. Calcium builds up. That causes the stones in acetosolamide. Well, Mona, let me explain to you what happens here. It's actually the pH, because if you have an intensified increase in pH, remember we have different types of stone formations with different type of pH. So the pH here favors these type of calcium stones. It does precipitate. You have higher levels of precipitation that goes on. And then you have formation of these type of stones. Alkalosis in the lumen. Yes, of the tubules. That's what causes all this type of precipitation for calcium. Remember that calcium loves to bind things. That's another mechanism that I also did not include because it's so easy, so I didn't add it. But I should mention this: albumin. Remember that albumin is the most abundant type of protein in our body. Albumin is found everywhere. Albumin tends to grab onto calcium. It grabs all the calcium that it finds. It loves to grab calcium. It's grabbing calcium at all times. Calcium being grabbed, being felt up on, grabbed. And what ends up happening is that when you have a higher level of hydrogen, you start to release the hold. You now start to release the hold, and now you start to grab up hydrogen. So you're exchanging here. You're causing an exchange of albumin. You are dissociating the calcium. And what ends up happening is that now you have a slight type of hypercalcemia, and it starts to manifest itself in that sense. So that's what you have there for that. Okay. So that's also manifesting itself there. Calcium has that major hold. It has that plus. So it tends to bind to things normally. Remember that. Remember the calcium oxalate stones as well. The mechanism of calcium oxalate stones. Remember that calcium tends to bind oxalate at the level of the GI tract. In the lumen of the GI tract, these two things are binding and getting excreted. That's what's normally happening. But when you have malabsorption, when you have problems, when your stools are very fatty, calcium, instead of binding the oxalate, will start to bind the fat. Remember, calcium loves binding fats. Remember the process of saponification when you have damage of the pancreas. a lot of calcium can go and bind to it, it causes saponification. So saponification can occur. But here we're looking at just the idea of these fatty stools that never have gotten broken down. So then calcium then will start to bind to it. So what ends up happening is that oxalate is now free. And this free oxalate tends to get reabsorbed. But it's no issue. It gets reabsorbed to the bloodstream. Once it's in the bloodstream, you start to try to excrete it through the kidneys. You want to urinate this away. So it enters through the tubules without any problem. And who does it meet? Who does it meet in the lumen? Who does it meet in the lumen? It meets its old friend calcium that was supposed to bind it from the beginning. So now at the level of the tubules, you'll have high levels of precipitation of calcium with oxalate, leading to oxalate stones. Guys, remember that? Yes, they solidify. They solidify. Yes, yes. Definitely, definitely. Perfect. Perfect. So, okay, just to finish up with this idea of aspirin, because we do have to get into questions. We have to do more questions. We only did like 3 or 4 questions. So the idea of aspirin, what ends up happening here? Aspirin, yes, you have a mixed. You have the mixed type of acidosis and alkalosis. It will be mixed. It will be mixed. So whenever it is mixed, what ends up happening is that your pH is normal, respiratory alkalosis, but you do have metabolic acidosis, and this will manifest itself. So will manifest itself with a decrease in bicarb. Your bicarb starts to decrease. Your bicarb gets lower. So now this is causing a mixed panel. It has a mixed. Now the next thing that we should take into consideration. So respiratory rate. How is the respiratory rate with this patient? Who can tell me? How is the respiratory rate? It's high. How is the PCO2? Low. How is the bicarb? Low. Mixed metabolic acidosis with respiratory alkalosis. Then we have here the last phase, the final phase, respiratory failure. This is a phase of death. This is the death phase. Here's where you die. Well, not you, the patient, let's say, who has done this overdose. This is where they end up dying. Why do they end up dying? Because now their system, that whole system, the pontine medullary respiratory center, it starts to now decrease in activity. What makes this decrease? Well, you do have the buildup of GABA. GABA starts to build up. Yes, it does. So GABA, remember, was that activity. So how did this all start? This all started with the action of, you mentioned barbiturates and somebody mentioned aspirin. So I thought of that combination. But yes, you do have this problem where now you have increase in GABA. So the increase in GABA leads to a hyperpolarized neurological activity. So now you have problems with the communication of neuron to neuron. Remember, yes, it becomes more and more inhibitory to this point. A lot of inhibition will start to happen. So when it gets more and more inhibitory, you then start to see this action. So let's remember one thing. This stimulus is managed by action potentials. Through this all, the autonomic system of respiration is managed through action potential. That's what ends up happening at the end of it all. You're seeing this? This is the pneumatic sensor. You're seeing how this operates. So what we end up seeing here at this point, you have this type of action potential going on. But now with GABA, it starts to have more hyperpolarization. Hyperpolarization, which makes this a lot more difficult to depolarize. So then your respiratory rate starts to decrease. As it decreases, then your pH gets extremely low. As your pH gets extremely low, the patient then ends up dying, right? This acidotic problem will occur, right? Respiration failure, then leading to death. Okay, that is aspirin toxicity. We now understand that to the perfection. So let's do the next question. Let's get this one down. Let's make sure that we know this. This next question will be acid both ways at the end. Yes, at the end, acid wins in that sense. It does win. So yes, this is the typical problems that are happening at this point. Resting memory potential are a lot different. When it comes to neuromuscular junction, our resting memory potential is a lot different. So many people might think that the respiratory failure happens because of communication between the neurons and the actual muscle tissue, but that's not the case there. The case is that you stop to stimulate your GABA, your actual neurological stimulus, right? That makes sense. Remember this, guys, this idea of depolarization. This is at negative 90 normally, but then of course your nicotinic type of receptors can stimulate this and reach threshold at negative 55. Remember that. So yes, and motor end plate potential. We mentioned that. No, motor end plate potential is the idea of it being negative 90 going to negative 55. That direction there. That's the end plate potential. Hopefully you guys can remember that. Remember that. Okay? That makes sense. Perfect. 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 Okay, let's continue. Let's continue. Next question. We will see it here on this MBME. So this MBME is pretty good. I would say it's pretty good, but a lot of these questions are kind of easy. Do you guys agree? Am I the only one seeing them as kind of easy? Do I see these questions as kind of easy? No? You agree then? So what does no mean? That you don't agree with me, or are you saying that you agree in that sense? Oh, you're saying they're not easy. Okay. So I think the way that they're asking it probably is a little weird. I would agree there. I will agree at that point. The way that they're asking the questions are a little weird. But overall, I don't think it's that crazy. So let's take a look at that. So that was the MBME. If I look at, what do you guys think is easier, MBMEs or free 120s? Old good step one. For example, let me show you this question right here. Typically speaking, so yeah, let me show you this. This question right here. It's easier than MBME. Yeah, I agree. I have to be honest. Old step ones. Step one was not a difficult exam. I just think that the materials were very limited back then. So it was very hard. It's very hard in that sense to take these exams and when your materials is extremely limited. What do you think the answer is here? Let's see. The beneficial effect of this drug is most likely due to the activation of which of the following? 27-year-old man is administered to the hospital 45 minutes after being involved in a motor vehicle collision. Physical examination shows sluggish response to stimuli. Neurological exam shows no other abnormalities. A skull x-ray shows linear, non-pressed basal skull fracture. 2 weeks later, the patient develops polyuria polydipsia. Laboratory studies show a serum glucose concentration within the normal reference range, increased serum osmolarity, and decrease in urine osmolarity. Which of the following administration? Following the administration of desmopressin, the urine osmolarity increases. So the beneficial effect of this drug is most likely due to the activation of which of the following? You see, second messenger system coming back at you. Second messenger system coming right back at you. I'm telling you guys, this is high yield. This is something that you guys need to understand and know. Definitely. So, okay, somebody is saying ADH functions from adenylate cyclase. Does everybody agree here? Are we all agreeing? I know that it's like, I don't know why, but it's like something makes us want to think something else. But yeah, the answer is A. The answer is A. We all agree the answer is A. That's the second messenger system that operates here. Okay, that is the second messenger system that will operate in these type of effects. Now, this jack right here and serine kinases, let's be very clear. What they did here is kind of dirty in that sense. Calcium channel is not, and serine kinases sounds like a distractor. Well, serine kinases has to do with insulin. The activation of serine kinases are linked to insulin reaction. So when we were looking at all of this type of activity of insulin, it does have to do with serine kinases in order to activate those type of proteins. Janice and Tyrosine did not see ADH in the respective list. A, the only one left. But yeah, A is part of that whole mnemonic stuff. When we're talking about flat champ, it's one of the A's. You have those two A's, flat champ or flat camp. HCG was a mnemonic. One A was ACTH, the other A was ADH. It was V1 and V2. If you can't remember the actual hormone, you could remember the receptor. The receptor, remember you have V1 and V2. So definitely this is a V1 problem, V1 activation. Remember what cell, a better question would be, guys, can you answer me this? What cell is ADH actually functioning? Where does it function? What cell? Who remembers? Who remembers? What cell? Close guess. Pablo, that's a really close one. Really close one. Because both of these cells are in the collecting tubules. They are. Principal. Yeah, the principal cell, definitely. Miriam, definitely it is the principal cell. Remember, you have the aquaporin channels. You have the aquaporin channels that get stimulated there. Right? That makes perfect sense. Here, you're going to have more reabsorption of H2O. Right? And what is the primary stimulator of ADH? Who remembers? Osmolarity is correct. Osmolarity is correct. Good. Osmolarity is correct. Definitely. Primary stimulator of aldosterone. Let's see if we remember. Yeah, I would say decrease in perfusion, which can happen because of hypovolemia. I can say that, definitely. Low BP, yeah, with low BP, you'll have decrease in perfusion in that sense. Decreased perfusion is the better answer. Decrease in perfusion can also happen when you have proper volume, let's say, but you have too much constriction. When you have a overconstrictive vessel where you have lack of perfusion, lack of renal blood flow is going to cause that. Remember, the kidneys want 20 to 25% of your cardiac output. If you're unable to give that, then it'll cause these kind of problems. Does that make sense, everyone? So remember that serine type of kinase activity, that is linked to insulin. Whenever insulin is trying to make all these, when insulin is trying to make, I remember this protein synthesis, it tends to use serine. And now this is weird, but amino acid serine is implicated in a lot of conformational change of proteins. So just giving you a little tidbit of information here. I'm going to tell you something. There's proteins that change their structure in order to function differently. I tend to see that serine as an amino. So what in the world just happened? Let me see. Yeah, what happened? I have no idea either. I don't know what happened. You Man, I was trying to break a record here. I'm trying to go, but it's still recording. It is. But what happened? Yeah, what in the world was that? That was super weird. I have never seen anything like that ever happen. That was weird. It just basically turned everything off. Am I still sharing the screen? I'm not, right? I'm not. Okay. That was weird. Yeah, I never ever had gone this long. So I'm trying to break a record. I am. Yeah, I never tried a marathon like this. I am going to do more marathons down the line in the future, and this is going to be basically all based on the idea of someone. You know what I actually thought? I'm not going to lie. This is what I actually thought that happened. I actually thought that somehow somebody has just hijacked or ended up like, let's say, how do I say, like somebody hacked the system, and I'm just like, oh man, what am I about to see? What the hell is gonna happen? Like, Somebody's just going to like open up a screen or something. I'm just like, oh man, this is bad. So I didn't know what to expect. I was just like, oh no. Yeah, definitely. Oh man. Anonymous just shows up giving me an encrypted type of message. Like all these questions that I'm taking are ripped from free 120s, not paying for my subscription. Oh man, copyright infringement. Yeah. That was wild. That was wild. Yes, the ECFMG is like, what is going on, you guys? We're highly suspicious activity is going on here. Too much activity. Yes, very suspicious. Something must be happening. Somebody must be cheating. This is making no sense. Yeah. This is wild. Yeah, this is wild. That has never happened to me before. But then again, I have never given this long of a class before. This is brand new to me. Yeah, yeah, that's good. That's good, Amna. You're not giving up. So, all right. I'll tell you what, let's do one more question just because I know everybody's tired and we're up to 7. We have 7 people here. We have 7 people here. 1, 2, 3, 4, 5, 6, 7. I remember not too long ago we were at 10. So yes, I mean, I could continue. I drank this cup of coffee and that gave me so much energy. To be honest, I have slept all morning. Yesterday, I was sleeping all morning. I really slept too many hours. So I don't have this lack of energy. I'm feeling this drive. Um, I would find this recipe. I'll tell you what the recipe is. It's that instead of waking up 8 in the morning, you wake up really fast, you eat something, and then you go back to sleep, and then you wake up like at 11, basically. That's the recipe. So it's basically that. I guess I was used to giving so many hours straight, so I still have that activity. Yes, anybody who has kids does not have that privilege. Yes, anyone who has kids do not have that luxury. Kids will definitely be an alarm clock that wakes you up. It will maintain your attention. It will take your energy. That's what I see. I My cousin has 2 kids. I live with my cousin, and he has 2 kids. He has a baby that's 1 year old, about to be 2, and then he has another kid who's about to go into kindergarten, 5 years old. So definitely, they're draining all the energy. Definitely draining all of his energy. I see that all the time. I've learned so much just from looking at him. I learned so much just from looking at them. It's crazy. Definitely, kids take all your attention away. So, wow, yeah, 5 years old, yeah, twins. That is crazy. I definitely, when I plan to have kids, definitely it has to be with a person who you trust, who has great habits, somebody who would actually have your back 100% and take care of your kids, and you would also help them and take care of them and do all that. You have to have that proper type of relationship. That's something that I've learned. You can't have these well, you can do whatever you want, but it's not beneficial. Yes, not a physician is a very good point, right? Because they are having basically their priority. I don't know how to say that. It's like, is their priority really their family in that sense? If they're putting like about 60 hours a week into their work, is it? Yeah, it's going to be a problem in that sense. I would like to be rich first, at least one problem less. Yeah, definitely. Yeah, we are torn apart, definitely. I would also love to be rich, man. I would love that to happen. I just know one thing. I'm following what I love to do, and I'm just continuously doing it over and over and over again for a long period of time to see what happens. I'm following it. I'm just going with it. Anything new that appears, I take it. So I'm following what I love to do. So I'm able to do this for longer periods of time than the other person who is not following what they love to do, for example. So yeah, yeah, I'm following what I love. So I can literally sit down and and you'll be amazed. There's times where I sit down, learn about something new, and I'm doing this on my free time. I don't watch Netflix. I don't really have much of a hobby or life. So I just basically study all the time and give class. That's how life is for now. So, yes, definitely. So I want to show you guys another type of question right here. Yeah, yeah, you could definitely believe me. You see, and something that keeps you curious. Yes. I don't know. I like to. I guess I like to tell stories. I'm the type of person who loves to talk a lot. I don't know if you guys noticed that. Everybody always says, "Damn, yo, this guy is always talking." So I love to talk a lot. So if I find something that is worth talking about, yeah, that's my weakness. Anybody starts to ask me about medicine, so around me, I don't have anybody who studies medicine. Yeah, I just start talking. I guess I start talking politics, everything. I just get into it. They're just like, "Oh my god, this guy talk." So definitely, um, yeah. So that's why the way I see is that this is lined up perfectly for me. This job is just basically me talking and me talking about something that I love, and then me organizing it properly. That's the whole idea behind it. So take a look at this, guys. Let's take a look at this question. This is a very good question here. This one is very good because again, it starts to talk about the activity. I think you guys will get this with no problem. This here, um, I would say it does have a level of difficulty, but I think you guys understand this already. I think at this point, you guys dominate this. So let's understand this. Can anybody tell me what the answer is on this one? I will show you the answer choices. And sorry for moving the screen. And let's see. So I did this question before. I did this question before. So I'm looking at it. What do you guys think? So we have one that says GTP works by using GTP. We're talking about here the mutation in KRAS gene that results in constitutive activation of the RAS protein. Under normal circumstances, this protein is only active when bound to which of the following substances? Who remembers this? D. Good. GTP, GTP and GDP. So it doesn't go down. It doesn't go down to the GMP. It'll go down to GDP. So yes, remember that. Definitely, definitely. This makes sense. This makes sense. And this is the whole idea of the MAP kinase pathway. Remember the MAP kinase pathway is stimulated by growth factors, right? You guys remember that? Here you're having this type of binding, this type of interaction. Good, good, good. You guys remember all that. That's perfect. Yeah, you guys are good in this sense. This makes sense. Okay. Let's see. Another question here. And this is rather easy. This also had to do with more things that we talked about today. We did talk about a lot of things. So let's take a look at this one. We're almost done, guys. We're almost done. We're finishing it off. We're almost done. This one here. Yeah, let me fix the answer choices. That way, you know which one is the answer. But looking at this one, this question here, it's asking you specifically which of the following processes most immediately precedes the observed increase in enzyme activity. So yes, I wonder who will get this right. Let's see. Researchers studying cell cycle observes a sudden increase in the activity of several enzymes, including dihydrofolate reductase and DNA polymerase. So they're saying most immediately precedes the observed increase in which kind of enzyme activity? Who knows? Who knows? Somebody says E. What else? That's E. You have two E's. Yeah. Yeah. Definitely. Definitely. I will agree with you guys. You guys are 100% right. This makes perfect sense, right? You seeing why. They mentioned the idea of de novo synthesis. Yeah. Retinoblastoma unleashes E2F. E2F. Do not confuse this with elongation factor. Do not confuse this with elongation factor. This is E2F. E2F is bonded to RB. But when you phosphorylate RB, it then starts to get released. So what causes the phosphorylation? It is the combination of CDK and cyclin. Cyclin, usually it's cyclin E that you have. This here combines together and then phosphorylates this. What inhibits the cyclin and CDK uniting? What inhibits this? P21. Wow, perfect. What stimulates P21? What stimulates P21? P53. Perfect. Perfect. Yeah, you guys are good. You guys are pretty good. You guys know this. It's awesome. That is awesome. That makes a lot of sense, though, right? It does make a lot of sense. All right. That's good. That's good. Let's see what else. So here's another question. Rats subjected to chronic inhalation of exposure of formaldehyde developed nasal squamous cell carcinoma. Decreased activity of which of the following genes is most likely found on the cytogenic studies of these tumor cells? What do you guys think? Just without looking at the answer. They're developing a squamous type of carcinoma. And then they're asking decreased activity of which of the following genes is most likely to be found on the cytogenic studies of the cell tumors. Tumor suppressors. Tumor suppressors. I agree with you here. So what is a tumor suppressor? Which tumor suppressor can we name? Like, let's say like the most obvious type of tumor suppressor. Okay, somebody says here RB. Someone says here BCL2. P53. Blarina, I like that answer the best. And you know why I'll tell you I like it the best? Because what stimulates, for example, I'll tell you this. What will make sure, so for example, yeah, P53 is involved with the action of RB. P53 is involved with the action of BCL2. So it's like, yeah, like you're going backwards, right? This one here is involved with all this. So I do see a connection here. Try to remember in HPV. Remember patients who have HPV, they can have a E6 problem and an E7. E6 and E7. E6 is related with the attack on P53, while E7 is related with the attack on RB. Okay, that's HPV. This is the HPV that is prone to cause cervical cancer. You guys remember that? Cervical cancer is caused by this. Okay, that makes sense, right? So HPV can go wild. HPV starts to cause these kind of problems. Yes, they're related to these both. So yeah, the answer here is P53, definitely. And you guys would have gotten it right because all the other answer choices were actually like oncogenes, activators of these kind of issues. So all that made sense. Definitely. You guys are pretty good when it comes to these type of questions. You guys are getting them 100%. That all makes sense. That's perfect. So if we're looking at questions that have to do with HPV, there's classic MBME type of questions. Let me show you, for example, classic MBME kind of question. This is seen on MBME. This is a MBME 26, older MBME. A 2-month-old boy is brought to the physician because of a 7-day history of hoarseness. His mother has AIDS and used cocaine throughout her pregnancy. Physical examination shows no abnormalities. fiber optic laryngoscopic examination shows a nodule on the left vocal cord. Which of the following viruses is most likely the cause of this nodule? Yes, it is HPV. Do you guys remember why exactly? You guys remember why exactly? Why is HPV linked to these type of cancers? True vocal cords. True, yes. The mechanism, yes, it has to do with tumor suppressors, but the specific type of tissue, these are tissues that are expressing epithelial cells, right? Epithelial cells. These are specifically these type of cells that you'll find, well, the same kind of histological appearance that you'll find in the cervical area, right? That makes sense. So the oral pharynx, these type of area have this appearance, right? That makes sense. Squamous. Squamous. So anything that is abrasive, remember anything that can take some kind of abrasive damage, these type of things are squamous. Does that make sense? And anything that is managing higher levels of acid or a change in pH, these things are more like columnar. Okay? Keep that into your mind as well. That makes a lot of sense. Okay, that's good. That's good. So yeah, there's many different types of questions that are involved with all these different types of cancers, especially these MBME questions. They have some really good ones. Let's look at a question. A bit new. It's a bit new in this. Oh no, it's not that new. Actually, let me not involve that question because that has to do with virology. It had to do with diarrhea. I don't know if you guys remember, but I'll give you guys a little hint here. Remember that there's diarrhea caused by virus infections, and usually it's RAN. Rotavirus, adenovirus, and norovirus, part of the Norwalk family. Norovirus, that's RAN. That's ran, like diarrhea, like it ran through the patient's pants. Ran. Now I'm going to mention a bloody type of diarrhea that's caused by a viral type of infection. Can anybody tell me, first of all? I would be impressed. Yes, good. Cytomegalovirus. Definitely. When the T cells go lower than 50, remember that, guys. CMV can cause perch, pneumonitis, esophagitis, retinitis, colitis, and hepatitis. So this colitis can get really ugly and it starts to cause a bloody type of diarrhea. That's cytomegalovirus. Does that make sense? Does that make sense? Perfect. Good, good, good. Yeah, you guys are pretty good. You guys are pretty good. I'm curious to know like what's everybody's like MBME scores, like more or less like what kind of scores are you guys getting, because you're really answering questions at a higher level. I have to find questions that are a lot more trickier in that sense, because a lot of these type of questions definitely, Amboss to me is the one that I see that's lately been stepping it up. Amboss is stepping it up. Amboss is trying to get a lot of people confused in all their questions. But nevertheless, let's look at a MBME question right here. This is a MBME 25 old school type of question here. Yeah, yeah. UWorld, I'm seeing a lot of easy questions. That just might be me, but I'm seeing it. And boss, when you start doing them, they have some questions that are really deep. Like they really make you think. So let's take a look at this, and let's try to look at the answer choices as well. So let me add the answer choices, and let's see who can get this one. I will stay silent. Let's see who can get this one. You can type in your answer. It is one of these, definitely. What do you guys think the answer is here? Take into consideration the patient's chromosomes, karyotype in the cultured Amniotic fluid. Cells, of course. Yeah. A newborn was delivered with normal male external genitalia, testes, and genital ducts. Which of the following is the most likely explanation? Who knows the answer here? Who knows? Somebody says androgenital syndrome. Any other answers here? I see everybody's quiet. I definitely had to start picking from this MBME pool. MBME 30 was kind of easy. We were doing MBME 30 questions before. Now we're doing old school kind of questions. Somebody says E. Okay. Somebody says maybe A. There is only one left. I would agree with Pablo, says Mona. None of the others really fit. Okay. Definitely. This is good. This is good. Okay. So let's take a look. So, interesting question. Yes, it is. Very interesting here. So let's understand what's going on here. We have basically a female, right? 46XX karyotype. This female here, she says, yeah, they actually got this from the amniotic fluid cells. So this is accurate. This is accurate. This is an invasive type of process where you can actually you can actually remove a part of the amniotic fluid. You can actually aspirate this and then check this out and then learn the actual material of it, like specifically what it has. This will give you 100% like a diagnosis if it's some kind of trisomy. Blurriness says D. A chorionic up to 10 to 13 weeks. Yeah, you don't want to do this later on because there's a higher risk. It is highly invasive. That's the problem there. Okay, but anyways, getting back to this, let's take a look at this. We have here XX, but we have external genitalia of the male system. That was seed. And we said seed gets produced with testosterone. So you have to have testosterone to produce this. This is the Wolferian duct type of differentiation. Then, of course, you have proper testes. And it says genital ducts. That doesn't really help me because genital ducts are part of. Okay, they said external genitalia. Okay, so now I'm seeing that you have. Okay, so hold on. I was taking into consideration the internal type of genitalia. This is internal. This says external. So external will relate to DHT. DHT. So we're having external, internal, everything. Which of the following is most likely the explanation? All right. Marianne says B, androgen insensitivity syndrome. Okay, let's see something. In androgen insensitivity syndrome, there is something that happens here. Yeah, it can't be. Why? Because this 100% always all the time androgen insensitivity syndrome, always all the time. They have female genotype, yes, but they are phenotypically female. They have male genotype, but they are phenotypically expressing XY. XY. And their Mullerian duct was actually properly inhibited. So they have that blind pouch. We can eliminate this. Let's get this one out the system. Okay. Now, adrenogenital syndrome. This is just a fancy word for CAH, congenital adrenal hyperplasia. Just a fancy word for that. It's the same thing. It's caused by congenital type of enzyme here, right? You have that 11, 17, 21, all these type of problems. It says here, SRY are the hermaphrodite kind of. So this is not CAH, right? You definitely know that this is not CAH. CAH has that type of ambiguous type of genitalia in the females because you have that increase, right? So this is not the situation here. Fragile X. Fragile X. Who remembers the appearance of Fragile X? What do they actually have? It is a trinucleotide repeat of FMR1 gene, the mental retardation 1 gene. And this results in DNA methylation. So if you have DNA methylation, was that an increase or decrease of expression? Who remembers? Decreased expression is correct. And is characterized by macro orchidism, right? Like there's a increase in the size, let's say. But don't get this confused. Macro. Don't get this confused with some type of disorder that is causing some kind of, let's say, irregularity when it comes to this these sex hormones and all this, right? They just have a mental retardation gene that has a problem and resulting in all these other types of intellectual disabilities, all these problems. Yeah, they typically look normal when they're born. That macro testicular problem that happens during puberty. Okay, we can get this one out the list. Now we have maternal exposure to oral progesterone, or ESRY. So this idea of progesterone, right? This idea of this is very interesting here. I can tell you. So it says here, but they would be normal when they are born. It was D, then the mom would have the effects.
I mean, like the mom would have like hirsutism and all those like excess androgen effects, right? If it was
Well,
like
progesterone.
if the fetus was exposing the mom to the androgens, like then the mom would be the one that would be affected.
I agree
Am I
with
confusing something?
I agree with you if we're talking about the idea of some kind of androgen, but progesterone itself, it's a type of like a progesterone type of drug, right? It's not like an androgen. Like progesterone is basically, remember that's the thing that we were discussing before. Well, we were discussing the idea of progesterone being produced by the corpus luteum. Remember, then the placenta takes over. It doesn't really have to do with the, yeah, it doesn't have that androgenic type of effect. Definitely not. So progesterone is just something that is related to um, promoting the uterine wall. Remember that? In the corpus luteum. But yeah, I do see if you're mentioning something that's androgenic, then I will agree with you. Let's say the female is on testosterone. Let's say she's competing for a weightlifting competition and she has no idea that she's pregnant. You would have ambiguous type of genitalia if she's female, right? But you would not have full-blown growth. Also prevents premature in short-length cervix. So let's be very clear here. So I'll give you guys a hint as well, just to throw this in there. Whenever you see something that doesn't make any sense, at all, like this here is not making any sense. The idea that she's XX, yes, she has fully developed male genitalia, both internal and external. Whenever you see a question like this, and remember this, keep this in your memory so it can last forever. This is why I lasted so long. I was meticulously going through the answer choices. I'll tell you why. Whenever none of this makes sense, the answer is always something that has to do with SRY gene, something that has to do with the testes, something that has to do with the formation of your gonadal system. Whenever it makes no sense, this is what the answer will be. So the SRY gene basically is located, of course, on the Y chromosome. It's not related to the X, right? This is what produces the testes differentiating factor. But let's look at it like this. If you can have, let's say, a translocation. So remember when, let's say you have the X gene, you're not supposed to express this or anything like this on the X, but there's a process called recombination. So during the process of recombination, you'll see that the SRY gene can become part of the X chromosome. This is super rare. This is super rare. But during the process of, so let's see, it says here, my very first gut feeling was correct. Yes. Yeah.
Doctor, can you, the recombination has been something we've seen in questions, in MBME questions. It's really tricky. If you can just really quickly just give us a hint how
Okay.
to go through these questions.
Definitely, definitely. So there is a process. There's this special process that whenever we have the idea of gene translocation, so we have to think gene translocation. When you're having this idea of gene expression, so I do remember when chromosomes are able to align, you're able to represent what part of the chromosome will be expressed and the other part is muted. You remember this happens with, you make bar bodies in females when you have XX. So this is a weird abnormality here. In this one here, during the process of recombination, SRY gene gets translocated from Y, it goes onto the X chromosome. So you have someone who has having an XX type of individual. They are an XX, but they have presence of this gene on the X chromosome. So we have to understand exactly the process of gene translocation. Gene translocation. Let's see if I can find you a nice little image. Remember, when these chromosomes align, they're able to interchange certain type of expression, and you want to have the dominant expression to be labeled, right? You want this actual labeling of the dominant expression. But here you're having this sneaky type of Y. So the sex determining region, Y. It's located all on the Y. So in recombination, this is an abnormality. This should not happen normally. You get this transferred. So the X, let's be very clear. Yeah, I think I could show you guys an image actually. Let me just try to show you an image. Remember when we were talking about the genes going towards their different sides? We were talking about, I think this was seen on Robertsonium when we were talking about the genes expressing themselves X and Y, right? You guys remember that, the pairs of genes that get chosen? There's going to be a process where they can interchange activity. So they have recombination, the idea of, let's say, chromosomes interchanging. Yeah, let me try to show you an image. I think that would make more sense here. Let's see. I think I have something here. This will be, yeah, recombination here. You have to understand recombination. Recombination is all about the process. So cell division. They have this on UL. They have that image. So let me just show you guys. They have the example with viruses. Not with viruses. We want to see it like this. Okay, this is perfect. Gene linkage equilibrium, gamete possibilities. This is linkage equilibrium. This is different. Yeah, let me not confuse you with that. This is actually translocation process. Let me show you too like this. Hold on, let's repair, recognition, ligation. No. This is different. Hold on 1 second. Where's this image? Linkage equilibrium. Oh yeah, hold on. Second, this is the idea of recombination. Yeah, I have to show you guys an image. That's the best way to explain it. Homologous recombination. No, that's DNA repair in that sense. Show you guys recombination. Yeah, I'm not finding some good images. They have awesome images for the viral type of recombination. They're not really showing recombination at this point. So let me just put it like this. Let me just explain it. I think so. Recombination. Okay. The internet does have actually, like Google, let's say. Yes. Perfect. So in the idea of recombination, we have to understand, yes, this is when you're making combinations of alleles. This is when you are expressing your alleles. This is what typically tends to happen when you're having your reassortment. You're actually able to express the information from chromosome to chromosome to pick which one will be expressed in this sense. So homologous type of chromosomes, you're seeing here the distribution. Yeah, let me show you this. So you're seeing, when we look at this example here, how you're seeing how they are able to express themselves. You're having this type of genomic activity, but you're seeing that there's going to be crossover region causing recombination. The recombination has to do with this, taking the expression, taking the actual information from one chromosome and expressing it towards the other one, right? So it says here also prevents premature in short length. Okay, hold on, that's before. Okay. But the idea of recombination, whenever you align your chromosomes, you'll have to have interchangeable relationship, let's say, between expressed alleles. So they're showing you a crossover region, basically the information that's going on is being passed on. Now, Y should not be having recombination with X. These aren't things that should normally be happening. These are sex type of chromosomes that could determine the gender, basically the sex of the fetus. You're not supposed to have that manifestation going on. So the recombination that you see with these kind of gametes, you're going to see that it's a very, very low frequency between Y and X. This is super pathological. It's not normal at all, where you should have the expression of one type of Y expressed on that. That should never happen. So that's what's happening in these kind of sense. Oh yeah, let me explain it a lot better. I'll tell you one thing. When you have chromosomal type of breakage during this process in cell division, let's say, chromosomes are condensed. You do remember that they do get condensed. And what ends up happening here is that you are going to have your DNA replicating. So hold on. The whole process here about this, when we talk about recombination, I'm going to put it to you the easiest way I can. Easy way I could put it to you is this. There's going to be segments on chromosomes. Segments. And remember the point where we were talking about repair. We were talking about the idea of segments that basically, when you have this, it says homologous chromosomes, whenever you have repair, I do remember. So the interchangeability of information through chromosomes can happen through the process of recombination. This does happen mainly during repair. During repair, you're going to have some kind of segments that should not be located in a chromosome. If they can homologous joining ends up happening in this sense. I remember they explained this on Amboss. They had that image. This is part of a DNA type of repair that you can have, either non-homologous or homologous. I remember we were talking about this before, actually, when we were talking about molecular biology. There was one that has this type of breakage. Remember when you have actual breakage of the structure, you have linking of the structure again. You guys remember that? A structure that was completely erased, but then it starts to join up like this, right? You guys remember that type of homologous type of joining. There's the non-homologous and the homologous. What we're talking about here is the rejoining, the formation of abnormal chromosomes that are basically happening here. This happens when a broken segment of the chromosome rejoins another segment. So all I'm saying here is that this recombination process, this interchangeable activity of chromosome expression, it can happen when you have breakage of your chromosomes. They are tending to try to link up, and they link up with some kind of chromosome segment that shouldn't really be present, but it is. So they take the genes from that chromosome. And if you have the bad luck of having that particular cell, let's say, undergo fertilization, undergo um, the embryological development, and they actually end up expressing that small segment that was stolen from a Y, then you'll end up having this type of dysgenesis issue where your chromosomes are XX, but the X that it has is that piece of the Y that was stolen. So this piece of Y that was taken, you'll see it like this. It will express like this. And out of all the segments of that Y, it just so happened that the segment that was clipped in was the segment that represents SRY gene. So when you had your development of this X, let's say, what ended up happening was that you had a breakage. And in this breakage, you were susceptible to pick up pieces in order to have attachment. So you just so happened to pick up a piece of a Y chromosome. And what specific type of piece did you pick up? The piece that has SRY gene. That's the idea of recombination. It has to be, it's so random, so rare in that sense, that out of all features that were picked up, that were actually used in this sense for recombination, you had to have the misfortune that it had to be specifically this strand. Okay. Now, this process here, this actual, so let's see. Here it says also must the X. So okay, let's look. Fixes it the best way it can. Also must the X that does not become bar body. A lot of coincidence, I think. Yes, you are right, because think about it. They are going to also only try to express the feature of one of the dominant type of X's, right? Because the dominant feature will get expressed. But here you're seeing that this feature doesn't have something to mute it. You don't have the mutation of this feature, because what are you going to align with it? You see what I'm trying to say? I am curious to know what segment, like what part of the X exactly. Yeah, it's like usually you'll have like muting of one. So this one here is like, usually when they mute, this is what happens. You have a process called lionization. Lionization. You line them up, and let's say you have a specific feature here. You will mute one of the features, and then the other one will have higher expression. So that's what ends up happening there when you line them up. But yeah, I am curious here, because if you line up one that has SRY gene, what are you comparing that with? Yeah, what's the counterpart? Definitely good. That's what I'm saying here. It fixes it the best way that it can. And this gene translocation is what happens here. So you have broken segments of chromosome. Remember that chromosome is just a packed up, stored nucleosome. Remember that nucleosomes are packed up and stored DNA material, right? You guys remember that? Chromosome, nucleosome, DNA helix, if we're going in order. All I'm telling you is that if the chromosome breaks apart at a certain region, it's able to patch this up by picking up something that's complementary to this region and then forming itself back up again. That's the problem here. This is what's called the homologous type of translocation. Now, this can happen with different things. Let's be clear. Robertsonian type of problem has the same issue. So hetero or homo, depending on the DNA really, to be manipulated or not. Yes, definitely. And to be clear, this is the same mechanism of Robertsonian type of translocation. Okay. This here involves fusion of chromosomes with very short P arms. That's what the problem is here with ribosonium. You have a translocation happening at this sense, where these chromosomes end up coming together, let's say, and you lose the short arms. This is what causes Down syndrome. Down syndrome. Robertsonium. Okay. That, yeah. Yeah, that's one of the mechanism basically involved in Down syndrome. You could also just have a problem with remember when we were talking about the issue of putting your, let's say, genetic material during the meiosis process while they're dividing. You have to be able to have your material spread out properly. This was Remember, we were talking about monosomy, uh, disonomy, trisonomy, when you're actually having, let's say, two, which you shouldn't have. Let's say you should only have one. Instead of having this properly done, you're having this, right? You're dividing it in this way, but the expression is showing that more, yes, distribution is now manipulated. Perfect. Gene translocation. This is kind of complex because you are getting this segment of a chromosome that you're not supposed to get. That's what's actually happening. You're getting this segment that you're not supposed to get. 21, 18, and 13 are the only trisomies compatible with life. It's true. That is true. Very interesting too. You think about it. So this is a deep kind of concept, but it's all about the idea of you picking up this type of material that you should not have picked up, this type of genetic material that will manifest itself with genes. And it just so happens that the gene that is being manifest is a gene of SRY. Does everybody understand that? Yes. And thank you, Pablo. Definitely. That does make sense. It does make sense. It is a little tricky though, because you're talking about like, how is that specific segment ripped apart in that sense? You have a breakage, you have damage of the chromosome. That's what's happening. And then not only that, but the damage, this chromosome has to also be viable. It has to have, you have to actually have a cell that's going to function. It has to be chosen as well. Let's say out of all the cells, it has to be this cell, right? That's what we have here. So this is these type of errors that you're having. There's actually studies that show that increased exposure to radiation can cause this type of issue with your chromosomes, with your sexual, let's say, developmental, like your, let's say, the sperm, the things that are basically going to carry these type of genetic materials. Does the inactivated X then become active? Well, what do you mean at that sense? The inactivated X, for example.
So in this question, he was phenotypically a male, but genotypically female. So like there's two X's. So does the one X that's inactivated, like the Y like goes in it, or?
So yeah, so let's explain this. So that is a good question, because what's happening here is that once you have one X, let's say you have one X, what does the X really do? What does the X really do in reality when it comes to the sexual development of a female? What is this X really doing? Think about it. What is the activity, specific activity that it has? Well, I'll tell you. It's not really doing anything in that sense. Think about it. It doesn't release some kind of factor. It doesn't release some kind of stimulus. It's not this proactive type of stimulation. Remember, to become a female, by default, the actual stimulus that you have, you'll have the gonadal differentiation, for example. If they differentiate with testes differentiating factor, then yes, they'll become testes. If not, you'll notice that the lack of testes differentiating factor will lead to the automatic differentiation of ovaries. So it's like one of them is quiet. Let's say the X is quiet when it comes to development, but the Y is loud. X cannot override Y, because what will X do? What is the sexual developmental feature of X? It really isn't, right? It really isn't. Once the gonadal expression of ovaries happens, then yes, you have release of estrogen. But is that really stimulated by X, or is that just stimulated by the gonadal function? Gonadal feedback of hormones, right? FSH, LH, that type of activity. Y wins by default. Y is super proactive. X doesn't really do anything. So if you have stimulus, let's say of the testes, it's so active that it'll turn off the features of this type of it'll turn them off. It'll turn off the features of Mullerian duct. That's what I mean to say. So that way you don't have the FUP, the fallopian tubes, uterus, or the proximal vagina. You will turn it off with your test. These testes are working properly. This is what they say that this Iranian fighter has. Don't know if you heard of that before. They have this person in the Olympics. There was a big controversy based on this Olympic type of boxer. They say that this boxer, but they have different conversations, and really there's no proof, there's no evidence, because this is medical records, and at a universal level, you're not going to have access to somebody's personal medical records unless they themselves put it up there. But the debate is very, yeah, the Algerian who has won gold medal. The actual debate that we have here is that people are saying, well, she is X, Y. And what the issue is that she has male developed gonads, but they did not develop properly per se. That's one discussion that people are having. She has XY chromosome. The other discussion is that, hey, she doesn't have XY chromosome, but she has this issue where she is developing male genitalia. She's developing testosterone. She is XX with a high level of testosterone. That's the two different types of debates. So somebody here says, hey, if she's XY, but she didn't develop testes, she didn't develop external male genitalia, she should still compete as a female. Because if you think about it, her development didn't work. If her development did not function, by default, she would be favoring female development. There's a lot of problems here. Will win all the battles with females. Yeah, there's a big problem here. That's the issue. You see, Paulo, that's what I'm saying. That's the issue. Because if it's XY, that the gonads didn't really function, then why is it that she is expressing phenotypic male characteristics? Why? That makes no sense. For example, why is she expressing male characteristics if she's an XY who couldn't express male characteristics? You understand what I'm trying to tell you? That there makes no sense. That's where their whole conversation ends up dying. The only thing that would make sense is that she has the condition here on the right, the translocation problem. That's the only condition here that would make sense. She's XX, but she has actual proper testes. She has penis development, everything developed as a male in that sense. This is the only conversation that would make sense. She is technically a female. She just took the one little gene that makes her a male, let's say. And with that gene, she is competing. Y infiltration, yes. That's the only thing there that would make sense. But then for that, they have to admit that she has male genitalia. And that's where there's issues. Yeah, yeah, that one gene. And here comes the problem. Here comes the issue, though. The problem is this. If for example, let's say this patient, so this does become a little difficult because think about it. She is XX, definitely. So yeah, this is hard because are these type of patients that have this, can they actually have viable sperm? You see, this is where it gets a little bit deeper. Can they actually have viable sperm? Because yes, they are making prostate. They are having all this type of activity. So they do have. But everything has to be perfect for a male to actually be able to impregnate a female. Everything has to be perfect in that sense. Right? You guys agree? Temperature down to the T. Like everything must be perfect. So, yeah. I'm curious. I'm not sure either. I don't know. I don't know if they can actually impregnate a woman, but this is here. This is definitely a big rabbit hole. This is something very deep. So yes. Um, yeah, this was a tough question. Definitely a tough question. And this had to do with this type of issue where you have stolen a piece of a Y, and that piece of a Y caused the problem. What would the inherited? What would cannot provide Y? What would the inherited anyway? What do you mean? What would the inherited?
Like if this person impregnates a woman, like he could even transfer any chromosomes or anything like that. Like,
That's true. Like hypothetically speaking, there has to be an X that he's going to give,
so, all right. I think
right? So which X would he give? Imagine he gives this X that has the Y. So then you're going to have to copy that X that has the Y. That's going to be the problem. Like they would have to copy this X that has a Y. Like so you can't provide the Y, but you're providing the X that stole the Y. So you see what I mean? This is where it gets super difficult. Like this is tough because yeah, we don't really know what exactly is the problem. So yeah, with the Algerian fighter, she's able to just not provide medical proof, which is a good idea. Don't provide anything medical. Keep it quiet. She wins her. Yeah, cannot provide. She can't. Well, she doesn't have to provide her medical documents at all. They let you fight with a passport. They said that's what they said according to them. You're able to fight with a passport. So if you demonstrate your passport, go in there and you can fight. So that is a very interesting kind of situation there. These women are fighting. She has filed a lawsuit for what? I wonder for defamation. For well, she won of gold medals. There was no actual, let's say, level of discrimination that did not permit her to compete. She competed. Oh, okay, I see. For people who were slandering her in that sense. Well, she's gonna have a problem because she is a public figure, so it's hard to to prove defamation on public figures in that sense. To tell that she is a man or trans. Yeah. Also, yes, that is another problem, Blurine. I didn't even think about that. The incited hate on social media. That's the thing in this country in America. For example, if that happened in America, hate speech, for example, we have freedom of speech. So you can actually, as long as he didn't threaten her, he's okay with it. He's okay. There's the only limits are like actual threats of harm. So definitely we have that First Amendment, which does protect freedom of speech for now. I understand, like in Australia, in Europe as well, they have problems where if they speak up against something or they actually insult or demonstrate some kind of hate or actual, like real hate, they said something like very bad to someone, they can actually have, they can be questioned by authorities or things like that. But not in America, not yet, not yet. We still have the idea of we're able to say really mean things, let's just say, and get away with it in that sense. Freedom of speech and defamation is hard to prove, very hard to prove on a public figure. Like you have to prove that there was actually, uh, yes. I don't know. I'm thinking about it. What should I do? I know it's crazy because this is such a long video, and I know there was so much talking, so much things I want to filter off, but I can't really like edit this as well, just because it will take me way too long. And also, I need better software for editing. I'm going to edit such a long video. Definitely. Yeah, I'll keep it as is. Should I just upload it on YouTube? Then I'll post it. I'm not sure. You guys tell me. What do you think I should do? Yeah, definitely this session. I feel a lot stronger myself from going through this session. Definitely. So, what do you guys think? How should I manage this? What should I do exactly? Marathon first edition. That's a good one. That is a good one. I like that. I like that. Marathon first edition. I know anybody who sees the time frame will just be like, what in the world is going on here? But definitely, I think this is a good idea. Then the comeback, the vengeance, definitely. So, okay, definitely, guys. This sounds good. I like these ideas. I like these ideas. These make sense. So I'm definitely going to promote this. Now, everyone who's in the camp, I don't know how I'm going to do this definitely because I'm thinking to myself, I do need to sleep, right? Because once I do crash, I'm going to crash pretty hard. And I'm going to crash pretty hard. And if I go to sleep, for example, my problem is that I have to wake up and then I'll be giving class right away. This is what will happen. So I will have to probably take, let's say, but then again, I don't know what you guys are doing on Saturday. So I don't want to step into anybody's day. So in order for it to work properly, everyone in the camp will have to agree. But we could postpone one day for tomorrow, let's say, and then we can continue on, like we can replenish this day on Saturday. That way we'll do.
Yeah, the thing is, we can postpone, but the thing is, it's like we will break the rhythm. Like I really like the rhythm with which we are moving right now, but you can ask the others on the camp as
Okay,
well.
no. Also, what we can do, so we have different options. That's one thing. That's one idea. We can definitely, like, let's say, postpone a whole day, or I don't mind giving class tomorrow as well. Going into the camp, doing a nice little 4 or 5 hour class, definitely. Especially when we're talking about endocrine, because we did go through so much. I did want to go through the features of acromegaly. That was a huge thing I wanted to do today, and I didn't get a chance. So we were able to do it in this session. Also, the whole idea of aldosterone, all that got flattened out. We were able to talk about it. That was major. So we were able to do that. After 12:30 on Saturday will be okay. Okay, that sounds good, Marina. I'm thinking what Amna said actually makes sense. We want to keep a rhythm. We do want to keep a rhythm. We want to
Yeah.
activate a rhythm. So what we could actually do is
Or
that,
we can start late if you want, or
yes,
if it's
that's the
okay with
second option.
everyone.
Second option, I
Yeah,
was thinking we can probably start later. I don't know if everyone
yeah,
is up
it's
for
much
that though.
better. Yeah,
I don't know if everybody is up for that. But if you can, that would be amazing. That would actually benefit me because then I'll be able to sleep, because now I'm getting kind of sleepy. Now I'm starting to crash. I can feel it.
yeah,
So
your coffee is wearing off now.
yeah, yeah, I could kind of feel it. So I would have to go to sleep, get about 8 hours, let's say, do some errands, and I'll definitely be available, but later time. So instead of 1 o'clock, I was thinking we meet up at, we can do either 6 o'clock or we can do 4 o'clock. What works here for everybody there in that sense?
Yeah, 4 works for me too.
4 o'clock is better. That's
Yeah.
awesome. I can do 4 o'clock. That is perfect for me as well. I would just have to let Francis know. Francis is asleep. I know he wakes up super early. He's like a military kind of guy, so he wakes up really early. So this was kind of late for him. So definitely, I would have to notify him and let him know. 4 p.m. sounds great. Miriam, how do you feel? We don't know about Miriam's life. We're just basically messing with the schedule here. But let's see. How does Miriam feel? I mean, if she's probably sleeping at this time, she probably fell asleep. But yes, by all means, yeah, struggling, definitely. Oh yeah, okay. Oh yeah. Sorry, yeah, I'm here. I think Marianne is also in the camp, so I'm here thinking, oh yeah, because Marianne, I got used to you. I'm not gonna lie, I got 100% used to you. I'm here like, oh yeah, Marianne's in the camp. For me, you're still in the camp. In my mind, you're still forming part. You're still in this current camp that I'm doing with endocrine. So I'm like, yeah, how about Miriam? We're here prodding into her. Like, yeah, don't worry about it. Don't worry about it. It's all good. So tomorrow, yes, okay, 4 o'clock sounds perfect. I just have to let Francis know. I have to let Francis know. If you guys are actually, no, you guys won't be awake, but I'll send him a message and I'll see how he feels. If he confirms, I'll let it be known in the chat, and then we'll start off definitely tomorrow, 4 p.m. This is the craziest session I've ever done in my life. I've never done a session this long. I do admit I have done some crazy stuff. I'll tell you something crazy that I did. One time, I had a whole bunch of study partners, and I lined them up. I made a whole bunch of study partners, and I lined them up. So it was about 6 different people, and I was doing drills. And I started doing drills with 6 different people, one after the other. And for them, it was just an hour and a half, let's say. But when I looked at the time, I ended up doing about 12 hours of just straight up drills and having like little windows of 10 minutes, 20 minutes between sessions. And I was able to run all this, and I had everything prepared for I knew all this information in my head. It was very clear. That's the craziest that I have done, I would have to say. For this, I didn't complete the 12 hours. Here I did 11. I tried to break the record, but it's not going to work. It's not going to work, but oh yeah, if you include camp hours, you're all right. You're all right. You're all right. Yeah, you're right, actually. So, so let's say I started 1 p.m. I worked till 5. Then we started 6:15. And now we're ending 5:16. So you calculate the hours. But I woke up like at 11. I woke up like at 11:30 around there. So yeah, you're right. I was totally forgetting the camp as well. But yes, definitely. So I'm telling you guys, you gotta keep consistent. I want everyone to take this MBME at the end of the camp. Definitely go and take your MBME and see how much you are scoring. We're going to continue. We're going to keep pushing, and I'm going to do more of these marathon type of sessions. I know everybody's going to go crazy on the Patreon when they see how long this video was. Definitely. And yeah, this was available for everyone. This is kind of crazy in this sense. But yeah, awesome. Definitely. We're going to post this. I don't know if I should just post this on Patreon, on YouTube. Let's see what happens. Definitely. Thank you everyone for joining me tonight. Thank you everyone for everything. This was a great session. This was insane. I've never done a session like this in my life. So definitely this is a new experience for me. I do feel now like I'm crashing. So I will drink a whole bunch of water. I would shower, and then I'll see if I go to sleep. So thank you everyone for joining me. And definitely this is intense. This is insane. This is how people should be studying before your exam, just to get the idea of knowing everything. But yeah, thank you for joining me, and I'll catch you guys next time. So see you next time. And if you're not part of the Patreon, consider joining. Yeah, definitely. This was awesome. I definitely enjoyed your input. Pablo, definitely. The input was great. Mona, thank you for your input as well. Sending me that image about mTOR. I was so lost. I'm like, what in the world? How is mTOR stimulated with IL-2 if IL-2 is stimulating some other type of... And then boom, JackStat stimulates mTOR. That was awesome. That really helped. And yes, thank you, Amna, answering all these type of questions. Miriam as well. Definitely. Yeah, it was super fun for me as well. Thank you. I appreciate everybody's company. And I'll catch you guys at another time. So take care. And yes, I'll probably upload this on YouTube. All right. Everybody, have a good day and see you.